night. Lord, you have enabled us to meet this day. We don't take it for granted. We thank you, Lord, that each and everyone is here for these sessions for today. This being our third day, Lord, we give you glory. And King of Glory, we ask you that you may take charge. May you lead us in each and everything that is going to take place today. May you guide our facilitators, O Jehovah Lord. May you help us, O Jehovah Father, that we may come out of this place with something that we'll be able to implement even in our counties. We thank you and glorify your name for this summit, and we trust upon you for each and everything. For it is in Jesus' name we pray and believe. Amen. In the name of the Father, the Son, and the Holy Spirit. Amen.
Yeah, we can take our seats and straight away go to the first set of presentation. That will be an opener to the day. Today we are going to have CFAID highlighting the work that they do. I want to request and introduce Dr. Lazarus Momanyi, who is a technical advisor for HIV care and treatment at NASCOP. Dr. Momanyi has experience that spans over 15 years designing and implementing different programs, especially care and treatment policy and guidelines. So, ladies and gentlemen, would you put your hands together as we welcome Dr. Lazarus Momanyi to start us off?
All right, so this is the opening presentation, and we wanted to speak to you about the point of care platforms that we have in the country and how we are trying to utilize them to scale up viral load and EID testing. I don't work for CFAID, so my colleague from CFAID will be coming to speak about the platforms that they have and some of the capabilities and how these platforms can actually help us to integrate some of the services that we provide beyond HIV. So I'll speak about a little bit of background. I'll also speak about the policy and guidance for viral load and EID testing and how we are using the point of care platforms now to scale up viral load testing. And end up with some of the takeaways, and then my colleague from CFAID will speak about the platforms that they have in country. So I think you have all seen this slide. I'll not speak so much about it, but it basically goes to say that our burden in Kenya, we still have 1.3 million people who are estimated to be living with HIV, with around 62,000 being children. And in terms of new infections, you can also see how we are doing. Of course, one of the striking things, of course, you can see that our MTCT rate is still at 9.0%, which is still concerning. And this is, remember that our goal is to bring it to 5%. And you can also see the other thing, of course, is the geographical distribution of the burden, that there are some counties that are what we call high burden, some of the counties mid, and some of the counties what we call low burden. So in terms of trends of number of patients that we have on treatment, you can actually see that we have relatively over the years maintained the numbers. Currently, we are speaking about having 1.3 million people, 1.34 million people currently accessing ART in Kenya. So these guidelines were launched yesterday. They're called, so those of you, I'm sure you have not gotten a chance to hold them and feel them. They're called the Integrated Guidelines for Prevention and Treatment of HIV, STI, and viral hepatitis in Kenya. So you can actually see now that one of the things that we tried to do was to integrate, because we had separate guidance for key populations, we had separate guidance for viral hepatitis, separate guidance for STIs, and now we have brought everything together so that the healthcare worker has all the information in one accessible guidance. So the other thing that, of course, these guidelines do, that they do recommend, of course, viral load still remains the gold standard for monitoring people on treatment, and they also do recommend use of point of care technologies, especially amongst populations like children, pregnant and breastfeeding women, and of course for early infant diagnosis. So the guidelines also do give, of course, a guidance on when should you do a viral load for the various populations. And as you can see, for children, pregnant breastfeeding women, we are doing frequent viral load after every 6 months. And the other populations for adults we are doing annually. And you can also see that now in the new guidelines have also introduced a baseline viral load for surveillance for pregnant and breastfeeding women who are newly diagnosed. The guidelines also recommend, of course, provide the guidance on how do you interpret once you've done a viral load, and our viral load suppression cutoff still remains 200 copies, but the treatment goal remains 50 copies. We have not changed much the early infant diagnosis guidance in our guideline in terms of when it should be done. It still remains at the 6 weeks or first contact, then at 6 months, at 12 months, and then at 18 months, which are an antibody test. But you can now see that you have actually, the guidelines now really emphasize on point of care. And we hope that with increased access to point of care, we can then now finally actualize what you've been calling BAT testing, whereby you can be able to test an infant at the point at which they are tested, which you have not been able to do much because of the platform that we had that were limited in terms of coverage. So there is clear, research, population research has been done before, has shown that when you do use point of care, you're able to improve early diagnosis, especially amongst infants, and also linkage to treatment, which of course also means better outcomes for children when they're started early on treatment. We also know that it's also using point of care actually improves adherence to the platforms, or to the algorithm that I've just talked about, and therefore these are some of the advantages of using point of care platforms. So what do we know about the point of care platforms that we have in Kenya? So our viral load and EID testing capacity is quite elaborate, and currently in Kenya we are talking about 9 conventional EID testing sites or laboratories. We have a total of 12 conventional, but I'm not wrong, I think now there should be 13 viral load conventional testing platforms. But now the most interesting thing that we also have all these gene experts that you can see that have been over the years, the capacity has been built by the TB program. And these gene experts, as you see from my colleague, they actually have the capacity to just test beyond HIV. They're able to do a number of other diagnostic tests that we can leverage on. So we've been actually discussing and seeing how can we be able to utilize this capacity, the gene expert capacity that has been built by the TB program, to be able to ramp up and increase capacity for viral load testing. So the point of care journey for Kenya has not started now. It's actually started in 2015, which was first introduced by UNITAID with the support through ECPAF, where some platforms were placed in some counties. And then over the years, through support from UNICEF, through CHAI, they've been scale up of these platforms to go beyond the ASAL counties, and a number of counties actually now have these platforms. But I was also said, on the other side, we know that the TB program over the years has already scaled up gene expert presence in the country. And then in 2025 now, with further discussions, we had, one of the challenges was that the support of the platforms that were initially placed, there were no cartridges, there was no funding that was being provided beyond what was provided by the program, the project. So now in 2025, you can see with further discussions, we were able to get support from the Global Fund to be able to support the existing gene experts with cartridges to be able to start doing viral load testing. And this is being expanded gradually as we move on based on need. So one of the key things, of course, we have had to do is to train healthcare workers to be able to use these platforms because we know that it's new technology, not really new, but it keeps on changing. So we really have to keep on updating our healthcare workers and laboratory staff on how to be able to use these platforms, how to use it for the various tests, and how to also ensure that the results are provided to the healthcare workers for decision making. So just to show that in the last 1 year alone, we were able to do a total of 1 million viral load tests. But you can see that the contribution of point of care is still low. We're still talking about less than 1%. So we think that with now the capacity and continued looking at the need and assessing where point of care can be able to be used to scale up viral load, then we can actually over time to be able to scale this up, because we know that it actually improves turnaround time, access to results, as well as, of course, decision making for clinical decision making. We currently have, I've submitted last year 34 gene expert or point of care platforms that are being used for viral load and EID testing. So one of the key things, of course, you have to do is to ensure that we have the commodities to ensure that these platforms are working, which is basically the cartridges and any other accessories that are needed to be able to make these platforms work. And in the last, this current quantification year, the last year it was a split of 5% to 95%. This year it has been increased to 10% point of care and 90% conventional. And as I've said, over time, we're still going to assess to see the need to increase this as we move on. So basically, the key takeaways is that we know that these platforms actually exist. We know that the TB program has this capacity across the counties, and we also do know that these platforms can actually be used to do what we call multi-disease testing, and we can be able to leverage on this platform to be able to increase or optimize viral load and EID testing. But there's further need to also, of course, do more operational research to understand where they can be better used to increase uptake. But of course, you also do need to continue doing continuous healthcare worker sensitization. So at this point, I'll welcome Job to come and speak about the CFAID platforms. Karibu, Job. We can clap for him.
Thank you, Dr. Mumanyi. One thing that he didn't say, which he always says, is that he went to the same school with him. That famous school in the bush near Kikuyu. We can move it. Please move back to the presentation. Yes, so that I can take it from where Dr. Mumanyi left it. Yes, so my name is Job Ndege, as has been alluded by Dr. Mumanyi. I'm the Regional Director for East and Central Africa for CFAID. CFAID is the manufacturer of the Gene Expert, the equipment that most of you have in your facilities. There are about 257 Gene Experts belonging to the MOH in the various sub-counties, and another almost 75 for research institutions and other affiliated support programs. So we're talking about integration here. And one of the things that is required for integration is basically laboratory and diagnostic integration. So the Gene Expert has a very wide menu. Looking at that, and Dr. Mumanyi talked about the guidelines that has been issued, HIV, viral hepatitis, STIs. Look at that coverage. We are talking of at least 34 CE-IVD marked tests. The same platform that you are running the TB at the moment, the same platform that about 35 of your sites are running HIV, can run from TB, HIV, viral hepatitis, STI, CTNG, cancer, you name it, everything. And you don't need anything else to be done other than your lab user being able to run that test, and the program or the facility be able to have the cartridges to do that. So we are saying the breadth of the Gene Expert menu will enable integration by allowing you access to a very wide menu of tests, including those that have been declared as a public burden, as has been seen by the recent guidelines. We also cannot integrate if we cannot reach all the tiers of the healthcare system. Kenya is tired. East Africa, I can see Dr. Cordelia from Uganda. They're also tired. All the other countries that I look after, be it Zimbabwe, be it any other country, they are tired. Now, the Gene Expert, as it is, and this is a WHO operations handbook document that I picked from there, you can see whether you are the primary healthcare level, or you are the secondary level, or you are the tertiary level. That Gene Expert that you have will still be able to support you in your diagnostics needs, the same result, the same quality, and even if you're actually putting it on a mobile lab, a mobile van, the same machine. So looking at the primary healthcare or looking at some sites where you're going to do surveillance, you are home and dry with the Gene Expert. Same quality, same turnaround time, and access. So what are we saying? We're saying that with what the ministry has already invested in, it's one platform, it's one cartridge, and it is more than 30 tests, fast and accurate results. So we are saying that the partnership that SafeAid, using the Gene Expert solution, has had with the Ministry of Health and the other supporting partners will also be able to enable the ministry and the country do integration as it is required in these current scenarios where sustainability and clinical outcomes is a key requirement. Thank you so much.
Thank you very much, CFAID team, supported by Dr. Lazarus. We are happy to see great innovations that have come in because of science, and that really shows that there is a lot more yet to come. I want to request Casco for Kisumu County to appreciate these two gentlemen. Eunice Kinyua, please.
Thank you very much. We are going to do the Karabanda, and today I think it's going to be organized. So can we all be upstanding? I will do a demo. So the Karabanda goes Karabanda, Karabanda, Senorita. Good, you're great students. So we go Karabanda, Karabanda, Senorita.
Wonderful. Thanks, Eunice, and thanks the presenters. You can take your seats. I want us to run through a short video that is going to give us a summary of what we did yesterday. This is going to help us in case one or two things skipped your mind. This will be a great reminder for yesterday's events. The IT team, please.
It's a profound honor for me to join you at the Health Integration Summit 2026 here in Mombasa. This forum brings together a very formidable coalition
You can put in
from
some
both
volume,
government and county leadership
yeah?
to civil society and
Okay.
to our
There is a
regional.
question? Okay. Please go ahead, come over. You can pass the mic to him as the IT team is putting that video summary.
All right, stand at the podium. Okay. Hello? Am I audible? Okay, I have a question for the POC, I mean, the gene expert team. Some of these POCs have been installed by partners, especially in our setup, it has been installed by Chai around some 5-6 years ago. But again, stopped functioning. We lost the cartridges after the expiry of, I mean, that project has ended. And it took a while for interventions to come, either from UNICEF or NASCOP. So in that situation, what could be the appropriate thing? Because we are one of the counties that are quite benefiting from gene expert POCs, especially the ASAL counties, which are very vast. The other thing is that we have 34 POCs in Kenya, as mentioned by Laz, and they only contributed to less than 1% of the 1 million viral load that were done. So in that essence, are we still really getting value for the POCs? Or what could be the problem? Out of the 1 million viral load tests that were done, 34 gene expert machines contributed to only 1%. If I got it right. My questions are many. On the aspect of POCs, functionalizing the POCs, and do we still need to refer samples to Cambry, to Walter Reed? If you can operationalize and maybe functionalize the POCs and make sure that every county has got several gene expert machines, because the TB program is doing great work. It has been taking gene expert to many counties, like in our eastern counties. For Wajir, we have 5 gene expert machines, of which one of them is 10 color molecule, 10 color gene expert machine. But it has not been programmed to do EID or viral load. So still the aspect of integration is quite far. I was still referring samples. So was it not necessary that the gene expert be programmed to perform all the tests, without necessarily doing TB alone, viral load alone, or EID alone? Third, the fourth or the fifth question, on the installation of the gene expert machines, are we having an MOU with the counties in terms of regular maintenance and supply of gene expert, the cartridges? Thank you.
Yeah, Dr. Lazarus, before your team responds, I just wanted to know whether there is another burning question, so that as you respond, you can put them together and respond at a go. Any other questions, so that we pass the mic to you? Okay, right there on my extreme right.
Mine, I think you can keep it for the SHA team unless there's someone to respond to it. It's an eye opener that the gene expert machines we are not optimally utilizing them. I'm looking at the potential and how we can exploit that potential. But for sustainability, then financing comes in. And why my question is directed to SHA is on the Emergency Critical and Chronic Illnesses Fund. I doubt whether that fund is operational, and if it is operational, just taking care of a bit of oncology. Our patients are attending to specialist clinics, and I'm looking at where we are doing a viral load that at the end of the day is going to be under the specialist outpatient clinics. They are not right now covered under SHA. So if we have no way of recovering that cost, then it means that even for the counties to scale up the testing and gene expert machine is going to be problematic without support. And this support from donors, as we saw yesterday, is dwindling, and the best choice we have now as a country is SHA.
Okay, so we will close the questions there, and I want to request Dr. Lazarus and the team to respond.
Yeah. Yes, so thank you, Abu. So you are right. And actually, what you said is what I highlighted in the presentation, that part of the challenge was that after the initial project that introduced the POCs ended, the continuity for support of the cartridges wasn't there. But the good news is what, again, I said that now from last year, we've been able to transition that support to go through Global Fund, and we have now increased from 5% to 10% with the opportunity to increase in the future, given that these platforms are actually existent. And number two, I'm also informed that I think there's a procurement of more than 44,000 tests for cartridges. That will actually increase the capacity for those point of care to test. And for regions like ASAL, where of course we know that it's hard to reach long distance within the facilities, then the point of care has actually become very critical to ensure access. So I think some of the issues that you mentioned, operational issues like MOU, I think those ones can be discussed. I don't have the answers, but they can be discussed and see what is currently existent. So I'll just allow probably my colleague to say something, and then we can end it up.
Thank you, Lazarus. As regards the availability of those systems, SafeAid and the ministry has an SLA, so your systems are always on service, and we are available to ensure that they're up. As regards reagents, that one is something that you can work with the ministry themselves and the program to be able to do that. However, I would like to add that for counties that have referral hospitals that are self-enabling, nothing stops you from actually seeking any of these assays or reagents as a self-sustaining service that you can do the community as a county. So other than depending on the ministry and the program, if you have care and you have self-sustaining operations, yes, SafeAid can still allow you to get these cartridges directly as a facility or as a county. Thank you.
Yeah, thank you so much. A round of applause to the SafeAid team, please. Yeah, the IT team, if you're ready, then we'd be happy to look at the summary of yesterday's events.
It's a profound honor for me to join you at the Health Integration Summit 2026 here in Mombasa. This forum brings together a very formidable coalition from both government and county leadership to civil society and to our regional neighbors. And we are all united by a very singular vision: health without barriers for a holistic HIV response.
In your cabinet secretary, we have about 700 delegates drawn from various organizations, from the Ministry of Health, implementing partners, our manufacturers, our suppliers, who have sponsored this workshop.
Should not be obsessed with following a virus and saying you are tested, you are virtually suppressed, and give you medicines for 1 year or 6 months in the multi-month dispensing, but fail to check your underlying conditions. And that is, for me, the compelling reason why we need to gather here.
Diagnostics play a central role in enabling this integration. They are the entry point to effective care, allowing diseases to be detected early, which is very important, and to guide treatment appropriately, and patient outcomes to be monitored over time.
It's important that we get the political direction and blessing, and after that we'll think about how we will let integration work for the system and work for the people of Kenya.
We move forward, we need to have patience, but focus on the patients. So patience with a C, focusing on patients with a T, because I think that's really going to be critical for us to understand how to ensure that the services are really truly client delivered, whether it's today, tomorrow, or 5 years from now.
It's not an easy journey, but I think we are at an opportune time with all the reforms that the ministry and the government, starting with the Social Health Authority, the Primary Healthcare Network, the CHPs, and the change of funding modality from implementing partners to G2G. All these are opportunities that can really help us leapfrog and realize that vision.
In this new reality, integration is not a project. It's a pathway to UHC. It is the way to protect continuity of care even as these shifts happen. As NSDCC, our mandate for multi-sectoral national coordination becomes even more critical because integration succeeds when all systems move in the same direction.
Our highest cause of death in our health facilities today as it stands is because of non-communicable diseases. And maybe, just maybe, we also might need to be able to concentrate on the level of prevention.
We are focusing on the resilience of our supply chains, and we are encouraging our local manufacturing of ARVs and other essential health commodities are of a strategic priority. And this will enhance our health security and reduce our reliance on external procurement. So this summit is a platform for a candid dialogue and practical solutions. And I want to encourage all the participants to focus on very actionable recommendations that will inform policy and guide investment into our primary health care networks. It's now my distinguished pleasure to declare the Health Integration Summit 2026 officially open.
Great exciting moments. Can we give a round of applause to the comms team? Thank you very much for putting that together. It's a memory that we can't lose, so thank you a lot. I want to take this opportunity to introduce one of our moderators today. Please have the bio projected right here. I want to introduce Dr. Evelyn Ngugi. So the next panel discussion will be moderated by Dr. Evelyn Ngugi, who is a medical doctor and accomplished senior public health leader with over 18 experience advancing large-scale health systems transformation in Kenya and across the global health landscape. She's currently working as a consultant in strategy, health system strengthening, and digital health, where she focuses on leveraging innovative technology to improve health system performance, strengthen service delivery, and drive measurable public health impact. Please help me welcome Dr. Evelyn Ngugi, who is going to moderate the next session. Can we do it much better? Until she arrives. Thank you.
Okay, good morning, everyone. Yeah, so yesterday we had a really beautiful day. As we continue to look at the building blocks of the health systems, we did look at leadership and governance and also health financing. But this morning, we are going to have the most critical bit where we literally discuss service delivery. And that's where the rubber meets the road as we discuss what it really means to have integrated service delivery. So as we go through this session today, I want to remind all of us that integration is not just a program strategy, it's a commitment to treating the whole person, that is patient-centered care. HIV care no longer exists in isolation. People living with HIV face complex intersecting health needs, including TB, mental health, sexual and reproductive health, NCDs, and more fragmented services remain a critical barrier. So this morning I want to invite all of us to really describe what that means. And when we really get to the client or the patient at the site level, what are we defining as integrated service delivery? So allow me to invite our speaker first. We were supposed to have the DG, but very, very well represented by none other than our head of NASCOP, who has really supported us and offered the leadership we need in sustainability. And he's going to be speaking to us on integration, and then we'll have a panel discussion. Please join me in inviting none other than Dr. Andrew Munwa to take us through that.
Good morning. All protocols observed. I stand here in the shoes of the Director General for Health. Maybe I need to put in a few inches height to fit his shoes. He's obviously taller and probably, I'll not say. So the Director General for Health, Dr. Patrick Amoth, will be joining us later in the day. He was supposed to be with us today, this morning, but he ably asked me to step into his shoes. If I don't fit, you will pass the review to him when he comes later in the day. We are talking about the service delivery integration. I think the reason why health systems exist is to deliver services. Health is a service industry, and the purpose for which all the other blocks exist is to support that component. And therefore, it's very, very central in delivery of health. When clients come to our health facilities, they do not come or experience diseases in silos. But the fact is, structurally, our health system is siloed and organized into RAMCA, into HIV, into TB, malaria, and rarely is there an interface for all these programs. I think historically, there is a justification for the silo approach to diseases. I think those of us who come from once malaria endemic area, I come from Mokambani, and when I was growing up, malaria was a real issue. It's no longer is today. It's now seasonal endemic. And those who worked in those areas, I know those who work in Busia and the western part of the country still experience the same today. Mkamba akikuwa mgonjwa alikuwa anasema kona ndetema. Because of the nature or the prevalence of the disease those days, that every illness would pass for malaria. And that was the reality those days. I think every healthcare worker, and Dr. Gakombe, you are one of them, who would tell me when you experienced, you are doing community health or something, you used to tell me that story, in Mwala, if I'm not wrong. And everyone will come and tell you, they have already diagnosed themselves with malaria. before they begin. And that therefore, the vertical approach to programming was as a result of the health system trying to respond to epidemics that were of significant levels to the communities. So HIV/AIDS pandemic, when I was in medical school, up to 80% of bed occupancy in health facilities were as a result of HIV. And the health system, to respond to that, designed what we call the national, from I think 1987, it was called the National AIDS, was it committees, which transformed to NASCOPs and later to National AIDS Commissions, the NACs and NSDCCs of today. So I think the justification was the verticalization of the health response was, I think, a reactive approach to address a pressing health issue, and that therefore means there was an historical justification for that. At the time, resources were made available to support such programs. The reality is, and Dr. Mwai, I had an opportunity to attend a lecture by Dr. Mwai on Friday rather, and he gave an analogy of when he was in training, he was in college, and every time he used to visit a relative, they would give him 1,000 shillings, 2,000 shillings for pocket money. When you are a student, you are poor, no one expects you to have anything. And he told us every time he visits a relative, today, they expect him to give them something. In the same way, our health systems, our economies have grown over the time, and that therefore means there is a shift in terms of what donors and partners can do, continue to do, and the government has to take more responsibility. Governments must take more responsibility in response to its people's health, because of course as a country we have grown, and part of the cost of growth is for us to we cannot possibly afford the levels of financing that, and Dr. Githinji yesterday, Dr. Mwai also brought out that we will not have the resources that we used to have 10, 20 years ago. And that therefore means it's for us to ask ourselves, how do we make the resources that are available deliver the most important services that are required in the country? Now that I'm representing the DG, I'll do more of reading than speaking from my mind. Otherwise, I will end up giving my own presentation. And I don't like reading, by the way. So that therefore means the conversation on integrated service delivery has become very central to the future health systems globally. And this is the reason, this is why this session on delivering care without silos is so important. The WHO Health Systems Framework has service delivery at the center because it's the point where all other building blocks converge, and these I had already mentioned, to produce tangible health outcomes. Leadership and governance shapes health policies, financing allocates resources, human resources deliver care, and medicine and technologies enable treatment, and health information systems generate evidence that guide improvement. But it is within the service delivery interface between providers and communities that health systems ultimately succeed or fail. Integrated service delivery, therefore, represents more than program coordination. It represents a shift toward truly people-centered health systems. It requires that services be organized around the needs of individuals and communities across the life course, rather than around diseases and programs. A woman attending antenatal care may be also living with HIV, and a middle-aged man receiving HIV treatment may be developing hypertension or diabetes. And a young person seeking sexual and reproductive health services may be experiencing mental health challenges. And for the individual seeking care, these conditions coexist within one life. And yet too often, the services meant to address this remain fragmented across programs, departments, and funding streams. Kenya has taken important steps in building policy and strategic foundation that enables transition towards integrated people-centered care. In the recent years, the ministry has strengthened the primary health care as the backbone of universal health coverage, recognizing that primary health care as the most effective platform through which integrated health services can be delivered equitably and sustainably. The Kenya Primary Healthcare Strategic Framework has positioned PHC as the entry for coordinated service delivery across the health system, and the Community Health Policy 2020-2030 has strengthened the role of community health systems in delivering integrated prevention, health promotion, and referral services. The Kenya Digital Health Strategy is enabling more interoperational health information systems capable of supporting continuity of care across multiple systems and levels of care. And this will be discussed further in the session on digital health, which we want to have an interface of interoperability between both the public and the private sector. Equally important has been the alignment of national strategies across HIV, TB, RAMCA, and communicable diseases to encourage integration within the service delivery platforms. And yesterday, when the Cabinet Secretary was here, we witnessed another important milestone in the journey towards integration with the launch of the 2026 Kenya Integrated Guidelines for HIV treatment, HIV prevention, treatment and care for HIV, sexually transmitted infections, and viral hepatitis as one guideline. These guidelines represent a significant step forward in translating the concept of integration into practical clinical guidance. They recognize the overlapping epidemiology of HIV, STIs, and hepatitis, tuberculosis, and increasingly non-communicable diseases. They promote person-centered service delivery models, differentiated service delivery approaches, integration of mental health and psychosocial support, and stronger linkages between community and facility-based care. By aligning clinical guidance across these conditions, the guidelines reduce fragmentation, simplify service delivery pathways, and help providers deliver comprehensive care within a single patient encounter. The need for integrated service delivery is not theoretical. It is driven by the changing epidemiological realities of our population. With more than 1.3 million people living with HIV, and the country with remarkable progress towards epidemic control, non-communicable diseases are rising rapidly, and mental health conditions increasingly recognized, and millions of women require reproductive, maternal, newborn, child, and adolescent health services throughout their lives. These health needs are not occurring in isolation, and they intersect and overlap within individuals, households, and communities. The growing population of people aging with HIV illustrates this shift clearly. Many individuals who are successfully receiving antiretroviral therapy are also experiencing hypertension, diabetes, cancers, and mental health challenges, requiring coordinated chronic care that extends beyond HIV services alone. This reality demands that our systems move from disease-specific service delivery models towards a more integrated chronic care platforms embedded within the primary healthcare. For integration to succeed, it will require deliberate system design and investment. First, by enabling policies and clinical guidelines must support, policies and clinical guidelines must support integrated care, ensuring frontline workers have clear operational direction. I think we have mentioned in the past, it is only in the HIV space where consultants refer to clinical officers. Because in the HIV space, a consultant or physician seeing a patient in the inpatient and the diagnosis is made, this is HIV positive client, they write in their ward rounds, refer to CCC. This is a physician and has referred that client to a CCC, which is run by a clinical officer. And we have not seen any problem with that in the past. That has worked for the past. And it's time now we ensure that every healthcare worker, every service delivery area is competent enough to deliver integrated services, including HIV. Health facilities must make optimal use of existing infrastructure. Integration may involve co-location of services, shared consultation rooms, integrated chronic care clinics, or organized patient flow within outpatient departments depending on facility capacity. And thirdly, human resource capacity must evolve to support multidisciplinary care. These I've already mentioned. Healthcare workers require cross-training, support supervision, and team-based approaches that allow them to address multiple conditions during a single client encounter. And fourthly, health information systems must be capable of capturing integrated service delivery, and interoperable digital systems are essential for tracking patients longitudinally across services and improving continuity of care. It is important that integration, equally important is the integration of health data systems. I think as Kenya moves steadily toward digitization of health records and reporting systems, it is critical that data recording, reporting, and analytics reflect the integrated nature of services being delivered. Data systems must, beyond program-specific reporting, reporting toward integrating patient-level information that captures the full spectrum of care received. When data truly speaks to the services provided, it enables better clinical decision-making, more efficient resource allocation, stronger accountability, and more responsive health system planning. One of the strengths of Kenya's health system is that many of the foundational elements required for integration already exists, particularly within the HIV ecosystem. Over the years, HIV programs have developed very strong community engagement mechanisms, differentiated service delivery models, robust monitoring and evaluation systems, and reliable supply chain structures. These programmatic strengths provide valuable platform upon which broader integrated service delivery can be built. Integration, therefore, does not mean dismantling successful programs, but rather it involves leveraging on their strength to support comprehensive person-centered care across multiple health conditions. True integration must also extend beyond the health facilities into strong community health systems. The Kenya's community health strategy has demonstrated the value of community health promoters in developing integrated health promotion, early detection, referral, and follow-up services. The community platforms are critical for identifying individuals with suspected health conditions, linking them to appropriate services and supporting adherence and retention in care, and also ensuring continuity of care between households and facilities. In many ways, community health systems represent the front line of integrated service delivery. As we strengthen diagnosis and treatment services, we must also remember that health systems cannot treat their way out of every health challenge. Integrated primary health care platforms provide a powerful opportunity to strengthen prevention and health promotion, addressing shared risk factors across HIV, non-communicable diseases, and health conditions. Investing in prevention is not only a public health necessity, but also a strategic investment in the sustainability of health systems. Perhaps the most important point to remember is that integration is not an event. It is a process. Brian talked about the two patients, one with a T and one with a C. It requires continuous learning, adaptation, and a collaboration across sectors, programs, and communities. It will require listening to providers, policymakers, and most importantly, the people who rely on the health system. As we move into the panel discussion, I invite us to reflect on several key questions. What are the real facilitators and barriers to integrated service delivery at community, primary care, and faro levels? What system investments are most critical to sustain integration? And how do we ensure integration improves and not compromises the quality of care for the people we serve? Ultimately, the success of integrated service delivery will not be measured by the number of policies written or programs aligned, but by whether individuals experience simpler, more responsive, and more effective care when they walk into our health facilities or interact with our community health systems. That is the promise and the responsibility of delivering care without silos. For and on behalf of Dr. Patrick Amoth, the Director General for Health. Thank you.
Asante sana Daktari. Join me in appreciating Dr. Mulwa. Thank you very much for reminding us that the systems that we build must serve the patient. And I think the other thing that matters for me, and I always discuss this with my colleagues at the ministry, is that we also do a lot of boardroom. We do the policies, we do the system building. And as I said, we've discussed most of these building blocks, but ultimately does that translate to what the client or the patient experiences at facility level? And really from a point of empathy, just imagine going to a clinic, and we do that all the time, or most of us have parents who are sick, and you have to go to almost 4 or 5 clinics with either different labs, you have to wait in 5 queues. And sometimes when we look at those systems and remember that we are the leaders, then we must seek to make a difference. So let's have the conversations today about what it means to have person-centered care. Let me remind all of us that a person living with HIV does not experience their health in silos. They do not compartmentalize their need for HIV treatment from their mental health struggles, their reproductive health needs, their risk of tuberculosis, or the chronic conditions that increasingly accompany a longer life on ART. They experience their health as a whole, and they deserve a health system that responds to them in kind. And so this morning we must have the fundamental promise of service delivery integration, because when we integrate our services, we do not just improve efficiency, we restore dignity, we build trust, and reaffirm our commitment to health as a fundamental human right, and that's in our constitution. So for the conversation today, I'm privileged to have a panel of speakers that are going to tell us how this really translates to patient or person-centered care at site level. And allow me to also ask whether in the room, how many people do we have from the site level in this summit? Site level, facility level, county? Yes, good. Many times when we started working on service delivery integration, I actually went to the sites just to see whether everything we discussed was theory and whether it was abstract. But one of the things I have learned is that it has to be a bottom-up approach, not the political one, but the fact that you must sit with the clients, you must sit with the nurse who works in that clinic, look at the patient flow, look at where the data systems are, look at the OPD, discuss with them how they would like that to work, and then have them co-create and work with you to see how they will provide patient-centered services. So allow me to invite my panelists. Team, please put up the bios. Okay, as they set that up, so my first panelist is Mohammed Hassan Malim. I hope he's here. Malim is a public health professional serving as the Director of Public Health and Sanitation, where he provides strategic leadership for programs addressing HIV, tuberculosis, WASH, neglected tropical diseases, nutrition, reproductive health. He oversees the management of 156 primary healthcare facilities and provides leadership and mentorship to more than 500 healthcare workers to strengthen service delivery and community health outcomes. So, karibu sana. My second panelist is Dr. Grace Rabut. I think most of you have had the privilege of interacting with her. She's provided very good leadership for this summit. Dr. Grace is the Integration and Health System Strengthening Lead at NASCOP. She provides technical leadership in advancing integrated HIV service delivery within the Kenya health system, working closely with the national county governments to development partners and community stakeholders. And I just remember when we started discussing service delivery integration for the first time, the first person we worked with was actually Grace. So karibu sana, Grace. Join me in inviting Dr. Grace Rabut. The other one is a teacher, and he has really been instrumental in this journey. And what I like about Prof is that he's very humble. He's really supported us, not only taught most of us, but has implemented large programs that we have learned from as a pioneer. So Professor Kimayo is a professor of internal medicine at the Moi University of Medicine in Eldoret. Has done a clinical pharmacology fellowship and has worked in HIV clinics and served as the chief of party for several USAID-funded programs, and while taking leadership also at AMPATH. I think most of you also know that AMPATH is one of the programs that has really supported patients in that region, but also has been a pioneer in innovations. Karibu sana, Prof, and you get a special clap. Allow me to now invite Dr. Jacqueline Kisia, a good friend. I hope she's... Oh yeah, Kisia. Karibu sana. Dr. Kisia works at the Ministry of Health within the Division of Maternal and Neonatal Child and Adolescent Health. She leads work on the adolescent sexual and reproductive health. She has extensive experience in public health. Most of you have worked with Dr. Kisia, including in TB. She has participated in technical assistance initiatives that evaluate policy strategies for malaria, TB, contributed to the development of regional and policy documents. Karibu sana, Dr. Jackie. Then this is another very special person. So we happen to probably have the same kind of epidemic around the region, but one of the things we have really benefited from is learning from each other in the countries in East Africa. And I remember when we were in the Secretariat for the summit, this time we decided it was going to be regional. And most of us have actually done what we call benchmarking. And one of the countries that has been very warm to us, but has also been a pioneer, is actually Uganda. And so allow me to invite Dr. Cordelia. I also interacted with her in many other forums where she has been the lead for the program in Uganda. She's a Ugandan pediatrician and child health specialist with the Uganda Ministry of Health STD AIDS Control Program as a project technical coordinator for the CDC-MOH Cooperative Agreement, a strategic mechanism between the US and the Uganda government. She carries with her over 20 years experience in HIV clinical care, public health policy, strategic planning, implementation of programs addressing HIV, TB care and treatment. Allow me to really appreciate her for making time to join us in Kenya, for all the time she has hosted us, and for all the times we've had the exchanges to be able to learn together and improve our programs. The next one is someone who has really worked with us closely to really tell us what the experience looks like and challenge us to make a difference as they experience the care, and has been very, very supportive to the leaders and the policymakers. Allow me to invite Nelson Otuoma. Special clap for Nelson. He's the director of the National Empowerment Network of People Living with HIV, NEFAC. He provides strategic leadership to amplify the voice and the visibility of people living with HIV and communities affected by TB and HIV. There's another very, very special panelist that I would like to invite. In Kenya, we have a devolved healthcare system. We implement our programs within the counties. And most of you know, when we started the journey for sustainability, one of the things that was really challenged is that we could not fund directly, but we really took up the responsibility and said, you know what, we want to support the counties directly. Some of them have done very, very well, and they have actually gone ahead. And let me say also, service delivery integration is not new. If you look at our maternal child health clinics, they have always been integrated. But allow me to say there were counties that were pioneers for the G2G. They have provided the leadership and gone ahead to do service delivery integration and provide the leadership that's needed. Allow me to invite Dr. Nelson Moreu from Nyeri County, the CDH. This is one of the counties that really went ahead, did the G2G. They were very, very successful, integrated services, used their HRH, and I must say the leadership in the county does matter, and we have received a lot of support from Nyeri County. Most of you remember recently that the ambassador was actually in Nyeri because of the G2G, to see how we can do that at national level, because they were very, very successful. Daktari is the county director of health in Nyeri, and I must say he has provided the much needed leadership and governance that we were talking about yesterday. So allow us now to go into the panel conversations with our panelists. Please invite them again as we explore what they have to. Okay, karibuni sana. And as we go into our questions, so our first question goes to Dr. Jacqueline Kisia. Integrating services at all levels of the health service delivery requires a system-wide approach from the national level to the community. And my question is, how can we define meaningful integration? From the RMNCH perspective, what practical steps should counties take to integrate services as vertical transmission, elimination, syphilis and hepatitis B screening and treatment within routine maternal and child health platforms without overburdening the providers? So this question goes to Dr. Jacqueline Kisia, who works in the... Yes, so Dr. Jackie.
Thank you. Thank you, Evelyn, for that
very, very important question. Looking at depression of donor funding, we all know that it's become very difficult, and most of the donors who were supporting us, especially in reproductive health, have reduced their funding. So for us in RAMCA, we have integrated our services for HIV, for looking at the policy documents. We know during ANC, you have to have at least 8 visits. So we want to make sure at the county level, during each visit, they use that opportunity to make sure the patients are tested for HIV, for hepatitis, for malaria, TB screening at the point of contact. We can use RDTs. We don't have to send the patient to the lab, because we know that when we send a patient to the lab, we lose them in the middle of waiting for the test or waiting for, or any issue which will come up. So we want to use that opportunity when you get the patient in front of you, and make sure that you're able to do those tests and able to advise the patient appropriately. We also have the guidelines, policy documents. We know that the policy documents are developed at the national level, but where are they used the most? They are for at the county level. So we want to make sure that SOPs and all guidelines are available, so that when the healthcare worker wants to give a certain service, we'll just refer and know how to integrate the HIV RAMCA services. We should also have the standardized integrated services, where development of clear guidelines and making sure that the counties are participating in this development. During the visits, we should also have the opportunity to use the LENPrep. We know LENPrep is not contraindicated during pregnancy, it's not contraindicated during breastfeeding or postnatal. So this is also a very good opportunity to make sure that we reduce the HIV cases by giving, and also being able to give that information to patients so that they can make an informative choice. Thank you.
Thank you very much, Daktari. Thank you very much, Daktari. And we did hear the young people yesterday say that we are focusing on NCDs and we are not focusing on the reproductive health and wellness. So thank you very much for those insights. And hopefully we continue to work together and not in silos to provide comprehensive services. My second question goes to Professor Kimayo. Integration without the right foundation risks creating complexity without improvements. And so we must have the fundamental prerequisites like policy, infrastructure, human resource. And so my question to you is, from your perspective, what are the key requirements for successfully integrating HIV services within the broader health systems, particularly within the primary healthcare platforms?
Thank you very much. You know, you're asking me to make a marking scheme of the integration. And I want to say that looking at it, I saw a 10-point agenda. You people know about 10-point agendas all over the place, especially the one. So this is a 10-point agenda. And It's a supermarket approach. And I just looked also at the Kenya AIDS Strategic Framework 2025 to 2030. So as Kenyans, again, we are excellent with the policies. That's not where the problem is. And then we also have looked at horizontal versus vertical and why we went vertical and why vertical may be important in something new and aggressive. And then we also need to think about acute care versus chronic care. You know, are we taking patients to OPD in chronic care, to join chronic care, or to join acute care? So again, the list have been given by Dr. Mulwa, representing the DG. Right from the building blocks, we have to fix the building blocks, from financing to medicines and products and the labs we talked about yesterday. But now, there is really something I'm not getting here. Which ones? I know, Grace, you talked about, do we do it outside or inside? Therefore, when are we going to do, at what point or which level are we going to do integration outside versus integration into the CCC? Example, in MTRH where we have 14,000 patients, should you take them to OPD? In Nakuru, where they had 7,000 patients in the CCC, should you take them to acute OPD? In Webuye, we have learned, we have taken all into the CCC. That's all the NCDs into the CCC. So what is the cutoff? Is it 500 patients in a CCC? Is it 3,000 in a CCC? Is it 5,000 in a CCC? There is a calculation there that has to be done. How many patients are ordinarily coming to the OPD? You can't just take them. We have to calculate and see how the numbers are going. How many are in the CCC? If the CCC has 10,000 and the OPD sees 5,000, you can't overwhelm the OPD, and so on. So there are calculations to be done. That's part of the marking scheme. You need to look at the physical infrastructure, engage the private sectors, the SHA. I keep saying the SHA. Mr. Mwai and Dr. Kidinji, you know, they took us through an uncomfortable part, that there are certain things SHA will do, there are things SHA will not do. But we still cry out, SHA needs to do better. And then the other things include quality of care, monitoring and evaluation. Actually, the other things will be discussed by my colleagues here, from the health workforce, right to the financing. So that is the marking scheme. But we need to really make a decision what we want to do. We have no choice, we have to integrate. That's the right thing to do. But is it to the OPD or is it to the CCC, is what I brought up. Thank you.
Thank you very much, Prof. Very critical point. It's not one size fits all, and so we must look at the models and really look at what works for where. If you look at some of the high HIV burden counties with over 3,000 patients, we may not be able to literally move those patients to the OPD. We may need to consider the chronic care model clinics. And so really, when we were told to develop a policy and guidelines, I remember having this conversation with Dr. Mulo, and he says, you know what? We are not giving anything prescriptive. There's no one size fits all. You must assess everything. And so thank you, Prof. And then look at the model that would work for patient-centered care for your clinic or your county, and then see how to integrate. Asante sana. So very, very critical question. And this goes to Dr. Hassan. The health workforce is the backbone of integration. Without skilled, motivated, and supported workers, integration remains a concept on paper. And I think we discussed HRH quite a bit. What are the key health workforce competencies? What do we need to do to make sure that at least for the health workforce, we're able to work with them on integration? And so my question to you is, from a county perspective, what human resource strategies and capacity building approaches are needed to support the effective integration of HIV services within the broader health system? And why this question is so critical for you, Hassan, is you also work in a region where probably getting health workforce, for you, you may need to pay more, and you may need to motivate them given all the challenges. And so I think this is the right question for you. Over to you.
Thank you very much. I think that's a very good question. First and foremost, we need to understand the perspective before we come to even the HR itself, because HR itself cannot work effectively without having the other basis. Wajir is one of the counties with the highest MTC rate of that 3%. I think is one of the highest in this country. And when you see what could be some of the reasons, is a result of low coverage in terms of PMCC coverage, low NC attendance, and mostly boils back again to lack of proper staffing as a result of high staff turnover. Having said that, I think we had to do soul searching and find out proper strategies of handling this. There are 4 fundamental issues that circumnavigate around the HR. One was governance. The other aspect was human resource. The third is infrastructure, and the fourth is community. All of them have an effect on the HR. Why? Simply because the community being, culturally laden and a patriarchal society, I think stigmatization becomes a very big issue. So even the staff themselves, how they're going to handle this concept of integration matters most. That's why we said first we need to think about governance. What do you mean by governance? First and foremost, instead of saying HIV program, I think we need to have a common program. We call it special program. In our setup, we call it a special program, and each one has a sub-voted where we think of TB, HIV, and the staffing in themselves now, they're programmed in a way that they are now said to be a special program. Even when they're doing the outreach program itself, they do it as a special program, inclusive of the RH, malaria, TB, all these are conjoined together so that when they go to the field, that's one thing they do. Then the other aspect is funding itself. We know, like most of the ASEAN countries, we don't have a support to undertake most of these things. So what basically happens, then we felt a strategy of soliciting funds within the county. One of the issues that we felt is very vital is that we need to maximize the share collection. After enacting the FIF Act, we have realized the FIF Act somehow may not be very clear in terms of level 2s and 3s. So then we had to develop a guideline on utilization of this. In the utilization, there are some components that we need to see effectively seen. One of the things was the outreach must be a component to it. Sample referral must be another component to it. And then we tailor-made these programs to have in a way that the few staff, skeletal staff who are on the ground can effectively manage this. Then we are able to do mentorship for this staff based on these programs they were talking about, with support from our elder brothers from national government, especially NASCOP have been very handy in this, and also UNICEF, a big colleague in this health wider issue. So, Dr. for me to talk about HR, first let me touch also the component of infrastructure, because you cannot talk about HR without also an infrastructure, because it's a strategy itself. Remember, a county which is the third largest county in terms of landmass in this country, which has over 330 outreach sites. There are no facilities, it's an outreach site. So this place also have to be managed. How do you do this? As a county, we had to operationalize close to 54 facilities for them to provide these comprehensive services so as to increase access to this. Remember, HR, without having an access to utilization of services, the community might not benefit from it. So we had to operationalize this, then employ 244 health workforce. Among these 244 health workers who we have employed, 10 of them were visiting counselors, purposely for volunteer counseling and testing, especially in areas we think that could be high-risk areas, especially the border areas, a place like Butte or Gia North. That's where we are trying to do our pilot study currently. That's one of the issues. So when we did this, then we had to do mentorship for these staffs. As a county with high staff turnover, I think frequent mentorship and capacity building is almost a must, because after every 2 or 3 years, we have to deploy a new staff and take to these facilities. So routine mentorship is being done on monthly basis, led by our CASCO and TB coordinator. That's in terms of HR. And let me say a bit to do with community, because also it plays partly with the community aspect. One of the aspects we have realized is that there is high poverty level, around 60% of poverty level. And when the poverty is high, access to services also becomes low because of the health-seeking behavior of the community. So when we do this, then what are some of the aspects that as a department we did? One was community engagement. More emphasis or more bias towards what we call the male partner involvement. So we had what we call male dialogue days, where we encourage this male so at least they can have an access to service delivery. And that was one of the issues that at least was able to help us in this scenario. Then the other work was having a strategy, what we call Know Your Neighborhood Initiative. Know Your Neighborhood Initiative basically circumnavigates around through the CHP, where these people are, for example, the client who are high index suspected cases are normally advised on how to do through the routine aspect that we normally have. I think by and large, that's how we basically do things. And we have already seen this achievement. For example, before we started this, 3 months ago, our ANC, fourth ANC coverage for the pilot study facilities was 40. Today, we are talking about 80, 85 coverage in terms of 4 ANC, and first ANC around 90 coverage. That means now the access is okay, and every client who are coming to these facilities are also being tested for HIV. I think this is how we do based on the few skeletal staffs we have. Thank you very much.
Thank you very much, highlighting very, very critical points on the need for capacity building. But I think also the other challenges we have for the health workforce is really aligning our cadres and really encouraging them on change management. We cannot possibly just manage one disease and stick to the fact that we are only trained to manage that disease. So how do we work on change management? How as leaders can we be the agents of change and champion change for our clients to for our health workforce to also look at clients holistically. But thank you very much. And of course, the other issue we need to discuss, as Dr. Moi said yesterday, is really the huge wage bills within the county, with sometimes a health workforce that's problematic and will not show up at work. Either they're on leave or they only work 2 days a week. They come to Ajia for 2 days and then they disappear for the rest of the week. And then we are busy complaining that we also need to increase our salaries. Those are the real issues we need to think about. I think the other challenge is the cadres. We must align the cadres and work within the cadres that are within the government system and see how we get to transition some of the health workforce to really serve the patient holistically. So thank you very much, Dr. Hassan, for that. So I'm moving now to the community. So speaking to trauma in the communities on person-centered integrated services. Integration must ultimately serve the individual, meeting people where they are with the services they need at the right time. And really, what does person-centered integrated care truly mean in the context of HIV service delivery? And how do we move beyond the rhetoric to genuine implementation? As I said, we are very good with boardroom. We have, yesterday we launched, was it 20 documents for one disease? And I was looking at Hassan just now and thinking that his problem is actually maternal child health. And then we are here with the HIV. So how are we looking at all this? And probably if you go to another county like Kiambu, or you go to another county, they'll tell you my problem is really NCDs, but they would still need to take care of the HIV patients. And so to Nelson Otuoma, from the community perspective, what does person-centered integrated service delivery look like in practice? And how can health systems ensure services truly respond to the needs of the people receiving the care?
Thank you. Thank you very much for the background, and also thanks to the head of NASCO for earlier sharing what the DG had. Yeah, I noted the policy documents we launched. The most interesting one is what we used to call ART guidelines. Right now it's called integrated guidelines to prevent and treat HIV, STIs, and viral hepatitis. So of course, we need to emphasize STIs and viral hepatitis because the moment, immediately after the launch, we drop the two, we focus on HIV because probably HIV has the money. But you were asking person-centered. I think we have lessons from differentiated service delivery because it starts by testing. And once you test, during testing, you can, at that level, start to differentiate between what Professor was calling acute and chronic. In Kenya, we talk about test and start. And therefore, for those who walk in where they are still very strong or healthy, and I encourage to do treatment, I think it takes very short time with dolutegravir to be established. We used to call stable. But there are challenges. So some people come late, particularly men and young people and key populations. But even those who come and are enrolled on treatment, then they interrupt that treatment. Actually, some of them end up being lost to follow-up or dropping out of care. So the person-centered care is individualized care, not always emphasizing the point that we have 1.3 million people with HIV are on treatment, but really focusing on these 1.3 million people who are, what are their care needs? And I can tell you in very quick time, you know, if you lived with HIV for long and you are on treatment and you are going to a facility, even the soldier at the gate knows you. And they also try to know even when you are supposed to come. So if they saw you last week and you are coming again this week, they just remind you, no, why are you coming back again? I thought you were coming again next. You didn't get enough medicines. Because according to them, what defines you is HIV. And you can't develop malaria, you can't develop headache. For women, you cannot want ANC services. They want you to come specifically for that HIV. So the person-centered care is based on the individual need and should be defined by the recipients of care to respond to that. Now, getting into integrated health services, I am of the opinion that care should be given to people as a right where they want it and where it is. And we have limitations, that's why we organize to go to health facilities. And yesterday I said that to keep HIV separate from the rest is to deny a person living with HIV the benefits of universal health coverage. But it is not a matter of saying if there is a CCC, then we need to close them down so that we go to the OPD. Because sometimes even that OPD probably you can ease the burden in OPD by referring people to those comprehensive care centers. So I'm quite in favor of the discussion yesterday. Yeah, I've always allowed, so even without this I can continue. But I'm of the opinion that we need to put care, and we are talking about HIV care, where it can be accessed in a dignified manner by a person who needs that care. And the person who needs that care can go to wherever that care is, only that it should not be a whole day to access that care. And therefore that brings us to the person who delivers care, the healthcare worker. And we need to also to reflect, in our country sometimes we have doctors striking, nurses striking, clinical officers striking. That is all clinicians striking. But still HIV care gets delivered because there is that lower cadre that don't belong to that category that probably go to strike. And that is why we were driving self-care. That there is expertise and experience in the recipients of care that can also be useful to the Ministry of Health. And therefore, when we talk about community engagement, we are not talking about only and solely of the CHP. But we can also broker dialogue with the government and say that we need specialized CHPs. So the people we are losing out, the mentor mothers, the peer mentors, the adherence counselors, can we be having specialized CHPs that can handle that? Because that is the only point and entry point into the facility level. So basically, for me, is allow people to seek care where they want and when they want. And don't define people by one condition or by one disease. Don't tell people that, yeah, no, pande hii hapana ya HIV, we utaenda pande hiyo ingine. And this happens even today. If you have a kidney problem and you are a person living with HIV, you'll be managed. And SHA will pay. Up to that point, the doctor will ask you, are you managing any other condition? The moment you say, I'm also managing HIV, they pick their phone, if you are in Kenyatta, and call the CCC. This person who is lost, please come and pick this person to come that other side. Is that the integration we are talking about? That's not the integration, because this person is supposed to deliver this care where they are, and it can be delivered by, but we realize that for the people we call consultants, is kind of, they deliberately, it's not that they don't have the knowledge, but they don't think that managing HIV is part of their core business. And that's part of the discussion that we have to deal with, because they think this is something that the nurses or their interns, who are also qualified doctors, can be dealing with. And then if you go to other facilities, it is for the other person to do it. The moment you mention, they're talking about integrating in the OPD, but the moment you go and whisper to a nurse or a clinician that you are there because you want HIV medicines, they look for somebody who can deal with you. They call their colleague, mtu wetu amekuja hapa. That's not what we meant by integration. So let us also resource and resensitize healthcare workers, and also appeal to their sense of conscience of saving lives and duty. Lastly, and more importantly, let us prepare the facilities where we want to integrate HIV so that they are aware. If I come to a facility to collect medicines or to collect viral load results, I don't need to come there at 8 and to be seen by 4. I'm causing a unnecessary crowd in your facility. It should be fast-tracked in such a way that if I came just to collect the viral load result, it is dispensed with very quickly so that I give space to the others. And that's why we are talking about differentiated service delivery, not being thrown and replaced by what we call integration, because then it will be chaotic. And we see differentiated service delivery as an enabler to integration. We also think that in as much as we are developing guidelines and doing all this, the HIV science is moving very fast, that tomorrow we may have a long-term treatment, because already we have a long-term prevention prophylaxis. And with the long-term treatment and also with DSD models like community pharmacy model, I think the discussion will shift very fast, because we will not be crowding those facilities. We will be going to private chemists. But the most important point is also to invest in self-care. Transfer part of the responsibility and explain it very well to the recipients of care, that there are things that they are responsible for, and there are things that you want them to also be self-reliant for, including transport, to send one of their peers to collect medicines for them, including the treatment knowledge so that they can interpret viral load, CD4 results, and know what action to take. Then that will ease the burden for the healthcare work, and the integration will flow in smoothly. Thank you very much.
Thank you. Thank you very much, Nelson. And just giving us practical examples of what you don't want to see and what it really means to have patient-centered care at at the clinic. Consultants, I hope you've heard that we can manage. We say patients don't read textbooks, so we can actually manage them holistically without having to send them around 10 times to different places. Moving to Uganda, regional experience, Uganda's journey with HIV integration offers rich lessons, both inspiring and sobering, for the broader region and beyond. And they have very, very good experiences and lessons on the integration journey. I've actually joined a lot of their webinars. And so would like to hear the successes, the setbacks, and the road ahead, just given that we probably manage we are struggling with the same problem. So to Dr. Koderia, would you share Uganda's experience in integrating HIV services within the broader health system, including key successes and challenges encountered? In your view, what are the critical components that countries should consider ensuring effective and sustainable integration on HIV services into routine healthcare?
Thank you very much, Evelyn, and good morning, everybody. I want to start my reflection on some statements. I was listening in to most of the speakers. So one time, our permanent secretary, those that have seen her, is a very, very practical person. So she went to visit facilities, and it was raining in one of the health facilities she went to, and she found some people that could not get shelter. And the HIV clinic was right at the corner. And when she asked, they told her these people cannot go there because it's specifically for people with HIV. And I'm talking about equity, how do we treat people? When we began the integration work, we began to get comments like, we cannot go to that clinic because the people now with hypertension and diabetes couldn't go to the HIV clinic. The people with HIV were also saying, we don't want them to come. And there are many other statements. Then we have the consultant story as well in Uganda. Even when they integrated, the consultants would still move to the chronic care clinic and see the patients that have hypertension and leave the ones that are living with HIV. So those are the realities around integration. I know they cut across both our countries, but I want to state that our journey in Uganda began with bold leadership. Those of you who have seen, and that circular, I think, went around all the countries. And it was a bold step taken by the PS, the Feb 7th circular, which said we must begin to see integration. And she was very clear. She said, where we have had challenges in the vertical programming, in the siloed programming, we must be able to see a change that cuts across all our levels of the health facilities, public, PNFPs, and everywhere. And at the end of the day, she wanted to see client satisfaction. She wanted to see better efficiencies in our care and improvements in quality for care. Those were the major areas she wanted to look at. And she drafted that guidance herself, which was guidance based on the health system blocks. And she wanted that circular to reach the in charge of every health facility so that they could understand it, make their interpretations, and make their context-specific implementation. So that is how our story began. Of course, being triggered by the shutdown that happened in January. So Uganda is a country with a decentralized system of governance for health, unlike Kenya, which is a devolution. And that means that our healthcare services are generally under a ministry called the Ministry of Local Government. So these are called local governments. We have districts that are in charge of the implementation, and we have about 146 of them. So they oversee our levels of care from the health center 2s, the 3s, which are really at the community level, and the 4s and the district hospitals, governed by a district health officer and a chief administrative officer. Then on the other side, we have our tertiary institutions, the regional referral hospitals, about 16 of them, the national referral hospitals, and I know those speak to some of your tiers, and the national referral hospitals that we have. So those are under the central government and the Ministry of Health. So that already shows you some of the challenges that, that you would face managing a local government and trying to institute certain changes. But nevertheless, that is how our journey started. So Prof talked about the foundation for integration. And I want to say that between Kenya and Uganda, I think we have the best foundations for integration in terms of policy, in terms of guidelines, in terms of governance. In Uganda, we have an essential health package of care. In Uganda, we have standards of care to provide care. And it does not say providing care for HIV specific, diabetes, or what. It is providing chronic care, communicable disease. It's an integrated guideline. Our standards of care are integrated. Our sector plan is an integrated. So by default and design, in Uganda, our system is already an integrated system. Now, for one reason or another, and we have tried to justify why the vertical programming had to happen, there is nowhere where it's written and they say establish a diabetes clinic, establish a clinic for hypertension. These were gaps in how we described our implementation, and it led us to where we are. So for us in Uganda, we are saying, let's just go back to the basics. Let's go back to the basics. So our foundation is clear. Now, unfortunately, to going back to the basics is we've got to go back to teaching afresh. We are teaching the doctors how to clerk a patient. We are teaching the doctors how to set up appointments. We are teaching the doctors how to do referrals. And that was because it was best done in a clinic for HIV, but for these other places, it was not known. Just recently, we had one of our webinars. Every Wednesday, we have webinars that are led by the senior executive consultants of the hospitals to tell us about their regions. And they said, we don't know how to give appointments to people with hypertension. Is it a chronic disease? Yes. Does it need appointments? Yes. But the health workers do not know how to give appointments. So those are the realities of integration. So what did we do as a country? I've talked about the leadership. And if you asked me, Evelyn, leadership is the most important aspect as we begin this integration. Right from the health center in charge, the district health officer, the consultants. And for us to achieve this, when we were beginning this integration work, we had to have stakeholder engagement. And really to put the point across, the PS herself met with different teams. She met with the hospital directors at the regional referrals. She met with the district health officers who are in charge of the implementation. She met with the community networks to communicate what the new reform was going to be and the reason why it was there. And she met with the in-charges. So that was really, how do you communicate your agenda? How do you get feedback from the stakeholders? And how do you communicate how you're now going to implement? So once that was done, we now went into a stage where we needed to make her circular practical. So we had a practical guide. And mind, I'm not talking about guidelines. We are saying, what do you have to do for integration to happen at the facility? And against this backdrop, Uganda is working, our integration process is led by what we are calling our national framework for integration, which is based on the health systems. So when we talk about the facilities, we tailored these systems to what should happen at the level of the health facility. And we developed a training. The training was unique because it was not going to talk about HIV and TB and diabetes. This training was about change, mindset change. So if you look at the modules that we had, the number one was leadership and governance for integration. And this was led by the regional referral hospital, the directors, the teams of consultants. They are the people that now came to lead this. So it was no longer who is working in the HIV clinic, rather it was the head of department. We continued with that training. It talked about chronic care. So the concepts of chronic care, the concepts of acute care. So irrespective of disease, we are saying, is it acute? Is it chronic? And most important was the community at the center. And then we had another module around quality. So 5 key things that were within that training. And I can say in terms of our early wins, we were able to reach almost 20,000 health workers in a space of 3 months, just for them to be trained. So capacity development is very key. So at the site level, what are the things that happened, Evelyn? And I want to go system by system. So we were not looking at the systems from the ministry side, we took it up to the site. And I want to give examples. So when we went to the use of the primary healthcare funds, which are operational funds, every facility usually has these. We tailored a checklist to ask practical questions of the in-charge. How are you going to utilize these funds to support the other areas that were previously not supported? So the outreaches, sample transportation, and all those basic things that were previously and as siloed, but now we are saying, can you repurpose your funds? How do you think about it in the face of integration? When we got to HR, the practical questions were, yes, you don't have wage, because that's usually the story. But the in-charge was tasked with, how do you optimize your health workforce in a practical way? Who are you shifting from here to go and work in this clinic? Who are you going to assign the leadership? How are you going to ensure that people have CMEs? So the HR became a practical issue, and that's what we're actually monitoring. When you go to the changes in the clinic space, and I think Prof talked about this, the guidance that we gave was, we are not going to have siloed clinics, but we gave liberty to the facility, pick what model works for you, and there were options. If you're at a health center 4 and above, maybe the chronic clinic would work best for you. That would mean that people with chronic illnesses go to one space. And we took advantage of the existing HIV infrastructure, which was already well developed, proper staffing, and everything was there. So that one, the facilities were able to choose. For those that had fewer patients, and Prof, you alluded to that, those are the ones that form the mix. So when you go to Uganda now, and because we have kept on doing our measurements and supervision, we now know that at least about 58% of the facilities have chosen the mixed model. About 30% have chosen the chronic model, based on context. Now, our principle here is we want to learn and adapt. Our approach to integration is learning and adaptation, because we have put within our agenda the research and evaluations, and currently one is ongoing. So it's going to tell us, if we do these 2 models, are we still getting the outcomes that we need? I will move to the information systems. What happened? I think all of us share the same gaps. We had fragmented information systems, the EMRs. We had an open EMR for HIV. We had the EAFIA, which is now the new government EMR. We have clinic masters, all of them not speaking to each other. And then the tools, oh my God. I think we saw 20 guidelines. So the tool, you can imagine now the tools just for HIV. Almost, I don't even want to mention. And then hypertension also had copied. They wanted an HIV, a tool that looks like theirs. So we had some tools. So there was all that drama. Right now, because of our adaptations and some of the learnings, we now have 1 chronic register that is being rolled out in the country. So we are learning, and I'm just giving a few examples across the systems, because I could speak around integration in Uganda forever. And so we are touching on every aspect. When we came to the community, How are we doing the referrals? How are we doing differentiated care for patients with chronic illnesses? And we have also established, because when we went to the sites, they told us now we need SOPs. We don't want SOPs for diseases. We want SOPs for chronic care. As I speak now in Uganda, these are being rolled out. And these SOPs are describing the life cycle of a patient through chronic care. When you come, how am I registered? How do I get my appointment? How do I get my referral? How am I assessed as a patient, not as a disease? You know? So all this is guidance to the primary health worker, and they are going to give us feedback on them. So we can see lots of changes that are happening. And I think for me, my point for this meeting is we have tailored the system adaptations and learnings to the primary health worker. It is practical up to the level of the facility. And I want to, because this session is for service delivery, so I'm not going to go into what's happening at the national level, but I'll probably talk about it because our heads of department, who are commissioners in Uganda, generally lead these pillars. So you have a commissioner in charge of the digital systems, you have a commissioner in charge of HR. So their duty is to ensure that all our guidance right up to the facility speaks to what we want to see at the national level. So I'm just trying to point that as a way in which we can have that. So some of the gains we have made, we have trained our health workers. We are seeing uptake for integration at about 83%. So all the facilities, and this has been rolled out in over 2,000 health facilities in the country. And it comes with challenges. I began my talk with the challenges. So we still have a mindset issue, majorly mindset. And right now we are getting the leaders of the regions and the facilities to support and give us feedback on what is happening in the country. They are the ones telling the story. Actually, tomorrow morning we have a webinar in one of the regions. They happen every week to tell the story of their regions, of their districts. The issues around HR, but I want to say the challenges for integration are a reflection of the challenges of the health system. Integration in itself poses few challenges. It's the inherent challenges of the health system, the health workforce. You don't have enough commodities, you don't have enough, the lab systems, the referral systems, the community systems. So once we clean up that using the reforms of integration, we should be able to see improvements. Thank you so much.
Okay, thank you. A lot from Uganda. And I think basically what we are saying, we need to benchmark. And we are very good at that. So we will be talking to you after this. So allow me to go to the next one, which is the practical examples from a county. And yesterday we did talk about the role of leadership and governance in service delivery integration. Integration does not happen by accident. It is driven by deliberate leadership decisions and enabled by strong governance system. And as we said, Nyeri has done very well. So Dr. Mureu, from a practical example, what is the role of leadership and governance in driving integration at the county level?
Thank you. Thank you very much. I want to say that having listened to our sister from Uganda, there are certain things that came out very strong that we're also doing at the county level. And the first thing that I want to say is that Nyeri has been fortunate. We've been implementing the G2G program for the last 5 years. And therefore, some of the things that I'm going to say here are very practical in terms of what is it that we've been doing on day-to-day basis. And the first thing I want to say is that when we started this journey, we had to get high-level commitment. Remember, what we were applying for was a transition grant. And therefore, the commitment was that after 5 years, the county was supposed to take over the HIV programming. And I want to say that right now in Nyeri, we actually don't have implementing partners. We are implementing HIV program in Nyeri. And one of the things, and I just want to reiterate on what my sister from Uganda has said, one of the things that we have learned is the issue of leadership and governance. There are certain things, I think, because of our nature as healthcare workers, we focus too much on service delivery, not realizing that for service delivery to work, you must ensure that there are certain aspects of the other pillars that must be addressed. And therefore, when we started this journey, one of the requirements was that His Excellency the Governor required to write a commitment letter that once we apply the grant, there are certain expectations that will be done from the county. And therefore, we had that commitment. And one of the things that has made it very easy for us during the implementation period is that every time we have a challenge, we always quote that commitment from His Excellency the Governor. So therefore, I just want to reiterate and say, and I think for the counties who are seated here, you can confirm that whatever happens in the county, if the governors have a buy-in, if there's a goodwill from that level, then that works for us. Then the next bit that we did was to ensure that we get buy-ins from also the various levels. That one, we needed to have some advocacy meetings, for instance, with the county executive committee. Just remember, in this game, you'll have, for instance, the team in finance and the county treasury, the people from planning, they need to understand what we are doing. So one of the things that we also ensured is just to have some advocacy meetings with them, just to make them understand what is it that we are doing. Because one of the things I want to say is that if you don't do that, then this one is labeled as a program that belongs to health, and they say that they always assume there's a lot of money, so they look at it as a health issue, so they don't see the big picture. Remember, in this journey also, we needed to ensure that we secure HR, which is also a big component, it's a pivotal pillar. So in the integration agenda, we have to ensure that HR is well secured. And how do we go about this in the perspective of leadership? That one, there are certain officers who've been working in the programs for the last 10 years. So we had to come up with a way of saying that if there is opportunity for employment, how do we ensure that we don't lose this experience and the kind of investments that have been done in this group over the years? So therefore, that means that you have to reach out to the County Public Service Board. You have to bring them to the table. So that is one of the things that we also ensure that we also had meetings with the County Public Service Board to tell them that one, we request that there be a special criteria when there's an opportunity for employment, the investments that we have done within these people, because they are going to be very key in our integration, then is not lost. The other bit is we also ensured that one of the things that we noted is that on HR, you have two categories, and this come up in this meeting. You have those officers who have been working in their HIV space for the entire period. Then you also have those people who have never worked in the HIV space, and therefore you are starting integration. So the guys who've never worked in the HIV space in the spirit of integration, they need to learn what happens in the other. So one of the things that we did, we came up with a curriculum. We developed a 5-day curriculum where we were able to bring the guys who have not been, who have been working in the HIV space, but they also just need to get updates on the other areas. Especially in here, we have a lot of NCDs. The reverse was also true. Remember, there's a lot of expectations from the clients. They are used to seeing people who have who eat, who sleep HIV. So we also needed to ensure that the staff who are not working in the HIV space, they also understand what happens in the HIV. So we also initiated some training. So that is in regards to HR. But I also want, when I talk about HR, I also want to talk about one of the things, because as Dr. Mulu earlier said, when we are talking about integration, you might focus too much on the key cadres, you forget about the lay cadres. So one of the things that we also did is to ensure that in Nyeri, we have ensured that our mentor mothers and our peer educators, they are part of CHPs, as part of ensuring that we institutionalize some of these things. So that ensured that whatever the mentor mothers are doing, now they are part of the system, and that has worked well for us. And it's something that I would want to encourage even other counties, because it has worked. These guys have a lot of exposure, and once they come onto the other side, they feel very much like they belong. The other bit that I would want to say when we started this journey, even as you talk about high-level buy-in, then we also had, as it was mentioned by our sister from Uganda, a lot of stakeholders meetings with the medical superintendents, the in charges of the CCCs, the sub-county MOHs, because the worst thing that you need in this journey is resistance. You have to ensure that the buy-in also comes from your colleagues and the people who are working and managing those areas. But beyond just having meetings with them, we also had to ensure that we capture this somewhere whereby there is a commitment from them. In Nyeri, we usually have performance contracts that are signed between all the way from the governor way down. So we also ensured that within the performance contract for the medical superintendents at the hospital level, we captured something on integration. And we told them, because remember, for a start, it's we felt that we needed to start small. So we told them that for a start, the small things are integrate, ensure that we have full integration of the pharmacy, of the lab and MCH as we work towards OPD. So therefore that ensured that from time to time we are able to monitor and find out how far, as we monitor the other key performance indicators, how far are we on this. I think the other bit that I would also want to say is that it is good in this journey, which we've also done, encourage some innovations. If you go, for instance, to our facilities, you'll find the facilities using their FIF. Because in Nyeri we have been implementing FIF since 2021, they are able to dedicate a certain amount of money to ensure that it supports some of this integration and transition agenda, for instance. We are able to, if it is a repair of motorbikes, if it is shipment of samples, that is supported at that lower level. And how do we make that happen? Beyond, even before those facilities started collecting money under SHA, before they got reimbursement for SHA, we ensured that 20% of what's collected in hospital would go towards supporting PHC. So therefore, we are able to ensure that at that level, there is some support, because we're also looking at sustainability. What happens? Remember, this was a transition grant. What happens after the 5 years? So therefore, I want to confirm that the whole bit about ensuring that you secure some finances to ensure that it goes towards supporting this journey then becomes key. My last comment would be that it's and still that touches on innovation, that those facilities were able to come up with something small like booths for at the level of pharmacy, whereby someone gets in, you don't know the kind of drugs they are picking, so they have some privacy at the pharmacy. And these were done purely at the lower level using the finances that they are getting from their SHA reimbursement. I think my last point would be that what I would want to encourage the various counties, let us not create, in this journey of integration, in terms of management oversight, let's not create parallel structures. Don't have a team that is overseeing integration or that is overseeing transition. Just ensure that this is integrated within the existing systems. And we're talking about the HMTs, the county health management team, and the sub-county health management. Just works within that, because there's a danger of creating some parallel systems whereby there's no ownership. So for me, I would want to say that that is something that we really need to guard and ensure that it is aligned to existing system. So therefore, as I finish, one of the things that I would want to say is that when all this is done, the most important thing is to ensure that whatever we are doing is sustainable. And as we look at integration, let's look at it as a subset of the greater transition. And I want to request the national government that these things have worked in certain counties. They have worked in the 14 counties that are transiting, that are doing the transition. And therefore, I believe even as we roll this, we scale this up to the entire country, there's a lot of lessons we can learn from the existing county. So I think for me, that's what I would want to say. Thank you very much.
Thank you, Daktari. And I believe the counties carry the burden. Service delivery is within their docket, and so really good experience. So we move to the final question. And Grace, you're last because you're at national level, so you give us the entire perspective. And so my question to you, as Kenya works to sustain the gains in the HIV response while strengthening the integration of HIV services within the primary health care and the broader health system, what practical approaches are most critical to ensuring that HIV services are effectively embedded within the routine health services?
Thank you, Evelyn. I think we've had quite a rich deliberation from this panel, and I've picked quite a lot from the panelists. But just to begin by saying that integration cannot be a national conversation only. It must be a facility level conversation. It must be a community level conversation as well. The community health promoters must also have their own deliberations as to what integration means for them. Last year in December, we had our first technical working group for integration. And one of the questions that we were asking is, how do we approach it? Do we go the rigid prescriptive way and tell facilities, these are the models that are on the table, kindly go this way? Or do we allow them to have flexibilities to choose what models work for them? I think listening to what Uganda has said, they went the flexible way, and facilities were able to choose based on their needs. I think one of the things that has frequently been said is that integration means different things to different people. And as we are advancing this conversation, I think it's important for us to say that there are global guidance, there are a lot of research that has been done around integration. And if you're to check, actually Kenya has the most number of research that has been done around integration. And so we are alive to all these facts, but as a HIV program, we must also be ready to have those uncomfortable conversations. There are things that are marked for the HIV program. We have the DSD models that are working excellently. We have the Mentor Mother program that has delivered very good results. We have the community pharmacy models that we are now scaling up. But these are programs that we need to also start thinking outside the box. And yesterday, one of the questions that we were asked is, can a mentor mother be a community health promoter, and can a community health promoter be a mentor mother? And when the SHA conversation came in, one of the stark realities we were told is that we cannot, the commodities probably may not be able to be onboarded into SHA. And that was a conversation that was uncomfortable for us. But if you look at the TB program, their first line is fully being paid for by the government. So why can't that be the HIV story as well? So as we talk about HIV service delivery integration and in the context of the whole healthcare system, we must align to how do we want it to be done. There are models that have been documented. We have the one-stop model, we have the chronic care models, we have the OPD models. So how do we redesign these models to speak to the facility level realities and even to the county level realities? And then when you talk about the healthcare workers, I think a lot has been said about healthcare workers, but there's no reason why consultants don't have the true depth of knowledge in HIV management. I think it's a disservice to our healthcare system. So as a HIV program, we are challenged that we are not just going to be training healthcare workers of certain cadres, but also consultants and across the different healthcare systems that are there. When you talk about the what, and these are the other building blocks, the data systems, the supply chain models, and all this health financing, all this must align to an integrated concept. A lot has been said about the where. We are moving away from disease-specific rooms, disease-specific laboratories, disease-specific platforms, because we don't want a system that responds to programmatic guidance, so that when we are given a stop work order, there are literally doors that are closed. I think it is backwards, and we must have those uncomfortable conversations that will push us to areas where we are well received. I think a pedestrian conversation says that the HIV program has become the child that goes to group of schools. Yeah, we have the sausages and the pancakes and all this nice food that we like to have, and it was necessary when it lasted. So when the government is giving food programs to the other schools, we are not considered in that program. But it is time for us to think about how do we have conversations of advocacy that will put us in a place for sustainability. We must be able to have HIV gains safeguarded, and that means that in terms of commodities, we must have assurance within the sustainable healthcare government systems, and between the healthcare workers as well. We must ensure that these healthcare workers are aligned to the integration conversation. So I know you are standing up because time is up, so I will stop myself as I continue to learn. Thank you.
Very much, very good insights.
And just to say that we had the absolute privilege of discussing the most critical components of the building blocks, which is service delivery. It ultimately ends with the patient outcomes. We must look at the patient outcomes, the virus suppression, the quality of care, and ensure that our patients are getting their medicines. Otherwise, then we lose the gains and begin to see a high incidence. So what did we hear from the communities? Communities are telling us something. They are telling us that fragmented services are inconvenient, stigmatizing, and exhausting, that being shuttled between multiple clinics, multiple queues, and multiple health workers for conditions that are deeply interconnected is not dignity. It is a barrier, and where services create barriers, people disengage, and where people disengage, lives are lost. I think we've heard that. And so they deserve health systems that see them as whole human beings with complex intersecting needs that cannot be neatly compartmentalized into vertical programs or boxes, and that our panelists have made it clear today that achieving this vision is both urgent and possible, but it demands deliberate, courageous, and sustained action at every level. And I believe everyone in this room is the person we need to do that. So as we conclude this session, we're saying that we need to organize our systems and deploy our resources to develop our services and to ensure that we meet our clients' needs and that we give them dignity and their right to health. A system that integrates services is not just more efficient, it is more human. So allow me to say thank you to my panelists, and I'm just urging us in this room, we are the policy makers, some of us are from the facilities. It's ultimately about the client. We must treat them with dignity. We must have patient-centered services, and we must be the change that we want to see. Thank you very much. Please clap for my panelists. As they come forward and we take a photo, don't go, you're very important people, please. We are the first guys. Clap for us as we take our photo. Thank you very much.
Thank you very much. You can now go down, and we appreciate you. The first team that has been able to take a group photo after a panel discussion. So that's yeah. So can we appreciate the team once again? Thank you very much. I want to recognize the arrival of other team members, and I want to request Dr. Newton to introduce the leadership of CEC Caucus, and the leadership will be able to say one or two words before recognizing some of the team members they work with.
Good morning. I want to urge attendees, please don't go for tea now. It's not tea time, but good morning. So we want to recognize that we have the counties here with their leadership here. We have the CECs and CDHs. So the CEC chair and the CDH chair, I want to give you a minute each, or 2 minutes each, to make some remarks before we proceed to the next panel. Thank you very much. CEC Chair. CDH Chair, Dr. Betty Langat, she's coming.
Good morning. My name is Dr. Betty Langat, the County Director, Health Services, Kericho County, and the chair or acting chair for today for the CDH caucus. I would like all the CDHs to stand, wherever you are. Well, I see quite a number. Maybe a few have gone for tea, and we really want to appreciate, as the county directors of health, being invited to this summit. There is a lot that we are learning from our colleagues, from our neighbors, Uganda, because service delivery actually happens in the counties. And this is where the rubber meets the road. And today we want to say thank you very much, and thank you for having us. And I believe that we will learn a lot and implement as we go to the counties. Thank you, and I welcome the chair of the CC caucus.
Thank you. Thank you very much. My apologies for coming late because of other duties. My name is Dr. Gregory Kanda. I'm the chair of the CC's caucus. I'm here with a few of my colleagues. Maybe they could stand up. And because there are so few, I'll allow them to come here and introduce themselves. From Siaya and from Baringo. Karibu. As they come, I think the issue of integration is no longer a matter of discussion. It is how we implement it. So we are no longer in the should we not. It's how we do it. And I think our governor spoke yesterday and gave the perspective of counties. But as counties and as CCs, I think we are committed to making sure that this works. We are capitalizing and strengthening our primary healthcare facilities and digitization as the backbone for how integration will work. We will have greater discussions as we go on human resource and the other pillars. So let me allow my colleagues to introduce themselves. Grace from Siaya. No, sorry, not Siaya, Homa Bay, sorry.
No, I don't want to move to Siaya. My name is Grace Masio Sewe. I'm the CCM for Public Health and Medical Services from Homa Bay, not Siaya. I'm excited to be here, and I look forward to some very practical ways that we're going to move forward with this integration. Thank you.
Yes, good morning, everybody. My name is Dr. Solomon Serma, the CCM Baringo County. And I'm surprised that we are few, but I know the reason is the CCs were not fully involved, and they were not even invited. I invited myself. And we are the heads of the health department in our counties. And we do a lot. Like my county, we have around 5,900 clients. I have 232 health facilities. So we've come here to support this summit of integration. I know in our Baringo County, when there was a stop work order, we tried to do integration a little bit. We experimented with 3 facilities. There was a niche, but later on we managed to pick. But our healthcare workers, they got renewal of their contract for another 1 year. So the challenges will be about the human resource, commodities, and lab equipment. So we need to invest a little bit on that area. Otherwise, I wish everybody a fruitful deliberation as we learn from this summit. Thank you.
Thank you. Thank you, Dr. Sima. I want to confirm that we were invited, but the leadership of the caucus was invited to represent all of us. So probably the information didn't get him, but I'm happy that he found out about it and decided to attend. Asanteni sana.
Yeah. Let's appreciate the chair of the caucus for the clarification and the next step. I just want to read a feedback from LVCT representative of persons living with disability. We didn't have enough time to go through questions and answers. His comment is that human-centered care should also consider that persons who may not be able to come to the facility due to disability, say for example, a person with cerebral palsy and living with HIV and other NCDs, looking at a person holistically means including persons with various limitations to access care. A round of applause for the gentleman. Thank you. Our time is gone. We want to encourage people not to break for tea now because time for tea is coming. We have another panel discussion that will be moderated by Dr. Lily Nyaga. Dr. Lily Nyaga, if you're there, please. Moderating this next session that will be looking at digital health and HMIS integration within HMIS. If you have the bio for Dr. Lily Nyaga, please. So allow me introduce Dr. Lily Nyaga, who is the lead of strategic information at NASCOP. Lily Nyaga has been working to put data together at NASCOP that is then used for decision making. A round of applause for Lily.
Yeah, thank you very much. Good morning. I see we are still full house. We are asking you what to bed only to bear with us. We'll be here for exactly 1 hour. Dr. Evelyn has eaten into our time, but we will figure out how to, save on the time. So before we begin, so we are having a digital transformation session that is going to be exactly 1 hour. But before we begin, I would want to first address what I think might be the most integrated thing in this room, my dress. So when I was preparing for this session, I joked with Dr. Barbara and I asked her, what should I wear for my session? Then she said, do you have something that shows integration? And that's how this dress was born. Multiple colors, different patterns, but somehow working together. And I was just thinking, if we could get our digital health systems to integrate as well as this outfit is trying, we might be in a good place. But now on a serious note, my name is Lily. I lead strategic information in NASCOP. And I want to start with something very direct. HIV program did not get here by accident. We built Kenya EMR. We built the data warehouse. As a matter of fact, majority of the people in this room and even some of the panelists were actually the pioneers of building these systems. We tracked very low coverage at facility level even before most programs knew what a cascade was. We created a data culture in HIV that is genuinely one of the most strongest systems in the Kenyan health system. And we should be proud of that. But here is the uncomfortable truth. It was vertical, it was for one disease. And for many years, the nurses who used to see patients in Kenya EMR in the CCC would walk out of the CCC into a maternity wing where everything was paper. The patient had just enrolled on ART, had her HIV record in one system, and the antenatal record was nowhere to be seen. Those two records never met. And you should let that sink in. So today, we are going to be having a discussion to really ask ourselves how that gap is going to be closed. I know Evelyn said that this is one of the most important sessions, but the service delivery, but I want to believe all those aspirations for service delivery integration cannot happen if the data systems are also not integrated. So we are going to be having a conversation that is not just theoretical, but heavily operational. And the people who are going to be sitting in this panel are going to be helping us to have that discussion. And we're going to be having 3 key things: what integration actually means, and the minimum bar we should be setting for ourselves. What it takes to move from ambition to implementation, and we'll be hearing that from healthcare workers and also the counties. And then finally, and most importantly, how to sustain those gains. So before we bring the panel, we are going to be first, sort of like setting ground for the current landscape. We have with us Dr. Jacob from Palladium, who leads the Kenya HMIS project, who's going to be able to share with us the context before we unpack it with the panelists. So Dr. Jacob, let's welcome him.
Yes, good morning, everyone. Yes, so my name is Dr. Jacob Odhiambo. I work for Palladium, and I'm happy to be here. So I think I'll just go straight to the point and just start with this presentation. I feel very humbled to be here because I have been contributing to the problem, but also privileged because we have an opportunity to address that problem with the lessons that we have learned. So to start us off, okay. Sorry.
You can't see the slide.
Yeah, it's up there. Okay. Yeah, so I think we are in the digital age. I think now we can even dare say we are in the AI age. But I think the unfortunate thing is that most of us, our personal lives are actually fully digitized. But then our workplaces aren't, simply because we have not really invested properly in data systems that will allow that digitization to happen. The reality of most of our health facilities is that health records start life in paper form. And this is the reality that faces many of the departments in the hospitals that are not HIV related, until recently when the Digital Health Agency started digitizing records in facilities. As we think about moving from this environment to the future, we have to think about several things. Okay, so the first thing is how do we want integration to happen? Because if you are having a patient who is going to be seen in outpatient, and their records, their clinical records about their HIV illness is in the HIV clinic and it is not digitized, then you end up with a problem that integration in practice cannot address, because the historical records of that person is not accessible to the clinician who is going to see the patient. The second thing is, we spoke about AI. Currently, if you are writing an email, doing a PowerPoint presentation, AI helps you. But how is the clinician at the front line in a paper-based OPD able to be assisted by AI if you do not have a digital system with which they can see the patient? So these are the sobering realities of the era in which we are and how we are mismatched with the data systems that we are implementing. So for me, I think it's very important for us to think about how we can integrate ourselves. How do you contribute to digitizing those outpatients so that your HIV clinical records can find their way in the desk of the clinician who will be seeing that patient, or in the integrated chronic care environment where the patient will be seen. And I think this reality is not very far. If you recall, during the stop work order, the EMRs were there, but the clinicians in OPD could not use them, okay? Simply because they were in the CCC. So those who tried to integrate could not do so because they could not access the records that they needed to take care of the patient, to know what the patient was in terms of regimen and their next appointment date. So I think it's important for us to understand that digital health systems are a very big enabler for service integration, especially because the HIV programs digitized fast. So I spoke about records starting their life in paper form. This presents certain difficulties. I remember when I started working many years ago, my first role at, in the district then, we were using file transfer protocols, then we go into DHIS2. And during the DHIS2 era is when we started now even doing more fragmentation of data systems. I remember the MOH 731, I remember DATIM coming in. And at the end of the day, the healthcare workers all of a sudden had all these different books that they needed to fill on top of the service delivery they were offering. I think as we move towards an integrated model of care, we really need to consider how to reduce the reporting burden, but also the data entry burden to practitioners. There are just too many records and reports that we require, but the HIV patient of the 2003 and the HIV patient now is very, very different. An HIV patient who is on care right now is more likely to visit an outpatient than a CCC for care. And therefore, we need to really start thinking about the profile of the HIV patient we are taking care of so that we can design data systems that speak to our new reality. You can no longer have tens of documents that monitor an informed patient who knows and is able to take care of their own health. So as we move forward, we know that we did a lot to digitize because there was a need for data systems that were going to help us to monitor the aggressive HIV program and to be able to basically contain the epidemic. But we went alone, and that is the problem that we have to face now. The HIV program moved alone, the TB program moved alone, and now we need to figure out how to bring the rest of the health system at par. I don't think the idea is to downgrade the HIV program in terms of the quality of care and data systems that we implement. The idea is to bring the rest of the health systems to an era where we can actually start leveraging available technologies for service delivery and health. So during this period, we know that because of donor funding, we had a lot of scale up in terms of testing, treatment. We had accountability structures for the money that was being invested, and we also invested heavily in health workforce. And this was driven by donor funding. Now MOH is taking the lead in all these things, but we did learn lessons. We know that data can drive outcomes. Automation is possible and can bring us a lot of efficiencies, and that digital systems in all respects outperform paper. Okay? And we also know that granular data matters because it is only when you can link a patient to their records that you can refer them seamlessly and you can take care of all the aspects of their disease. The whole idea about person-centered care is based on the premise that every individual record that we generate is linked to the owner of that record. And I think that is something we have been struggling with. And as we go through the next few slides, you'll see why it's very, very important for us to start thinking about how the digital superhighway is going to offer those services we have been lacking for so many years. Now, I want to give this as an example of what is possible with the digitization. This slide is a longitudinal view of a cohort of patients who have been receiving care in our clinics. Simply because we have data systems, we can now identify the ones who are actually well and the ones who are sick. Patients who are diagnosed, some of them end up not being linked to treatment. But of those who get linked to treatment, many are found to have AHD just because they were tested through CD4 or WHO staging. You can start beginning to understand how commodities impact how patients are staged. And on the right-hand side, you can start looking at individual cohorts, and you may actually start discovering that there are some cohorts that are actually disadvantaged in their journey to health, simply because we have individual linked longitudinal data sets. I'm saying this because we need to not consider downgrading the program's value to the patient by ensuring that we uplift the rest of the health system to match. Now, in terms of surveillance, this slide seems to have not shown up. I think this basically summarizes the silos, fragmentation, that is also affecting our surveillance systems that we need to really confront, because the COVID-19 epidemic showed us that what you really need is individual level data that is linked to a case, whose contacts you can trace, and who you can follow up for outcomes. But moving forward has also helped us to understand certain things that must be in place for us to be able to really deliver an integrated health system that gives value to both the practitioner and the patient. So we know that there are structural limits to how fast you can go without the rest of the health system. We also know that underinvestment in digital public infrastructure is very, very risky because you struggle. I remember, and I'll bring this up later, what's a digital public infrastructure? Because if you don't invest in it, there are certain services that government only offers to facilities that cannot be offered to you. These lessons have been very valuable as we think about a shared foundation, a digital architecture that allows us to basically offer an integrated service delivery. We can think integration all we want, but if DHA is digitizing facilities and we are not onboarding that, we are actually not we are actually not getting out of our HIV silos to embrace outpatient digitization, that there is no way we are going to integrate services in a meaningful way that is progressive. Because remember that many of the clinicians who will be seeing the patient will actually not be experienced and trained practitioners. They will need decision support features. Those things must be built in the outpatient clinic. It must be built in the chronic care clinic. We can no longer have HIV-specific forms. We must have workflow that is managed by the system in a way that recognizes that this is an HIV patient who also has hypertension and changes its behavior so that that patient is given a person-centered care for all the diseases they have and comorbidities that they live with. So our challenge is to move together. We cannot sit and wait for the rest of the health system to catch up. We need to help the rest of the health system to catch up. We are very loyal to the applications we have built. We are very loyal to the structures we have set up, but we need to let them go so that we can be able to pull those who are down up with us. So what is integration? One patient, one record, all of them linked to the same person who can be identifiable and own their own data. It is commodity data and service delivery data being reviewed in lean time because you know which patient got which medicines and the conditions they're having. It is facility level data informing decisions on the same week it's generated. Right now, we are talking about a lead time of 1 month. What can you do when a patient was not linked last month and you're getting to know about it 2 months down the line? It's not the right thing to do, right? If a patient has hypertension today and is an HIV patient who has been living for long, they can actually die before you actually discover this patient was hypertensive. Okay? We are talking about the clinician in the facility and the public health practitioner at national level having the same data they are using to make decisions so that you can hold each other accountable for resource allocation, but also for service delivery. So I talked about digital public infrastructure, and I think this is the direction that we are heading. And I really like what Dr. Mwai mentioned yesterday, that one of the biggest benefits to the health sector is the formation of the Digital Health Agency. Because for the first time, we are having a government-led, coordinated approach and overarching legislation that is forming a strong foundation to hold everyone accountable to standards and to a certain mode of practice. For digital public infrastructure, I'll use one example. I remember in 2023, we did ART verification. The reason we did that, because we did not have a nationally issued identity to use to make sure that our clients were actually real people who receive care. With the establishment of the Digital Health Superhighway, identity management is now sorted. Okay, and that is the value of digital health public infrastructure. Terminologies can now be standardized, and the referrals can now be possible through interoperability. So as we build on this foundation, it's very important that we do not repeat the mistakes of the past. Our systems need to be linked to the highway and should ensure that there is seamless movement of patients across the health sector. There is overarching legislation, and just following up on the very, very coordinated approach that envisions the comprehensive integrated health management information system. The Data Protection Act that anticipated individual level data will be generated, and now the Digital Health Act that is going to guide implementation of these digital health innovations. I think I'll end with this slide that is basically telling us to onboard the change management bandwagon. Because as we do integration, we really need to make sure that the awareness on why we are doing this, practitioners at all levels, public health and at the front line, desire to actually change to a digital future that is integrated and have the knowledge to do so, the ability to do so, and we reinforce that through management support. So this is the last slide, and I appreciate you guys for listening to me. This is just highlighting that systems must deal with health information at the same time. So thank you so much. I'll end it there, Dr. Lily.
Thank you, Dr. Jacob, for unpacking that for us. I'm also happy that you started by declaring that you do agree that you are one of the problems. I inherited the program from Jacob and Dr. Wamishwe, so they created the problem, but we are here to really discuss how we are going to be part of the solution. So we will now bring on board our panelists. We have exactly 45 minutes to have this discussion. So we start with So in the interest of time, I'm not going to go through the bios. So we start with Pamela. Pamela is coming from a facility, Lumumba Hospital, and she's the medical superintendent who's going to be sharing with us her journey in overseeing a digitization of our facility. Let's welcome her. Then we shall now move to the next panelist, Dr. Gakombe. We are really humbled to have you join us. Dr. Gakombe is the founder and the CEO of Metropolitan Hospital. He has also overseen digitization of a facility, not just one, not just within this country, but also in other areas around the globe. And so we'll be hearing from the private sector to really understand what it takes to digitize a facility. Next. So next we have Dr. David Kasanga. Dr. David Kasanga is the Director for Curative and Rehabilitative Health in Makueni County, which is also on a journey to digitization. And we shall be hearing really from the county on what the role of the county in digitization looks like. So let's welcome Daktari as he comes from the back. And finally, we have Dr. Wamishwe, who is the Director for Standards and Certification in DHA, who are also leading the digital transformation agenda in this country. Let's welcome her. She was also my predecessor. I have to keep saying that so that as she's saying the solution, she remembers that she handed over for me the verticalized systems. And then, of course, Dr. Jacob will also continue to be in the panel. As I mentioned, Dr. Jacob heads the Kenya HMIS project, and we are going to be having a discussion together. So keep your questions, and then we shall be able to address them either within this meeting or away from the meeting. So you have your mics, panelists, asanteni sana. We shall begin with Digital Health Agency. So Dr. Wamishwe, I know you're not new to this space, the HIV space. You had the session that was much earlier, integration. And I was also hearing mamas, what does integration really mean? I think if you asked everybody to define integration in this room, we will have as many definitions as there are the number of people. So we want to understand from a digitalization angle or lens, what does integration really look like from DHA's perspective? What are the minimum bars that we must be working towards? Dr.
So good morning, and thank you very much, Dr. Lily. And nice to have a great panel team up here. Also, good morning to everyone in this room. It's nice to see the many faces, some of the people I saw one year ago plus. So you do ask a very good question about integration. And I would like to tackle it from a user perspective. At the Digital Health Agency, we do not just say, okay, so our mandate is to deliver the comprehensive and integrated health information system. Many people have been walking around this country looking for that system. They want to touch it. But that particular system is many systems. And each one of us is supposed to be enjoying parts of that system without knowing that there are 38 or 40 plus systems within it. So that is integration for us. When you move to the user perspective, we have our two main users. That is the healthcare provider and the patient. I want to propose that we need to look at integration like my dress. You shouldn't see the many colors that are on your dress, Dr. Lily. So a patient, when they come to a health facility, should not feel that they are moving from one system into another, despite there may be different systems within that one system. A healthcare provider should also not feel that they have to go to this system if they have to see lab, they have to go to this system if they have to see pharmacy. They should seamlessly be moving in between whatever system it is to deliver their mandate. That is what integration is. That is what we are seeking to do. Right now, what we have, is it integrated? Not quite. Eventually, it will be, because we have so many systems we are working on, and just making sure that we tidy up and make everything speak through the health information exchange, which has not been there. So I hope that I have convinced people that I am the one wearing the integration dress. Thank you.
Yeah, thanks so much, Daktari. I really like that. Really being able to use a system without really seeing the multiple. You know, when you enter the bank, you withdraw your money. You're not interested in knowing what is happening behind the scenes. You just want to get your money. So now we will transition to Lumumba Hospital, Pamela. Just really being able to hear facility reality. Lumumba Hospital has for a long time had Kenya EMR in the CCC, but you took a bold move to really scale that up to from end to end, from registration to really the end. So we want to hear your journey and what you would have done differently, what you needed to really let go to make a fully digitized health facility, public health facility, a reality. Pamela.
Thank you, Dr. Lily. And yes, it has been a journey, as you have indicated. Lumumba Sub-County Hospital is a level 4 facility which is very busy. We have about 10,000 outpatient, and our HIV care has a workload of about over 7,000. So it wasn't very easy. But when we thought about digitization, we felt that since the Kenya EMR is what was being used in the CCC, then the issue of the facility-wide digitization came in. So we thought, why don't we just use the same system in the whole facility? So this we discussed as a management in the hospital management team to have their buy-in, because it would not be easy if the heads of departments do not buy it in. So we discussed and let them go and discuss in their departments. And yes, the feedback was positive, because it was like digitization is the way to go. So then Palladium came in and supported us in trainings, because we had to start with trainings. It wasn't a system that all of us knew how to use. The model that people knew was the model that was being used in the HIV care clinic. So we had trainings, modular trainings, depending on the departments. Then later, we started rolling out. But before rolling out, there was the issue of the infrastructure, the hardware. Again, because SHA came in and there was DHA, and they managed to give us some tablets. So we were able to distribute the tablets all over the departments. They were not enough, but at least they were able to start us off. Then as we were starting, we decided let's make it let's take a phased out approach, and started with the outpatient. So we had it at the registration, the clinical rooms, the laboratory, and the pharmacy, because this had to be connected. Although as we started, we made it hybrid, because we knew we may have issues. Some people may go slow. So we made it hybrid, but tried to pull out the peppers slowly by slowly. So since we started, the staff have really managed to embrace it, and we've managed to actually roll it out to the maternal, neonatal, and child health clinics. We have rolled it out to the inpatient also. And right now we are completely paperless. Our CEC is here and will tell you that he actually had to move to Lumumba every other time to check whether we are managing, because it wasn't an easy one. But I would say that with the digitization, it has really improved on our patient management, because then right now a patient has only one unique number, and this unique number that is generated by the Kenya EMR is the same number that the patient uses in all the clinics. Whether the client goes to the CCC, to the outpatient, to the maternal and child health clinic, comes to deliver in the maternity, it is the same number. So that means as you open the dashboard, you are able to see everything that the patient has received in the facility. And we hope to continue improving. I know there have been challenges. We have even realized, or the staff prefer the desktops more than the tablets. The tablets seemingly are slow, and we are trying to replace the tablets slowly by slowly and putting up the desktops. Then system downtimes, especially earlier when we started, we really had issues, but the downtimes are reducing with time. Internet connectivity, it wasn't a very easy one. We were really struggling and thinking, can we have different internets? Like we would have Safaricom and be sure that Safaricom would work. Sometimes it gets slow. We decided let's now bring in Starlink, and mostly in our maternal, newborn and child health clinics and in the maternity, now we have decided to use Starlink so that not everyone is struggling for the same internet.
Pamela, hold those thoughts. We want to now hear from the private sector. We have had, so you will take us through the challenges in the next round, but now let's hear from private sector. We have Dr. Gakombe, who I indicated that started digitization way early in the 2000s, not just in one facility, but in multiple facilities. So we would also want to hear the journey and what is really different, what is happening in private sector compared to what the public sector is doing, and what did you really have to stop doing for digitization to work for you, Dr.
Thank you, Lily, and good morning. For the private sector, the key driver of digitization or change is one, financial sustainability, whereas the same applies to the public sector. In the private sector, there is no KRA to collect revenue for you, so you either make your books balance based on what your patients are paying or close. So we are a lot more sensitive to financial sustainability. The second is control. Health organizations are complex. So if you are the CEO, if you are the head of operations, for you to feel that you are in control in an organization where everybody is spending resources, you need data. And data can only come from a system that collects it and allows you to access it in a way that you can consume it. The third is service excellence. Anyone who pays for a service expects to be attended in a manner that suggests they're the customer, which means short waiting times, which means that the price is right, which means that the staff are focused on giving the care, and therefore a digital system does offer that opportunity. And one of the greatest opportunities, and for those of you who are clinicians in this space, when you have a patient in front of you and you have to write the name on a lab request form and write the name on a physio request form and write the name on a diet sheet and write the name on an imaging request form. That is very tedious work. And that is work nobody should pay for today other than by buying IT infrastructure, because those details should have been captured centrally, and all you need is to put the test you want to order or the details that you need from the clinician, but not what records should have put into the system. So integration, an ERP does offer the opportunity that you have single points of data entry, and from there, everybody can use that data to provide service. So that is, for us, was the primary motivation. And this was in 1998. And the proof of the pudding is that since 1998, we've never closed our doors. During COVID, during the introduction of SHA, we have been among the more resilient health facilities. We didn't even retrench staff or delay salaries. We may do now, and we'll have a conversation with SHA over that one, but we've not had trouble paying our bills from 1998 to yesterday.
Wow, that is really excellent. Let's give him a clap. So you started your digitization journey when I was doing my KCP, and here we are. So now, yes, so we will be talking about sustainability now from a reality point, not from aspirations. Thanks so much, Daktari, for those insights. So now, Dr. Kasanga, you have heard what the facilities are doing. At county level, do you have a plan? Do you have a roadmap? How do you see yourselves, fully digitizing at county level, having multiple of those facilities that our earlier speakers have spoken about? And really, what is the role of county leadership in leading the journey towards full digitization of facilities in counties?
Thank you, Daktari, for the question. Before DJ came in, let me take Makueni to be the example, because that is where I come from. We had most of our medical records manual, and only about 20% were digitized, but the platforms were also fragmented in the sense that we had various softwares in use, one being FunSoft. We also had another one called Elephant. And of course, across our care and treatment sites, which are 72 in number, we had Kenya EMR in 70% of the care and treatment sites. So that fragmentation was a challenge to us, and the current dispensation began to develop an EMR. But in that process, then DHA came in, and after announcing the opportunity for partnership, we went in. We were among the first counties to partner with the DHA. So we received the gadgets from DHA last year, about 1,384 tablets. Of course, we anticipate in the near future to receive additional desktops and laptops. Now, these gadgets from DHA have the EMR Tibabu. We all know Tibabu, or most of us must have interacted with Tibabu. But again, we realize, our problems were not being solved. Ladies and gentlemen, I think as a country or even in human life, for Kenyans, I think we like to run too fast all the time. And it is important sometimes to slow down, look back, evaluate before you can dream or project into the future. And I'm not saying this because I'm against any person or organization, but if you compare, and now I'm talking as a practitioner, what we have in Tibabu, and for example, you compare that with what we have in Kenya EMR, then you realize that Tibabu is like a baby who is yet to sit. In this sense, most of the modules are still under developed. You want to generate reports for KHIS. Most of the reporting tools are yet to be put in. Whatever you generate currently as errors. And then, of course, the other challenges of system downtimes. I believe it was for a good purpose. Tibabu was meant to assist operations or the financial bit of SHA. But again, the accounting module cannot give you a financial report. So that's where we find ourselves. Did we enter into a marriage before one of the partners was ready? And that, or underage, and if that's a vehicle, because really our dream was, or our dream, and still remains to be our dream, how soon, as our colleague or a brother observed, how soon can we have one record for one patient and do away with this fragmentation?
Daktari, in Jeff Koinange's tone, do you have a plan?
Yes, we have a plan, Daktari. But what I'm saying is that the plan is in threat or under threat. Because the vehicle we boarded, we are not assured of getting to the destination. But our plan is in the next 5 to 10 years, can we have all our medical records electronic, and that every patient, one record for every patient, and not having, even to burden the users with several platforms. So we have a plan, yes, and our dream is to have within 5 to 10 years, have every facility digitized. So far, level 2s and 3s, we are not having a big problem. Where we have a challenge is the hospitals, and most of the outpatient departments, the hospitals are digitized. Thank you.
Thank you so much, Daktari. Very candid reflections and also feedback to your experience, which is critical in ensuring that the digitalization, or rather the digital transformation, is as seamless as possible. Before we also have Joyce weigh in to the underage child that she sold for marriage. We shall now hear from Jacob, who I mentioned was also my predecessor. Jacob, you have a rare perspective. You build the system for one disease. You're now rebuilding the system for an entire facility. What lessons from digitization days have you carried forward? What mistakes were made much earlier in the Kenya EMR rollout that you are determined not to repeat? Is there any success that has become foundational as we move towards the facility-wide approach?
Yeah, thanks, Dr. Lily, for that. There's a whole book we can write about the mistakes we made, but I'll probably just summarize in maybe 3 or 4. So the first one is that we started digitization by translating paper forms into digital formats. So you ended up having these several forms that were being captured in the system, and then put them in digital format, so that then what we were doing is propagating what we call retrospective data entry, right? What that ended up happening, it created the impression that data systems are for data. Yet the reality is that they are supposed to be solutions that manage the clinical workflow and manage the facility workflow. Then they generate data that can then be used for reporting. So related to that is just a delicate balance between what is being collected and what is not necessary to be collected, what we call data minimization, in the sense that we avoid making the EMRs look like a research instrument, and more like a clinical care solution without compromising reporting. Because at the end of the day, the data that you generate is also what motivates the program managers to basically oversee service delivery, which is something that they do need. I think the third thing is just working with government. I think those days we did really have very strong structures for digitization. And I think right now, looking back, it was an important investment to make. such that you are, for sustainability purposes, you are sure that you are not relying on probably staff who are not employed by Ministry of Health to maintain the system. Because right now where we are heading is that the staff who are using the system, it's basically a tool for their own service delivery, not because they have been asked for someone who needs a report at the end of the day. So I think those are mistakes that I think we can avoid, and just think data, think workflow management, and think governance and structures.
Thank you so much, Jacob. I think we will learn a lot from those lessons as we go, full-scale facility-wide systems. So, Dr. Amisho, we've heard from facilities, also, from the counties, but I'm also happy that you started by, debunking what integration is. Maybe you can also tell us what, as you react to some of the issues that have been raised, also tell us what you feel about interoperability. I think when I joined the HIV program, you used to laugh at me because I always used to ask you, what is this interoperability? At that time, we couldn't even be able to, mention it. But what is it really? What is that health information exchange? I feel like a lot has been done in terms of having the standards available, but we are still not seeing systems speaking to each other. So how do you envision this exchange, Daktari?
Okay, so it's always exciting hearing feedback, and some of it makes you feel like, where was I supposed to take the aeroplane to come here? But allow me to just give some reflections, and I'll start with, if Dr. Gakombe was to tell us the journey that he has taken in digitalizing Metropolitan, it would not be a one-day story. Neither would it be a one-year story. It's many, many years, okay? Then when you come to the public sector, if yourself, Dr. Jacob, Dr. Mokoi, the people who were there, were to start talking about how we moved from no records to a blue card, to a green card, to Kenya EMR. Remember when Kenya EMR was only doing CCC? And people were wondering, how about the pregnant woman who is positive? What is supposed to happen? It's years and years of lots of work, lots of labor of love. If Prof. Kimayo was to talk to us about AMRS, it's not a story of one day. So what am I trying to say? What we are going through is digital health transformation. Why it's moving at the pace that you feel it's moving too fast is because we are leaning in on the lessons that have been learned over time. For the Digital Health Agency to be established, that is because there's been thinkers through for a long time asking, so how should this interoperability work? I recall at some point when I was working at NASCOP, and the whole story of unique identifier used to be funded in the COAG at NASCOP. But it took us bravery to say, no, unique identifier is not about a program, but it is about the health sector. And we pushed it to Afya House at that time. We also had conversations of HIV EMR technical working group. Many of us were in that technical working group. But after some time, we moved to the national level, and it is that national level technical working group that actually developed the Digital Health Act. So we are at a point where we have lots of lessons learned, and we are pushing them out to do a lot of the things that we have been thinking a lot about for many years. Specifically, allow me to talk to Daktari. Dr. Kasanga, I feel you. Tibabu, yes, is not as mature as Kenya EMR. That's a fact. It's also not as mature as Afya KE. That's another fact. But the other fact that we need to appreciate in this room is the same brains that built those others are the same brains that are working on Tibabu, and they're working on it even faster. That's why today you can say Tibabu is working for level 2, level 3. It wasn't 1 year ago, truth be said. And now we are working on the MOH reporting and the reporting for SHIF, the claims module. And in another 1 or 2 years, it might be superior to Kenya EMR. But the idea is we want systems that we have control over as a government, because we understand that health data is a strategic asset. So we don't want systems where we later have to go and beg to get that data. So let's walk that journey. It's not going to be a clean journey, but it's going to be a shorter journey because we have lessons that we are inputting in there. And within no time, that story of one digital health file for every Kenyan will be a reality. And it will be a reality through the Health Information Exchange. Thank you.
Yeah, thank you so much, Dr. Joyce, also for assuring Dr. Kasanga that youth, being young is not so bad. Even we know that when old men are about to retire, they start looking at much younger girls. So to scratch the back, in Oburu's words. So yeah. So we'll go to now Pamela. In the interest of time, I'm now winding up because we see our DG has joined us. So we'll now have the last questions. I know we had like 3 sets of questions, but we're going to now wind up. So Pamela, in the next 5 years, your Lumumba is fully digitized, fully integrated. What does the best version of that system look like, both for the patient who walks in and for the nurse who's sitting across that patient? What is your best version of that fully integrated, fully digitized facility?
The best version for me would be that system that when a patient walks in and is seen by the clinician, you are really able to get your reports as you expect. As people working in health, we were used to particular way of reporting. We had registers which we have now pulled out. So we really expect that all those indicators that we follow, we should be able to get them in our system as we move forward. Because currently, I know some issues could be because of the staff. We are still having shortcuts in the system, but we hope to work together to be able to generate the correct data so that we can actually be sure that as we use data for decision making, we are using the correct data. Thank you.
So much, Pamela. So really, Joyce I can see Joyce is taking notes on what it means for a system to be fully integrated from the perspective of a clinician. Dr. Gakombe, you have sustained a digitized system since I sat my KCP, and then I went and got an A much 4 years later, then went into medical school 6 years, and now almost 16 years. Are we doing 16 years? 16 years since, in health, and you have fully sustained your system. What advice would you give to this panel, and especially the DG, on what it takes to sustain these systems that we are currently building?
A couple of things. First, no system is fully mature. In fact, he and I are in the same space because whereas we have used the same logic, we have had to change the system last year because our tools had reached the end of life. So the metropolitan system of 1 year ago and the metropolitan system of now, we are having that Tibabu, Afiake, EMR debate internally. And my staff are not happy because they preferred what they were used to. So those transitions will come, and this will not be the last one. The third thing is something Dr. Gada said. The debate about whether to is done. The debate should be the how to. And anyone who refuses to change will have their Kodak moment. You'll simply go bankrupt. And even for a county, please remember, because of SHA, counties have to separate payer and provider. Otherwise, our health system will not work because governors will start saying they will not treat strangers on their budget. And SHA and universal health coverage offers us an opportunity to separate payer and provider. And the reason we are never going to end this journey is that in our case, we've now moved to patients doing self-monitoring at home, because those with long-term diseases, our vision is to take care of them even when they're at home. So I want my sister to follow me in that journey. And in the other extreme, we've moved into robotic surgery, which is also highly digitized surgical environment. So we all should walk this journey, and DHA and SHA offers two opportunities. One is that anybody who ever has a check has power. So SHA can force us to do certain things that the MOH could not do, that Dr. Amoth had no ability to do, because if he says we do it, we say, says who? But SHA writes us a check, and if they say they can only send money to a bank, we are going to provide bank details. If we are told to register all our beds afresh by KMPDC, and we are very annoyed, but we registered our beds afresh, and now we know who has an ICU. I want to remind all of us here what happened during COVID. We were busy asking, who has an ICU bed? Who has a HDU bed? Now you go to their dashboard, and we not only know who has an ICU bed, but whose ICU bed is occupied. But that transition was very noisy. Most providers made noise. I did not. Most providers made noise because we are being asked to do extra, but the country is better off today. So DHA and SHA offers two catalysts. The second one, now for DHA, one of the biggest challenges we've had is, what do we call a patient? What number do we give them? What do we call a drug? What number do we give it? What do we call an equipment? So by having, you call them directories? Those registries are very fundamental to integration, because people who have to work together must speak a common language. And the common language for us should be the same health codes. Finally, there's a great opportunity, because nowadays, writing software is not the main problem. That can be done quickly. Tibabu can evolve very quickly. My system can evolve very quickly, because traditionally the limiting factor was IT guys sitting at computers writing codes to digitize what you want. That is now a lot easier. So our challenge is being able to define what we want, so that the team on that side can quickly translate our needs into code. Thank you.
Thank you. Thank you so much, Daktari. And now to the County Director, Dr. Kasanga. 5 years from now, what has to be true about digital health in your county? What role does the county play in terms of balancing the county autonomy and, the national level, the Digital Health Agency and the national programs in terms of ensuring that your county is digitized?
I think, as my brother has observed, we have no choice but to go the digital way. I look forward to a system which is very simple, and behind the simplicity, being effective and efficient, serving the client to the extent of sending a reminder SMS if need be, serving the healthcare worker by not overburdening them and being able to use artificial intelligence, and serving the manager in the aspect of providing both financial and operational reports that are reliable. The national government, we know by law, is tasked with policy, and the policies and the laws are out. It is the duty of the counties to implement, domesticate and implement those policies and laws and regulations. The role of the county leadership is to provide direction and ensure that resources are provided to achieve and realize the goals and objectives of digitization. And therefore, the road that works, the road that is reliable, is the one to be followed by every county to make sure that as soon as yesterday, one client, one medical record that assures continuity of care across the board. Thank you.
Thank you so much, Daktari. Reduced burden on the healthcare worker, for them to be able to embrace it. Dr. Jacob, as we close, Dr. has mentioned about the use of AI. I think I've had a lot of AI in this conversation. Technology is moving very fast. In the next few years, beyond AI, there will be other things none of us can predict. How do you build a system today that will not be obsolete tomorrow? What are you doing to ensure that the systems that we are currently building are able to adapt to whatever new thing that comes up without forcing painful transitions like we have heard from our panelists?
Yeah, I think maybe I'll just summarize it because of time into a few things. So the first one is that you need to use technologies that can be evolved to the next level. Technology. If you look at 1 year ago, how things have progressed, you really need to regularly refresh the technology that underlies the solution you are building. The second thing is to build for scale. The small facility today will not be small tomorrow. It will be really big the next day. So you really need to build for scale. And then finally is to also anticipate where the world is going. I think for me, we have focused so much on the system and the information in it that sometimes we forget about the health it's supposed to be supporting. For me, I really look forward to the day when we'll be talking about how the system helped, how my health improved because of the system. Okay, how we can innovate on top of the foundations that the team will have set, so that then we can be able to make health for everyone very easy, accessible, and efficient. Thanks.
Thank you so much. So, Dr. Wamishwe, as we close, 5 years from now, we may be here on this panel. I don't know, maybe we'll be CECs, we'll be ministers for health. But I know there will be a meeting to really ask ourselves, what have we been able to achieve? So what are these investments that we must do as we move the digital transformation agenda forward for us to be able to actually feel the impact of the discussions that we are having here as we implement?
Okay, thank you. I had thought you'd ask me to put a picture of how it would look like 5 years from now. So I'll still do that. But at investment level, the biggest investment is reforming in our minds. Everything else is there. The vision is clearly articulated. We've figured out how to sustainably finance digital health transformation in the country. We're already doing it. We've started with our public health facilities. Privates are at different levels, and our faith-based facilities are also at different levels. We are looking forward to innovative ways of financing the FBOs and the private health facilities to digitize. We are not only looking at digitalization of health facilities, but the whole ecosystem. So looking at the different pillars as WHO guides us, you know, the human resource, the health products and technology going on. And at the end of the day, we have this great digital public infrastructure called the Health Information Exchange, which is also called the Digital Health Superhighway, that's been making people quite uncomfortable and also quite excited, depending on which side you are. And that's the game changer. And then lots of data with possibilities, opportunities, potential for lots of data analytics, predictive analysis, all this AI talk will get in there. But at the end of the day, 5 years from today, Wanjiko will be walking from one health facility to another without carrying the many things that they carry as they go to visit their facility of choice, without having to start the story one more time, and having a healthcare provider who's able to access their digital health record with their consent and able to continue their care. That's the big thing that Wanjiko will be able to see. But at Dr. Amoth's level, he will be able to see lots of data at the click of a button on his tablet without having to call 5 people at the ministry to tell him what is the status of SHA. So it depends at which level we are in. In between, you put the CECs, you put in the county health management team, And also, even the media, they won't have to call Dr. Lily to know how many people are living with HIV. There'll be a public portal for such data. So looking forward to the next 5 years, may we be alive to see it. And it's an exciting journey. Thank you.
All right, so I think we are coming to the end of the session. In the interest of time, we've been requested not to take questions from the panel, but we are available for discussions over lunch, and even in the evening, we are available. If you're buying drinks, we will give you the information. So, just one. Okay, I've been allowed to ask just 2 questions. So, Sarah, you can help me get the 2 persons.
Thank you very much. I think this is a wonderful panel. Jacob, the handshake, remember? And Dr. Wamishwe, wonderful. I think I have just one question. The interoperability by, I don't want to call who is doing it, that interoperability, please open it up. We are all in the digital superhighway. EMRS is there, Kenya EMR is there. But please allow us to work there rather than reinvent the wheel of doing billing when somebody else could do better billing. And let that person who is doing billing not do another EMR. Thank you.
I think that a comment to Daktari Kamau, and then one last person, Sewe.
Thank you very much for the presentations and everything here. I've seen Dr. Amoth has walked out, but I have one question to the panel. You want to use this side? You said everything you can say which is good, but what barriers do you get when it comes to the financing? We know very well that SHA is underfinanced in the primary health care, which is the government, and one of the critical issue. So unless we put all this together, it will not work. I would have thought in the panel there would be somebody from Ministry of Finance to be able to show and see. So one of the things that needs to come out as we move forward for SHA and the integration is we need to come up with the socio-economic benefit of the system. Hello, we need to show that the return on investment of health is actually working. If we don't do that, the finance guy is not going to do anything. And that's where the problem is. 2 years, we have not paid our co-financing for Global Fund. Yet here we are, health without barriers for holistic HIV response. Thank you.
Yeah, to thank you, the panelists. I'm representing persons with disability, and this is one of the panelists that can be able to address some key issues concerning about access to service. I want to point this question to Dr. there about the AI usage to actually unpack the issue about access to persons with disability who have mobility issues. Number 2, I want to address the issue about data. The segregation of data is what drives some decisions to some populations. How our systems are going to include persons with disability in actually programming. Thank you.
Thank you so much. We have taken notes. I think most of the issues were really raised as comments. And so as we close, allow me to say what I have picked from this session is that integration, is that, all right, is that integration is really not about systems, but it's about people. It's about the nurse that shouldn't have to enter the same data multiple times. Dr. Gakombe has really highlighted that to us. It's about the patient whose data doesn't have to be fragmented in multiple systems and they have to repeat their story over and over again. The patient doesn't really care which system holds her data. She cares whether the clinician in front of her knows her history. The success of digital health will not be measured by the number of systems that we build, but by how invisible. And Joyce has tried to challenge this dress that I am wearing, whether it's an integration dress or she's the one who has the integration dress. The one where you see multiple colors by design, or the yellow one that looks very cumbersome. So it's about how invisible the systems become to the healthcare workers while making clinical and other decisions. So with that, join me in appreciating the panelists. So we shall take a group photo, and I hope we've been able to convince you that integration for data systems is just as critical as service delivery integration. So we shall take a photo for the panelists. Dr. Ramisi, please join us. You were the one who is behind the success of this session. So that we take a group photo and then we hand over to the chair. Yellow dress. Thank you so much.
Good afternoon. Good noon. It's not, it's just been afternoon. Thank you. Let's applaud Dr. Lily and the team for a wonderful session. We have been joined by the Director General for Health, Dr. Amoth. And like I said in the morning when I was representing him in this very platform, I said I would not fit in his shoes for obvious reason that he's taller than me. But we want to take this opportunity to appreciate you, DG, for joining us today. We have been here from Sunday. In here, we have delegates from the 47 counties representing the county departments of health, implementing partners, and communities from the 47 counties. We have team from the Ministry of Health, NASCOP, NSDCC, and other directorates in the ministry. We have team from our development partners, the UN family, UNAIDS, UNITAID, WHO. We have the USG family that is here, led by Brian, of course. We have other bilateral partners who are here. We have our sponsors from various, from the industry who has been supporting us. We have CEOs from various implementing partners. We have a representative from the Ministry of Health Uganda, Daktari, who has been with us from yesterday. She was part of the service integration panel in the morning. We have representatives of counties, CECs, Dr. Ganda, the chair of CECs, is here. We have representative of county directors of health and county chief officers. Above everything, we have our young people, adolescents and young people, as special community groups who are here that I appreciate. And above everything, DG, I have been the father of everyone here. But now that you have come, I probably become a mother or a deputy father. So I want to hand over the fatherhood to you. You will give me the right role. I want to take this opportunity before I invite you to make remarks. Dr. Nganda, I will give you an opportunity to speak again. I will also invite the Deputy Secretary, Kenya Red Cross, to just say hello, then invite Dr. Nganda to speak on behalf of the counties because he was not with us. I know you gave remarks earlier on, but like I've said, the real father is in the house. Mbalu, on behalf of our partners, kindly make one remark, and then I invite Dr. Nganda and the DG. Let's applaud him as he comes forward.
Good morning, everybody. Good afternoon, or sorry. The discourse has been that engaging that the movement transition of time is not registering. So I just wanted to say hello. I've been told to just come in and say hello, and I wanted to bring our support of this particular summit deliberations from the Red Cross and the Red Cross movement. And in particular, I have the fortune of heading the localization hub for African region, and I'm very excited to see the thinking of being able to bring in our regional neighbors to come and participate in this. So through the DG, we just wanted to appreciate what is happening. I know the sessions that have come in have been quite tough. I am already prejudiced because I will be also prosecuting one of those in the session that I feel is the most important about communities tomorrow. So thank you very much, and we're very honored to be part of this. Asante sana.
Thank you, Balu, for making it brief. I now want to take this opportunity to invite, I was once a chair of CECs, Msinione hivi. My successor, Dr. Gregory Ganda, who is the CEC for Health in Kisumu County and the chairperson of the CECs for Health, to come and make remarks, and in turn also invite the DG to make his remarks. Karibu, Waziri. Let's applaud him as he comes forward.
Good afternoon, everyone, again. Yes, to be told to speak twice is not easy. And you know, I'm a surgeon. I just cut and get the tumor out. So if you tell me to be a physician and ask so many stories, I don't know how to do that. But anyway, I think I'm honored again to come here and speak just before the DG has spoken. And first of all, allow me to appreciate all protocols observed and riding on the already established protocols. All for the DG and the team from the Ministry of Health, my colleagues from the counties, all our partners, friends, and all those people who are here today. I want to say that we as counties appreciate this opportunity to be on the table to discuss. As you are aware, we have a devolved system of governance where the national government has a big role in terms of policy and giving direction, and the counties have a big role in adopting policy and implementing. And these are not actually divergent, they are complementary roles. So we work with each other to be able to implement these policies. As we are moving towards integration, I'd already said earlier that we are not discussing how, or not how, we're not discussing if, we are discussing how this integration has to work, because it's no longer a choice and is the right thing to do. We as counties are strengthening our primary healthcare systems to be able to adopt to this. And these sessions are very important. Actually, I learned from Dr. Kimaio when he was here last time about how to structure integration. And I remember at that time we said, the lower level facilities integration is possible. But as you move higher up, you need to think differently. That perhaps you need to have these as chronic illness centers. And I think that has guided us even up to now with what we are doing. We want to leverage on technology that is coming in because we know the experience that people have gathered over many years goes with them. And I learned that the art of transferring that information into the computer so that it has AI assists the first frontline healthcare worker. So as we move towards digitization, then the many years of experience will be available also to the lower level people who are frontline healthcare workers. So we commit as counties to do our part so that the whole country succeeds in integration and ensuring that the gains that have been we already had are not lost. I would speak so much about all the health system strengthening blocks, but that I will leave it for the reason that we're here today for the next 2 days in the discussions. Thank you very much, and with those few remarks, it is now my honor and pleasure to welcome our DG, Dr. Amoth, who is also a gynecologist and surgeon. Karibu.
Thanks, Greg. Our colleagues from the counties, led by the chair of the CEC caucus, the county directors caucus, the county chief officers caucus, adolescents who represent nearly a quarter of our population, the distinguished delegates from the Republic of Uganda. I am glad that at least we have a sister country represented in this gathering. Our development partners, colleagues from the Ministry of Health, sponsors of this key event, and the communities that we serve, ladies and gentlemen, good afternoon. First of all, I want to start by apologizing for not being able to take my earlier role in the program because of exigency of work. And that was delegated to Dr. Mulwa, who says he's shorter than me, but he's still growing, so he'll catch up by the time he hits my age. And thank you for doing a good job in terms of representing me. This is a very exciting moment. As much as we live in difficult times, we know what is happening in the global financing ecosystem. We are back to the days of nationalism. We all know what is happening in the Middle East. Crude oil has breached the $100 price per barrel in the past, a price that has not been seen in the past 5-6 years. And all those events have a bearing on our health architecture. And therefore, we need to be able to have this conversation in line with the Accra reset of health sovereignty. We are saying as a people of the great continent of Africa that this is like a second wave of independence for us, where we can be able to plan our interventions and then implement them with our own domestic resources. And one way of doing that, to be able to get clinical effectiveness and cost effectiveness of our processes, then integration is key. The days of doing things in silos, of course, is long gone. That is the reality, and that is why we're here. And it's also a difficult moment, but also a great opportunity for us to be able to do things a little bit differently. So we are shifting our global financing landscape, then integration becomes key. And our discussion here then forms the foundation for the integration of the rest of healthcare services. We'll not have another summit for integration of malaria or TB. We'll use this as a plank to be able to integrate the rest of healthcare services. And I was discussing with Dr. Mulo, and he was telling me initially we expected about 500 people to be in this gathering. We have registered more than 700. That tells you the enthusiasm about this entire process. And I want to applaud the audience for that engagement in this process. The HIV program has served as a very critical program in delivery of healthcare services in our country. And a lot of lessons that we have learned from the HIV program are the ones that we have scaled to be able to deliver better healthcare services to our people, including the discussion that has just taken place here about digitization of our health systems. And again, it's very exciting because it's only 2 weeks ago we hosted the entire top leadership of the Ministry of Health of the Republic of Ghana, who came here led by their minister. And the minister in person spent an entire 6 hours at the Shah building having detailed discussions with the teams from DHA and Social Health Authority to see what they can be able to learn. And we moved together along the Africa Union Agenda 2063. Before that, we also had a delegation from the Republic of Malawi, who was led by the Permanent Secretary for Health, also coming to be able to share experiences. So it is indeed a very exciting moment for South-to-South learning. The national government will continue to steward the process of policy formulation, development of strategies and guidelines, while the counties who are represented here in their entirety will continue to run the role of ensuring implementation. And therefore, this is now us working together as expected of the creators of our Constitution. There are 2 levels of government are distinct yet interdependent and should be able to function through consultation and cooperation. We also now, this is a time for us to be able to have a honest discussion with our development partners to see that when we develop our plans, we develop them, we co-create together. Because in this era, we need to be able to do more with less because of that dwindling resource envelope, but also to be able to do less with less. Less with less meaning that we need to prioritize. We don't just have to implement because we have implemented before, but we must have evidence that whatever is implementing is impacting population health. And as a country, our journey towards universal health coverage is premised on primary health care. And why primary health care? Because primary health care systems tend to be integrated. They tend to offer comprehensive services. They promote inclusivity and equity. And therefore, the landmark laws that we passed in 2023, which enshrined the Primary Health Care Fund as one of the 3 funds in Social Health Authority, to be able to ensure that resources reach the very lowest level of our healthcare system. We all know the investment we have made in the community health systems in terms of the community health promoters, and the kind of data that is coming from the CHPs through the electronic community health system. In fact, the discussion that just took place here a few minutes ago is one of the pivots that we want to use to move as a country from the periodic surveys that we do to real-time data for real-time decision making. If we can be able to digitize our processes through our health facilities, we will not need to wait for 5 years for the Kenya Demographic Health Survey to know what our maternal mortality rate is, to know what our child mortality rate is, to know what our rate of stunting is, or to know knowledge of HIV spread amongst adolescents. So we'll be able to have this information real time for decision making. And that is why it is a very exciting moment for us in the health space at this particular time. But now that we have the greatest ingredient for universal health coverage, which is political commitment. We really feel proud and excited when we hear the top leadership of the country talking about ending AIDS by 2027, ending preventable maternal newborn deaths, ending TB, name it. So we are really privileged at this particular time that we have that kind of leadership which is prioritizing health for the development of our country. The private sector, of course, will continue to play a critical role and in terms of development of innovations. But now we appeal to the private sector to be able to develop innovations that can serve multiple facets of the requirement of a health system. If you have a diagnostic platform, let's not have a diagnostic platform that will only diagnose one condition. Let's have a platform that can be able to diagnose literally anything and everything on planet Earth so that we can be prepared for anything that the challenges that will be thrown at us as a people. We will continue, of course, to be able to partner with the private sector because health service delivery in this country is nearly 50% provided by public health facilities. The other 50% is provided by the private and faith-based facilities. And we acknowledge the private sector because of their agility in terms of turning around innovations, adapting technology quickly, and we'll also be able to learn from them. And I think that is why we said, and I want to repeat the words of Madam Kambasam who was here, that is why we created the health information exchange, so that we don't interfere with whatever system that you have, but you can be able to plug in so that you can be able to speak to each other. So that our health information exchange is a kind of a universal language that is understood by all and sundry. I know you are going to have this, continue your discussions for the next 2 days, and you'll go into various thematic areas where we are going to take a deep dive into the issues. I want to remind you that we are not going to have another integration summit for anything, so you must be able to do a good job so that whatever comes out of this gathering then becomes the blueprint for integration of all healthcare services. For a long time, we have talked about integration, but we used to talk about integration when resources are available. Now, nature has pushed us to the wall because of the changing financing landscape, and for now, we don't have an option. I believe what Dr. Ganda says is not about if, it is how to go about it. Now, out of this gathering, then we should be able to come up with a document that can clearly give us the roadmap as to how to integrate our healthcare services going forward. Again, this discussion is also taking place when we are also reviewing the benefit package in alignment with the Social Health Authority laws, that we need to be able to review the health benefit package every 2 years. And the process of the health benefits package tariffs advisory panel review has commenced. I know because I sit in that committee that NEFAC had submitted a proposal, and the BP TAP team had a discussion with them as to how to be able to integrate HIV services into the soon to be launched benefit package that hopefully will have out in the month of October. So this discussion then becomes very, very critical because it lays the foundation for what will be in the benefit package to be administered for the next 2 years before the next review. So the journey towards universal health coverage is critical, and integration is part of that journey along all the facets of health service delivery. And therefore, I want to wish all of us very fruitful deliberations for the next 2 days. And we look forward to a solid document coming out of this engagement that will be able to inform our policy as to how we are going to deliver better for Wanjiku. Thank you very much. To our Muslim brothers, Ramadan Kareem, Saum Makbul. Thank you.
Yeah, thank you so much, DG, for the wonderful encouragement and the next steps that you have highlighted for the country. I want to request our only international guest to come and appreciate our DG. Let's give her a round of applause as she comes.
I was ambushed, but thank you very much. I would like to let's allow the pleasantries to happen. So please join me in thanking, today I'm going to call him our DG, so I'm privileged to have met you, DG. And soon we'll be inviting you to Uganda for a DG's forum. So I'm going to, because we're organizing it. So join me, we are going to pick flowers, this time not from the gardens of Kenya, but from the gardens of Uganda. So we're going to stretch and pick the beautiful roses from Eastern Uganda, Western Uganda, Northern and Southern Uganda. Let's put them together. Let's get a ribbon and let's throw them to our DG. Thank you very much. Thank you.
Yeah, thank you a lot for that. And we want to transition to the next step of breaking out to the breakout rooms. I just want guidance from the IT team. If that is ready, we want to give that guidance. After that, we will also be able to break for lunch after the breakout rooms. So we have a total of 6 breakout rooms with each having thematic areas handled. We are having the first one. Can you help me with this one? The front screen. Okay, so we have breakout room 1, which is integrating HIV prevention and treatment, TB, NCD, and mental health. That is going to be in Echo Ballroom here, the main hall where we are. Dr. Lazarus Momanyi and Dr. Yvette will be taking charge of that. We have breakout room 2 integrating HIV, RAMCA, malaria, EVT, viral hepatitis, STI into PHC. That will take place in Arabuko 1, the first floor where we had our first session on day 1. Breakout room 3 is facility-wide EMR and interoperability digital solution for continuity of care, referral and epidemic preparedness. That will take place in Arabuko in Selfish. It is selfish or selfish or selfish? Selfish, yeah? That will be next to hotel reception area, and Dr. Lily Nyaga will help us there together with Dr. Jacob. We have breakout room 5, where there is leadership and governance, health financing, in Shimba Hall, just next to the main reception here in the next building. I will have here. That is the 4th. I skipped 4. That will be breakout room 5, Rachel Keuna and Dr. Patrick. To the fourth is Integrated Health Workforce for Service Delivery and Communities. We'll have Arabuko 2, also in the first floor, on the first floor, taken care of by Dr. Kenneth Masamaro and Dr. Pius Mutuku. Then the last breakout room is for empowered communities at Mantarai Room. Mantarai Room is towards the registration area. We will be led by Margaret Ndumbi and Dr. Janice. Please take note of the area of interest, but we also encourage that we don't flock one particular breakout room so that we are well guided in terms of which rooms we need to break to. Prior to that, I want us to look at how are we going to score the oral presentations. There are 5 oral presentations in each room, and we will have participants in those rooms using Mentimeter to score the presentations in this manner. The first criteria is relevance to the theme. It has to be aligned to health without barriers for holistic HIV response. The second criteria is innovation and originality. Should not be something that is already going on in other counties or in Kenya. It needs to be new idea. Good presentation skills of the one who will be delivering that presentation. We will have those done within the breakout rooms. Please don't vote here. Go vote in Arabuko and go vote somewhere else. You vote wherever you are to make sure that we don't go into problems with counting the votes. Next. After that, we want to evaluate the morning sessions digitally, and we will have a QRS code displayed for all participants to partake that exercise. So IT team, please take out your mobile phones, check if you have internet, and then have this evaluation done. For session 10, the first one, which is leveraging on a point of care platform to scale up viral load HIV testing in Kenya, that was the first one. You have a number of questions to score against. Then the second session is on expert speaker service delivery without silos. Panel discussion on HIV, TB, malaria, EVT, mental health, RAMCA, PHC integration, and then the panel that we've just had. We are giving 3 more minutes. Anyone having challenges, please? It's me. Are we okay with the QRS code? Okay, could it be too far for other phones? Okay, please zoom out, zoom in a bit. Zoom in a bit for yes. Two minutes left. I think we have some challenges with the QR code. Yeah. Okay. The IT team, I think we are encountering some challenges with the QR code because we only have 290 people who have joined. Yeah, take me back to the slide for breakout rooms. We are coming back after 1 hour. After 1 hour of meeting in the breakout rooms, we'll go for lunch, and then we will come back at 3 to continue with the sessions. Okay. Please display the breakout rooms again for people to see. Okay. If you have challenges knowing where they are, we have the team here that will be able to direct. But those who are having challenges with evaluation, feel free to get to the desk, the technical desk behind, and be able to get assistance. We will be reconverging in the main hall at 3 p.m. Thank you.
Appreciation for the chance to make this presentation. I'll make it online. I would have loved to be in Mombasa definitely, but due to other competing tasks, I'm unable to join. And as presented by Lazarus and Dr. Rose, the Minister of Health, and I'm happy to share with you some of the works that we're doing while I'm in. Just showing that I'm still a very busy person in terms of integration. My presentation is on stakeholder perspectives on the integration agenda. And as the first picture shows, I'm hoping it's a cover picture. It's really about those stakeholders, you know, the people, whether it's the communities, the partners, the counties, the programs, the ministry. And this is just a reminder that we started this journey in 2024 and we still continue together. Next slide, which is an introductory slide. Moving us to the answers.
Yes, you're on the introduction, the overview, the study overview.
Okay. So this study was one of questions of how should it be was consider prioritization and synergy of resources to, we may not be able to deal with everything, but prioritization and synergy is important. Very strong feelings around embedding these integration and HIV into the UHC reforms, including in FIF and SHA. But also some ideas around engaging non-traditional actors were given. So I'll just pick one or two. One statement that was really interesting is that it is not integrated if funding continues as is. Let everyone bring money into one basket and let HIV be fully managed under UHC so that we can say we are integrated. And second is commodity assurance. I think one of the comments that came out again around financing is that people have clear minds around, prioritization. As one of the county officials mentions, HRH capacity building in terms of numbers and skills, EMR, commodity security are the main cost drivers and critical issues to think about integration when you're talking about financing. So it's while resources are few, people have feelings around how further future resources should be managed and shared. Next slide. So there was a question around ownership and acceptability. And this question was really interesting for me because it was happening, remember the study was in March, it was happening just after the stop work order and the massive, reorganization of the financing mechanisms, and conversations were really ripe. And so what we were getting at that time was the, immediate feelings and experiences that people had. And what was clear is that there's a bit of resistance from healthcare workers, but it's driven by the workload, but also skills gap. Patients had concerns, or clients, there were concerns of stigma, confidentiality. But what was also interesting is that patients noted that healthcare workers lacked in the broader space wherever they were sent, where there was no capacity, they would like the correct knowledge around HIV. And so also they felt there was a one size fit all, and that was a big concern. On further conversations with the implementers and civil society, there's a perceived loss of relevance, also loss of resources with no alternative options. And of course, exploring further what would have made a difference is issues of staff training, mentorship. Multi-month dispensing was felt to have been a good practice, merging clinics with privacy, alternative finding, and also sustained engagement and engagement with the stakeholders. So I think I just want to pick a few statements. Someone says kind of like, surrender. We can't fight integration because its time has come, but we need to make it fair and ensure quality and confidentiality. Maybe a guidance on how to practically integrate would be good. Also address the loss of livelihoods for the key populations here. How can we still get funding if we integrate? This is the biggest concern from my constituency. Then another person mentioned PLHIV internalized stigma. Moving from an island of executive treatment informs resistance by clients. The fear of what if it fails is real for us as programmers. So far, all is well, although focus on quality and transfer of good practices from HIV to main service delivery will make it easy. So as you can see, the issue is not really integration, it's some fears that people hold, and maybe the space to speak about them and also to see them, thought about as a conversation. Next slide. So around leadership and coordination, repeatedly what came out is that there's lack of clear integration policies and guidelines. And also stakeholders felt that actions around integration are happening ad hoc, either due to sudden donor exits, but not really as a strategy that has, is sustained beyond. And there's a lack of clarity and accountability. So what people actually were expecting is a stronger GOK leadership, national and county, defining scope and accountability, and also indicators. It was very clear that people don't know what would be the measure. And then realignment of structures to facilitate integration. People expected dedicated funding, and also felt that it should not be just HIV, but also have NCD as a partner to move with. So the next slide, Lazarus, I'm being very fast. There's one very interesting statement that I picked. We had a push and pull where some partners and facilities pushing to go back to standalone. However, as a county management, we have reinforced our guidance and mentorship, insisting that we adapt this. We have to keep communicating and reinforcing. So just showing that at leadership and coordination level, there's really also some work of conversations to happen. So next slide. Really, in short, what kept coming up back as in all the conversations was government, please lead, guide, communicate, engage, monitor. So that was last year. I don't know how it's looking, but also issue of prioritizing health workforce, health information system, and commodities. It is very clear that even as we go through integration, the issue of not having a one-size-fits-all, especially looking at different facilities and what is feasible, but also population by population consideration, a deep concern, and maybe data can support that maybe some population can be supported in a certain way and others differently, but definitely there are concerns. But the last thing that I actually picked that I felt is important in this discussion is not to gloss over losses that come with integration. There is very clear need for honest navigation and honest discussion because stakeholders had also some ideas. So in summary, what I found is that stakeholders feel that integration, while inevitable, is currently challenged by inadequate dedicated funding. There is weak leadership and policy clarity. Even as people speak, people are not clear what exactly are we talking about, and there's a mixed acceptability. Success would need policy and financial commitment, but ground level innovations. It's very clear that strong county and facility capacity makes a big difference rather than just high level discussions. Inclusive planning, monitoring, and feedback would be critical just to understand how the decisions are making a difference. I picked that acceptability could be enhanced by addressing, specifically define what is it we want to achieve maybe in this year or the next year, including patient outcomes that we want to see. That may might chew what people then understand because there's all over fear of everything. I think we also need, as mentioned, to address power shifts and perceived losses. They are real, and then financing of it will make a difference. So my own reflection as a last slide is that HIV integration into the broader health system requires bidirectional culture change. It's important that we don't just think it's about HIV. HIV has something good to bring on board, but the system that we're bringing on board may also have something good, but also something to learn. So how we foster that will be very helpful. The second reflection is that, as much as we are talking, maybe people are interpreting integration in different ways. And it might be good to have clarity on that, put finances in what we want, and then help people shift their mindset. I think within our complex country health system, national, county, partners, civil society, communities, it would be good to consider, collaborative conversation, recognizing good that is in both sides, communication, trust, and co-designing solutions without necessarily assuming that what is happening in one place may work in another place, may make a big difference. These are just my personal reflection. I think the last slide is just to acknowledge a big thanks to, as mentioned, it was a Kofi Annan supported work, Africa Center of Disease Control, the mentors, coaches, Minister of Health. I did get a lot of support from the DG's office and the partners on the ground in the county government teams. We also had communities, PLHIV, participating in this. I had support from my cohort, colleagues, and my family and friends. And the KII specifically was funded by Randian's pharmaceutical company that I appreciate so much. Asanteni sana. I have tried to rush. Hopefully, I've not taken forever. Asanteni. Thank you.
and treatment, and they have any other problem, they were supposed to be referred to the outpatient, and that is how we used to lose most of the clients because they will not go and start queuing at the outpatient department. So these clinics were almost at 100% donor funded from the human resource, the service delivery, the monitoring and evaluation, medical supplies. We were depending on donor funding. Level 3A, Chani, has a coverage of 30,000 target population. We serve outpatient service. We offer outpatient services with a 24-hour maternity service and a recipient of care of 445. So in January 2025, when there was the stop work order, there was a disruption of service delivery. The HIV service delivery came to a standstill because now there were no service providers, there were no supply of commodities, there was no resources at all. And we can see when there are challenges in documentation, especially in the Kenya EMR, because historically we know that only the people who give HIV care and management are the ones who are conversant with the Kenya EMR. So when we had to go home, the Kenya EMR also came to a standstill. In response to this, the facility we had to think and see, as we go home, what is going to happen to these recipients of care? As much as we may also want to keep our jobs, but we also need to take care of these people who are receiving HIV management. From March, therefore, we had to do something, and we started with the stakeholder engagement. We developed a task force that included the county, the sub-county health management team, the facility management, the recipients of care themselves, the MOH staff, and then we developed a roadmap with key deliverables. We had through the CQI approach, we had to know what is it that we can do so that our recipients of care will continue receiving HIV care and management. So we came up with the challenges and prioritized our interventions. Through one, we did now this is from June, we did the capacity building to healthcare workers. We had to do regular continuous medical educations, regular on-job skill transfer, which was specifically focusing on prevention, treatment, and integrated service delivery, prevention of HIV. And we also did the digital health sensitization. We see that the people who are working at the CCC then were really conversant with the Kenya EMR, which serves the care and treatment service delivery. But we did not have any idea about the Tibabu for the Social Health Authority. So the transfer of skills was both for the outpatient service providers and the CCC service providers. They were teaching us on Tibabu as we gave them information on the Kenya EMR. We also had to strengthen the differentiated service delivery models for the stable clients through the CADIP, CASHA, so that we could also reduce the people who come for HIV management. This is how integration looks like at Chani. You can see here, we integrated staff. Previously, even the CCC clinicians were never included on the duty rota. I think because the service delivery point was already isolated, even the clinicians were isolated the other side. So after integration, now we have a unified duty rota that includes both the partner staff and the county staff. For the patients, we had to redesign the flow of patients at the outpatient service delivery points, as you can see. The pharmacy and laboratory, before then, we were doing our reports, our HIV commodity reports at the CCC and forwarding them to the sub-county. We also had a very separate pharmacy store for the
ART commodities, but now after integration, all reports are done at the same pharmacy level. We also share a pharmacy with the outpatient department. Laboratory services have also been integrated at our facility. We can also see there is comprehensive service and unified client flow at the outpatient. So these are the results of our integration. We can see in the first photo, this is a CME that was going on for the healthcare workers and on-job skills transfer. And this one has really helped us to enhance knowledge in offering comprehensive care to all our recipients of care. Initially, we had only 2 clinicians who were able to give comprehensive services to the recipients of care, but now we have increased from 2 to 7 after the continuous medical educations. Here we have holistic management of every patient, improved patient outcomes. Currently, we even share the waiting bay with every patient, so you cannot say this is an HIV positive patient and this one is an outpatient, a general population. We are now reducing stigma to that level. Resources have improved. We have HRH and improvement with the task shifting. There is improvement in the use of infrastructure. We can now see our beautiful outpatient center with the consultation rooms, which are now serving both the recipients of care and the outpatient department with a similar triage. So now when any person walks to the facility for any services, they'll pass through the customer care desk, they'll be triaged, all of them, before they proceed to the outpatient rooms for clinical services. We also have a comprehensive service delivery that is uninterrupted. Like if the stop work order came today, we are sure and comfortable to say that our recipients of care are going to continue receiving wholesome services without the stop. We have learned some lessons through the process. One, stakeholder engagement with strong leadership is very critical in driving change across all departments. It has played a big role in our structural adjustments and our resource allocations. We've also learned that trainings and capacity building, early trainings or continuous training and capacity building to staff, it helps even in building confidence among the clinicians, especially those who are not specialized in HIV care. Integrated records, you can see all are being documented in the facility-wide DMR as we continue integrating the services. We have also seen that both the clinical teams and patients have experienced reduced stigma as focus changes from disease-specific to comprehensive care. Originally, they will go to a very separate room. Everyone will know that this one has come for care and HIV management. But as we continue sharing our outpatient space, someone will come and they will receive all their services without stigma. The challenges, as I wind up, we have multiple EMRs that increase workload to healthcare workers. Someone can come, a client can come for management, and you'll have to, if they are coming for care and treatment, you'll have to use the Kenya EMR, which is specific. If you have to use Tibabu for the outpatient department or SHA, you have to use TB Lite to screen or to do TB management. So all these EMRs for one client really increase the workload to the healthcare worker. This here, as you can see, this is our pharmacy. There is no patient privacy so far. One-stop shop doesn't provide privacy and confidentiality. Meanwhile, we cannot dispense ART in our pharmacy because of the open space. So maybe with the resources, we can get a pharmacy booth for privacy. And then the resistance and stigma from maybe the healthcare workers or the clients themselves, they feel stigmatized. This is also a process that with continuous medical education, it can go out slowly. So our recommendations are the stakeholder engagements should be early and continuous. And the healthcare integration and capacity building should also be a continuous process so that everyone will get enough information and give services according to what any client deserves. We are also learning to really integrate those clients who are stable, the ART models, the CASHA, the CADIP, and the parcel delivery, so that we also reduce the number of clients that are coming for the services. Thank you so much. I really want to appreciate you all.
Thank you, Dorothy. A minute above the timing, but apologies for hurrying you up. I think those were very good insights. So next from Mombasa, we are going to listen to Kisumu County from Dr. David. You have 10 minutes. Please keep your questions. We'll be able to take them after the presentations. Your 10 minutes start now.
Good afternoon, everyone. My name is Dr. Kwom David from Kisumu, County Government of Kisumu, that is. I currently manage the hospital, the medical superintendent, and I also lead the primary care network as the team lead. So my presentation will be covering majorly on the operationalization or at the operational level, or how to implement integration, and we're going to learn together what we've done and how the journey has been. The journey I'm going to be describing here has started in 2023, and most of the report covers up to 2025. Of course, we're in 2026. A few updates in between. So you could see in the map, Moroni County Hospital is in Kisumu County, next to the lake, the red dot on the map. We serve a catchment population of 18,469. We offer 24-hour services. Workload monthly is about 1,600. And as of March of 2026, we had a TXCA of 1,112. VL uptake is at 81%, and suppression at 93%. That is our clients with less than 200 copies. Now, when we, as a management team of the hospital, thought about integration, first, it's important always to have the problem defined accurately. So these were the issues that as a management, and of course, this started high level at the county, and then sub-county team, who are lucky at this time, we're also working together with CHEB Kenya, and of course, our CASCO and sub-county coordinators. So what were the main issues? Standalone and partner-supported CCC model, which was a whole structure on its own. Most of the health system functions when running in parallel, the HRH, management for partner-supported staff, was completely separate from the main MOH HRH management protocols. In terms of supplies, again, for CCC wing, it was purely supported by the partner. That means when ART commodities came in, they were received directly by, then we had a unit manager at the CCC. So as a facility, we sat together and said we need to change some of these things. And these were our objectives: to normalize HIV care within the OPD, or the general outpatient department, reduce the stigma, increase uptake of comprehensive primary care services. Now, our integration journey, or the model we chose, is a mixed model. That means we had a little bit of one-stop shop. We had a little bit of the critical care, or chronic and critical care. And being that we are a primary care referral facility, and we work within a primary care network, we looked at it that we'll need to take care of the other lower level facilities. This is a level 4 facility, but acts as a hub for several spokes, which are mostly level 1, level 2, level 1 being the community, level 2, level 3, and of course, some other faith-based and private facilities. So what was done? We did a concept called reorganization, and when you think about reorganization, really is just trying to look at the structures, look at the processes, and look at the most efficient way to deliver this kind of service that we wanted to do. What was the approach? It was based on the quality improvement. And even from the presenters that have been here before, whenever you talk about quality, there are 3 things that you have to take into account. The first one is the structures.
So when we were thinking about reorganization, we had to think about the structures. How are we going to ensure that the new structural arrangements serve the clients the best or the best way? When talk about quality again, you have to look into the issue of processes. The processes here majorly is how do we comply with the clinical guidelines? How are we ensuring that we are using the latest information that's outside there to take care of several diseases, not just HIV, maternal care, being that again, we are primary care referral facility offering comprehensive primary care services. So reorganization here took into consideration the structural issues I've talked about, and you'll see some of the changes we had. The processes, that means we had to find a way to integrate these clinical care pathways. Human resource, again, we had those clinical officers and medical officers who were attached purely to the CCC department who had to be moved to serve the general public or the general patients coming to the OPD. What did we achieve with this reorganization concept? Again, I tried to compress my presentation to be in a way that those other level 4 facilities would also be undertaking this journey of integration could replicate what we've done and maybe get similar results or even better results from this. I have to mention that we've received several counties coming to benchmark with Kisumu County and our facility. The latest was Migori County, who joined us last week. And whenever these facilities come around or these counties come to benchmark, we also learn with them because we open our system for scrutiny and we allow you to go through the care processes and explain to us those areas that you think we are not serving our patient best. Throughout this summit, most speakers have mentioned the importance of considering the patient, and I think it is quite, it is something that all of us must think about. Whenever you think of quality, the first thing that comes to your mind is the person you are serving. Are you really serving their needs? So as a facility, that is the center point that ensure that this integration happens. So these are some of the results. HIV services integrated into general OPD. We adopted facility-wide Kenya EMR, now Taifa Care. And this actually isn't the merger in terms of clinical care pathways, which is part of the processes. Then we had unified staff reporting. This is part of reorganization because the command structure of the hospital was realigned so that we have the heads of departments, heads of units, and then of course up to the medical superintendent with the key oversight of the board, which is part of the community, because the board members are appointed from the community so they can give us that insight. Now, we have also managed to integrate vertically the level 1, that is the community, through the CHPs, mentor mothers, and other community-based organizations to try to listen to them. We have quarterly what we call is an assessment done by the what's called community health committees, who the secretary is the community health assistant, who also sits in the HMT. So this way we're able to integrate the flow from level 1 to the level 2, level 3, because again, as the medical superintendent, I still sit at the PCN to ensure that we cover the whole primary care network, formerly the sub-counties. So this is in terms of pictorial what we've done. You could see this is the general OPD workload, 2023, 2024, 2025. You can see a bit of a shift in 2025, the one that is in orange. Sorry if the color is not orange, but brown. This is in terms of viral suppression. So you can see in 2023, there was a little of a dip in 2024, and that is when we were at the apex of the integration, but it has peaked, and as we move towards 2025, you can see most of those indicators going up, with adolescents having 100% suppression. Of course, you can see there's a little bit of a problem with 10 to 19, but something that we are working together with the CASCO and the county team. Other success stories, improved management of HRH, I've already talked about this. We reduced the waiting time or turnaround time for most of our services, improved workflow balance, and one that I have to mention is healthcare financing, which has helped us do a lot, procure health products and commodities. The viral loads, we are able to procure them locally, not having to wait for partners to get this in. We've managed to clear most of our bids, and I will explain how this was done. And our primary care network are able to take care of those other facilities that may not be receiving much of a reimbursements from the Social Health Authority. In terms of finance, I would really take my time, a little time on this. You can see on the left-hand side is quantity, sorry. We've managed to improve that revenue from a budget of 5 million before we started to a budget of about 35 million within 24 months or so. In terms of quality, and what I wanted to pick on this side is the difference between the user fee, which is out-of-pocket expenditure, and health insurance. You look at the bar on the left, you could see it was almost 40% health insurance, 50% out of pocket. Look at after integration, almost 90% is health insurance. That means out of 10 patients, 9 of them, or 9 of our clients are using health insurance. Lesson learned, addressing stigma, staff morale, and data-driven management. Of course, you have to convert data to information, and we really thank TaivaCare and the DHA, the work that they are doing. I know my time is almost up, but I would like to show you a little of the pictorials. We had a standalone CCC, which now has been moved to the outpatient department. The structure is still being used for several other purposes within the hospital. Lastly, because of the improved reimbursement from SHA, we've managed to do a lot of structural inputs that are still ongoing, renovation of ward, creating of new patient-centered centers within the facility. I want to thank you all and receive greetings from Kisumu.
Thank you so much, Daktari. Looks like integration is working, and so is SHA at Muhoroni. So allow me to introduce the next speaker, but as I do that, we are going to break exactly at 2 to allow us to have lunch from then. So presenters, bear with me, I will be a bit tough on you. I want to introduce Dr. Sharon Kimani from Nakuru County, and as she comes, one of the questions that we'll be asking the presenters, it's very good to see the HIV services uptake and quality. We are also asking what is happening to the NCD services. Do we have any idea of what that is happening on ground? Kimani, karibu.
Hello. Hello, everyone. How are we doing? Okay, my name is Dr. Sharon Kimani. I am the medical officer in charge and AHT focal person, Nakuru County Referral and Teaching Hospital. Now, the month was January 2025. And we were called into a training meeting, and we were excited to get our CPD points, our per diem, and our free lunch. And that is when it was dropped on us like a joke. From today henceforth, there will be no more CCC services in our facility. Shocked. We asked, what do you mean? And they said, from today henceforth, let me clarify, you will all now be CCC. Sawa? So that is how, just like a rug pulled from out of us, the CCC review that we've been writing in the wards was pulled from beneath us. And us healthcare workers were now the primary decision makers for our clients. Scary. But still, we still got our free lunch. And that is how we, we started integrating HIV services at the Nakuru County Referral and Teaching Hospital. And as a survivor of that scary reality, I have come to share our experiences and lessons in advanced HIV disease management in a retrospective analysis of service integration over the last 14 months. So, who of us can help us with the definition of AHD, advanced HIV disease? Just name one thing. Anybody? Yes? Below 200, well done. Somebody else, one more? Yes? Children who are below the age of 5 years. One more? Anybody else? Yes? Thank you for clarifying that. Hey, we've got qualified, very educated people with us. Isn't that amazing? Now, AHD is a cause of morbidity and mortality for our HIV clients. And we have a case of healthcare workers who are over-dependent on CCCs because we just write CCC review and then we're in the middle of a pandagram shift, where there's no longer CCC services and they are being made the chief decision makers for these patients. That is a very scary reality. So in our county hospital, we were hoping to do just a very brief study to see whether or not this is possible, whether or not we were dreaming too much with this. We did this by taking a look at our program data. We took a look at our AHD data, and we also did that over a 14-month period. Our key focus areas, number one was service delivery. Were we able to deliver these services to our patients? Number two, it was our patient outcome assessments. And number three, integration facilitators and the lessons for scale up. Now, our strategic goals were three. Number one, we wanted to demonstrate integration advantages at a high level, level 5 facility. This was going to be demonstrated by service efficacy, by resource optimization, and by patient flow. Number two, we wanted to identify our key facilitators. And number three, we wanted to determine the effect on our patient outcomes. This will be determined by mortality reduction, discharge rates, and quality of care. Basically, the question we were asking is, are our patients safe in our hands? Now, that sounds like very amazing theory, right? But how did we implement this on the ground? Sasa daktari, kwa ground, how was it, So the first thing that happened was capacity building. So we were benefited by the healthcare worker training that was underwent by NASCOP and CHAI and our South Rift Valley Technical Working Group. We also integrated the services into our daily ward care. We had our AHD CMEs that were happening on a monthly basis, and we also had ongoing mentorship programs that were continuing. Now, in the midst of our integration of services and our healthcare worker training, we stand before Dr. Nyelech and we're like, hey, Daktari, the qualification of AHD, part of the definitions is a CD4 count, less than 200. But in our facility, the last time we saw a CD4 count was 6 months ago. They said, don't worry, we are going to strengthen the lab by ensuring that there are CD4 count, there were CD4 count machines as well as reagents present in our facility. And they said, we know you'll ask about the reflex crag. We are bringing those strips on board as well, so that your lab is strengthened to take care of your AHD patients. And we stood before Daktari again and we're like, Daktari, so the CD4 count is less than 200. We have done our reflex crag and it is positive. We've done our CSF crag and it is positive. But from timely memorial, we only have 3 ways in which we manage our cryptococcal meningitis patients. Number 1, fluconazole. Number 2, amphotericin B deoxycholate. And if the patient looks very bad, prayer. Now, you have brought very amazing guidelines, but how are we going to apply those on the ground? They said, don't worry, Daktari. We are going to strengthen and secure your pharmacy by ensuring that there is a flucytosine supply, ensuring that we're bringing liposomal amphotericin B, and we're also going to ensure that fluconazole is in good supply. So we're securing your pharmacy, so therefore your guidelines can be applied in your facility. And the other 2 pillars include patient ID and data. An AHD focal person was identified, yours truly, as well as a tracker system which was updated. And finally, there was governance and care within our AHD management. So what was the outcome? Were our patients safe? Well, first and foremost, we were able to get amazing demographics and monthly trends. I won't belabor on this point because they heavily reflect what is reported nationally, which includes a majority of our patients were female, actually 61% of our patients, and followed by males at 39%. We also had an age distribution between 30 to 50 years. In our monthly patient trends and outcomes, we saw that there was, number one, a very consistent high level of admissions of our AHD cases, but also there was a consistent high level of discharges of our AHD patients in the age of integration. Now, this is what I would call my money shot, because this is what really shows the impact assessment. We had a dramatic mortality reduction amongst our AHD cases in our facilities from a baseline in 2023 of 50%. And let me explain what that 50% means. That if 2 AHD clients come into our facility, one is being discharged vertically and the other one horizontally. I hope you understand what I mean. All the way to 2025, when we are having a 14% mortality rate. That is a 36% mortality reduction. I think that deserves a round of applause, eh? Beyond that, we had improved opportunistic infection detection. So no shocker there that pulmonary TB was the #1 OI that we had with our patients, followed by diarrheal illness, followed by cryptococcal meningitis. We are also very happy and proud to report our discharge rate. We had a discharge rate of 74%. That means that our patients had improved treatment adherence. They also had better care coordination and enhanced patient support. So what was the training impact? #1, there was reduced TOT in decision making. Because healthcare workers were empowered, they were able to make better decisions quicker for our patients. The second impact was there were guideline-based care. If you walk into any one of my Nyayo wards, you will be able to see the guidelines, you will see the patient plan, and you will see that they match up. Now, with every single, this slide I won't belabor on, but basically we were able to uptake our lab as well as pharmacy security. Everything that was brought to us, we used very, very diligently. Now, with every new endeavor, with every pioneering effort, there are challenges as well as implemented solutions. One of our challenges was the data collection burden. A single medical officer was managing up to 50 AHD patient records on a monthly basis. How did we, what solution did we create for that? Well, we created a forms sheet so that we were able to encompass more people in the data collection efforts. The second was there's a training and orientation gap. Every few months, interns would move. Every few months, MO is posted to a new station, and therefore there would be a gap in care. How did we deal with that? We added our AHD guidelines, a more concise and brief guidelines to our Nakuru County Referral and Teaching Hospital orientation package. #3, we celebrated our high discharges. Unfortunately, we also had a lot of readmissions, and we realized that that was because on our discharge summaries, patients were still being discharged through CCC. And remember, in January 2025, there was no more CCC. So basically, the patients were being discharged to the community. And how did we address that? We had more thorough and strategic discharge summary planning, ensuring linkage to care. And finally, we still have an ongoing challenge, which is the absence of essential staff, mainly our adherence counselors that we are hoping to come back. I'm on my final slide, which is #1, the knowledge that we have gained and the lessons that we have learned. #1, there was continuous healthcare worker empowerment. The continuous healthcare worker empowerment leads to better care for our patients. Number two, supply chain strengthening enables us to actually implement the guidelines at our facility level. The multi-partner collaboration, meaning that we cannot do this alone. All our partners, NASCOP, SHA, CHAI, RTWG, we are grateful for them because they made this possible, and that our AHD cascade actually works for our patients. So as I say, my last point, our AHD in Nakuru County, we endeavored to pioneer integration, and the question was, are we safe? Are our patients safe in the age of integration? Well, with the statistics like this, I think the answer to that question is yes, they are. Thank you.
Wow. You can give her a better clap, really, guys. Thank you so much. I promise people lunch at 2. And so Joshua, you have exactly 10 minutes starting now. Joshua is going to present something from Bungoma in Busia County. Your stopwatch, the countdown starts now. Slides. Move the slides. Okay, proceed. Starts now.
Yeah. Good afternoon, team. Yeah, my name is Joshua. We'll be presenting on continuous quality improvement and how it strengthens integrated people-centered chronic care. I think the team before me, what they were presenting is purely how continuous quality improvement has impacted quality of care among our clients. And for me, the definition for quality improvement using the Malawi definition of 1997 is doing the right thing right and doing it better in the subsequent time. So that is purely what we'll be talking about quality improvement. So as a country, as we move from the vertical HIV programming and now this one to just have the facility-wide integration of healthcare systems, HIV and the NCD all have same kind of challenges that we have been having across the different years. And as a team, we can for sure say that quality improvement has been having for a long time in HIV, and this has not been practiced well in the other NCDs. And now we want to scale up these quality improvement activities in HIV now towards the integrated service delivery within our facilities. This will help us to sustain adherence in treatment for our clients, as well as monitor regular follow-up as we see how do we adopt differentiated care facilities. Interruption in treatment among our clients, that is all HIV and NCD, has remained a challenge across board. And these are some of the challenges that we would like to address using this approach of quality improvement. As a program supporting the 2 counties in Western Kenya, that is Bungoma and Dumisha, we initiated integration in the last quarter, October, December 2024. However, we did a baseline assessment and our IIT rate for PL-HIV was at around 1.5, which is way above with 0.5 points against what the country expects. However, we were able to do exit interview and also interviewing clients engaging back to care, and we were able to establish and identify different reasons as to why clients have interruption in treatment. And these are some of the challenges that we were able to see. We have some barriers. These include geographical issues, transport. Some of our clients are way far from the facilities, or they are also not able to raise transport to come to our facilities to receive care. Including others, multiple appointments. For example, client with NCD is given multiple appointments for NCD and also HIV. A single client comes even 3 times in a month. For example, a PMTCT client who has hypertension They come for hypertension, later for NCD, for pregnancy, and also later for for CCC. So those are some of the challenges that we were able to establish within our facilities, and we wanted to try to see how best do we answer the question of why we are having this client having interruption in treatment, and how do we solve all these issues as a client come and receive a one-stop service within our facilities. Again, out of the analysis, we were able to establish that most of our clients who have interruption in treatment, this occurs mostly within the first 6 months on ART, and we were able to establish that case management allocation for cross follow-up within the first 6 months, very important for our clients, just to make sure that we're able to closely monitor them and retain them into care once they are stable to continue receiving care on their own. So what we focused on is strengthening and coordinating risk identification, just asking clients, what is the issue? Why didn't you manage to come to the clinic? And we were able to establish, for example, client coming and, for example, in our facility, coming to different SDPs to receive care, and we felt integration whereby individual clients receive all services within one SDP also would help these challenges. Differentiated service delivery, just to accommodate different clients with the different needs, just to make sure that they are able to receive the different care wherever they are. Appointment scheduling, and again, this one I have mentioned about client having multiple appointments within our facility. And we can for sure check the areas that we had parallel program monitoring. HIV has a very robust method of HIV monitoring in terms of data performance and tweaking where areas they are not performing. So those are the focus areas that we were able to focus on. And this is just to prevent interruption, particularly during high-risk periods, and for example, during December holidays, when our clients may be focusing on festive period and not interested much in their health. So those are some of the areas. So what are some of the results that we're able to see? Again, I have mentioned a reduction of IIT, which is a positive one, from 1.5% to 1% within the same review period for the year 2024 and 2025. We also had interruption of care going down, and that is the SIRA declined from 2% to around 1.7%, and those clients who are continuously interrupting treatment and coming back within the facility increasing from 26% to around 36%. So just a snapshot of few facilities that noted a decrease in terms of IIT. For Busia County Referral, which is in an urban setup and also within the borders of Uganda as well, you could see they're having a different problem, and we were able to do a different QI plan just to support, improve this reduction from 0.8% to around 2%. And for Port Victoria, which is border.
For the 2 days that I've been sitting here, I've been learning, I've been observing. Sometimes I've been missing out on some things. Why? Because there is not disability disability integration. So you're talking about integration of health and HIV. But how is it possible that you're talking about integration? For example, without access. For example, now we can see like maybe somebody has a wheelchair, but do you have access to disability friendly services? For example, like as a deaf person, how do I communicate? So what I understand is that when you're talking about disability, there has to be a lot of evidence. For example, how do you communicate? Because there are communication barriers there. For example, the non-communicable diseases. how, if you want to talk about non-communicable diseases, how many of those are people with disability? What is the percentage of people with disability? So I'm humbly requesting all of you, like even as you talk about funding, like the funding is dwindling, but we do not have evidence exactly to show people with disability, how many are they? Now, for example, now we are talking about, yes, good work, yeah, but you can see that there's a disability group that is already there. But you're forgetting, you know, like there are small aspects for people with disability. So disaggregating data specifically for people with disability.
Wow, thank you, and I'm very glad I took that question. That question goes to all the panelists, including Dr. Rose Wafula online. I hope you can be able to say something as we finalize. There is no other question. Dorothy, take it up. Depending on how people will be feeling, let's answer these ones first. I beg. Dorothy.
Okay, thank you. I wish to respond about integration of TB services. I didn't mention because actually we've not integrated TB services. We moved from the isolation building, yes, but we have a separate room for the TB management just to prevent the disease prevention. And then I wish to respond about the pharmacy. We are currently not dispensing ART at the pharmacy until we get a booth, which is in the process. Meanwhile, what we do, because we use the same store, in the morning, we take some commodities to every service delivery point, the outpatient services. So specifically for ART, after you have done with the client at the outpatient, you dispense the ART at that point. Thank you.
Thank you. Kimani?
So about the major causes of death, TB, pulmonary TB was not number one. Actually, it was extrapulmonary TB, which was specifically TB meningitis, followed by cryptococcal meningitis as well. We had a few cases of, I think we had a patient with toxoplasmosis as well, who had passed on, unfortunately. And we also had patients with diarrheal illness, which with severely immunocompromised states. We're talking about CD4 counts in the single digits, and with others underlying OIs. So pulmonary TB was the major opportunistic infection for our clientele that was admitted. However, it wasn't the number one cause of death.
Okay, so thank you so much. Our panelists are still around. The conference is not yet done, and we should be able to get something on the disability question from Dr. Laz as he summarizes. Thank you so much, and apologies for going above and beyond the time allocated. Laz.
All right. So let's give them a clap again. A nicer clap. I know guys are hungry, but a nicer clap, yeah? So before I think we're close to a wrap, I want to allow Dr. Rose Wafula, probably there was no specific question for you. I know you're still online. I'll give you maybe less than a minute to give a parting shot. Dr. Rose? Oh, she's off? Okay. You load it. All right. Yeah, so I think we want to bring this to a close. And first of all, I want to thank the presenters, yeah? You know, it's not easy to be able to do what. Let's clap for them again. We have had very nice presentations all the way from Mombasa, Muhoroni, Bungoma, Busia, and Nakuru, yeah? And I think we probably have the best presenter in this forum. Sindio, tumpigie makofi, yeah? We've heard about AHD, we've heard about health financing, we've heard about integration, we've heard about commodity systems, we've heard about service delivery flows, how we can be able to change them to be able to enhance integration, to actually improve outcomes. We've also heard about how we can use quality improvement approaches. And I think Dr. Rose Wafula shared about the study that she did around what were the views of the stakeholders about integration. So I think it's been a very fruitful session. I want to thank all of you as the audience for staying with us. I know that some of you didn't even take tea. You're yet to have lunch. and you were able to stay with us. So let's clap for ourselves also. Tuchipigie makofi. And I know that you still have some questions for the panelists. So those of you who can come to the front, you can have those questions. But otherwise, I really want to thank all of you for staying with us. It's been a very interactive session, very great lessons learned. And again, a round of applause for our presenters. Tuwapige makofi. Thank you so much. And I would like to bring and I want to remind you that there's is it loaded? All right, so as you go out, please scan a Mentimeter to rate the session and also the presentations that were done so that you can get your views. Thank you so much.
As you go for your lunch, there are those who have not been able to get their milk.
This beautiful lady is a pediatrician with over 23 years of experience in program leadership, academia. So you can read through her bio. And until she arrives, let's give a clap until she comes. Karibu Doc. Thank you.
Ladies and gentlemen, and all our guests today, good afternoon. Yeah, so as we wait for the other team members to come in, I think because of time, we'll start. Thank you so much, Dixon, for starting off our session, being our chair for this, our MC. And we want to turn and focus on one thing that is the pivot of the integrated health services. This session is going to be on the HRH realities, where we want to ensure that you are building, protecting, and financing a resilient, integrated health workforce for sustainability. Just a 1-minute story. I visited a health center in one of the interior places in Bungoma. We were there at around 10 a.m. And by 10 a.m., there was already a queue of around 30 patients waiting with only one healthcare worker. There were ANC mothers, we had outpatients, we had the CCC clients queuing, and they had a small emergency where they can be able to review patients before referral. And in each and every of these departments, they have a number of registers. They were still working manual. So she was supposed to see the patient's document, and she was the only one on that day. And not just on that day, she was the only one manning the facility. So by midday, she was so burnt out, and we just asked her one question: what will make a difference in your work? And I'm sure you know the answer. She didn't ask for commodities. She didn't ask for an increase in salary. All she said was, I wish we just had 2 more of us. We would save more lives than what is happening here right now. And that brings in focus our discussion today. Health workforce is what makes a difference in service delivery. And to frame the session, we have the privilege of having an expert in this area, Professor Frank Wafula, who is an associate professor in Strathmore University and has done a lot in the area of human resources for health, being the chair of the Kenya Human Resource Advisory Council. And he'll help us unpack the current HRH realities, the policy direction, and how to build a more resilient and sustainable health workforce. Please join me in welcoming Professor Wafula on the stage.
I admire whoever owns this because they probably have a superpower. Can use them sometimes, and sometimes they don't need them. Yeah, so good afternoon, colleagues. Wow, you look tired. This is not a very good sign. Or is it the food? The enteric nervous system is now active at work. Huh? Yeah, all right. It's always a pleasure joining colleagues, to discuss important matters on health systems. And, we talk about the health systems building blocks and, their importance in delivering the country health goals. But I always say, and I've been privileged to work across different components of health systems, from my earlier life in healthcare financing, and then supply chain management, and then service delivery and quality and regulation. And I find myself in health workforce. And I'm always telling the team that I work with that this is the trickiest building block I've ever kind of encountered. Yes. That's where do I point? Brilliant. Okay. Yeah, so allow me to start because we don't have a lot of time. And so the introductions have been done. And so I was told what I need to do is to basically set the scene for the discussions that are about to happen. And, my friends who are organizing the session ambushed me late last week, and they told me, can you throw in, can you create interest in the audience and throw in some numbers and some information, some useful narratives on what the health workforce situation looks like as a starting point for the conversations that we're surely supposed to have. So that's exactly what I'm going to do. That's a summary of the session outline. And, I'll mostly talk about some information that we have from a national health, research project that was done jointly by the Ministry of Health and WHO called the Health Labor Market Analysis about 3-4 years ago. But I'll also draw some early insights from research we are doing on the health workforce in Kenya. Some of you might have seen a link inviting you to join a survey. So far we have about 3,000 respondents, but we're still gunning for 10,000. And so that's what we're going to draw our insights on. Now, the health labor market analysis, probably one of the first countries in Africa to successfully do this. And, the Ministry of Health was at the forefront of that. It created some really interesting insights. In front of you, you can clearly see there's a huge deficit in the health workforce. But I want you to focus on two statistics. So one of them is the unemployment and underemployment, which of course points to an irony. How can you say you have a deficit and you have people who are unemployed and underemployed? That's the first thing I want you to note. And then the second thing is, when you talk about return on investment, when it comes to the health workforce, and you aggregate it, it comes to, twice. So $1 investment gives you $2 back in the health workforce. But actually that too also hides a lot of information, because as you go lower down the health systems pyramid, that number increases nearly 5-fold. If you look at the return on investment when you invest in primary healthcare, it's much, much higher. So some of these aggregate figures hide a lot of things. So again, the reason I want you to focus on that is we need to stop talking about HRH and start talking about individuals who are working within the systems, because their needs are different, the demands are different, and the systems need to treat them differently rather than going on average figures. Let me say something about this river that you can see in front of you that we call the well. One of the challenges we have in Africa, it's a challenge in Kenya, but I think it's an Africa-wide problem, is the fact that we don't focus on generating and maintaining evidence in work that's done. And so the Kenya Health Human Resource Advisory Council, being the state corporation responsible for basically reviewing global best practices, understanding what is happening locally, and then developing standards, norms, guidelines, and policies on health workforce, has partnered with Strathmore University to create basically an evidence library that hopefully continuously informs not just the ministry and the counties, but also the private sector and other actors who have an interest in human resources for health. So I talked about the insights that I want to draw in the next about 5 or 6 slides, and they are part of the well. We're going to be focusing specifically on what we can see happening with the 3rd and the 4th island. The idea behind the well is it is possible to actually not just have evidence on the different components of the health workforce, but see how they are interlinked. So that river flows to a well, and we need to make sure that that evidence is maintained. We can't be having no evidence on what is happening for human resources. Let me give you a very short example on why I think this is critical. When the board of the Kenya Health Human Resource was inaugurated a couple of years ago, I got a summon. I was summoned by the county public service boards. They have an executive committee of about 10 members, and they wanted to have an engagement so that we can hear them out. And the first thing they told us is they're struggling with medical specialists. As the county public service boards, they think they're not getting value for money from medical specialists, and the medical specialists are taking too much money. I was taken aback because, my impression was we have a problem with medical specialists and we can't service counties enough. So I took a bit of time to understand what is the problem, what is the challenge that counties are having with medical specialists. Surprisingly to me, just after a couple of months, I actually realized there are about 6 independent streams of work that have actually tried to develop a policy direction on managing and rotating medical specialists. And all of these were sitting in different places. The Senate in the last parliament had actually done a paper on management of medical specialists, a very powerful paper, which is buried, and the clerk shared it with me. Cambridge have done research on medical specialists. It's sitting somewhere in a different corner. The Medical Practitioner and Dentist Council actually have a very good document that was done by a number of professors on how medical specialists can be. So the story I'm trying to make here is we have a lot of information, but it's not in one place. So it's very hard to design policy and make anything that supports HR if you don't know that you actually have the answers. And what you're doing is you're looking for more money to do more research, but you have the answers in front of us. Now, what are the insights that are coming from the survey, which is ongoing, by the way, and I'd encourage as many health workers to participate as possible. Like I said, we have a response rate of about, we have about 3,000 responses so far, and we are still way below our target. But one of the things that's coming out quite clearly is nearly 3/4 of healthcare workers have actually confirmed that the donor transitioning has affected their departments directly. That's a huge number. And if you try to break it down into how this looks like, a lot of them talked about staff layoffs and some kind of pay cut, not just on the salary, but other benefits. And of course, issues of being reassigned without support, which I'm going to talk about in more detail. So what happens to the remaining workforce once, as the donors go out and you start moving towards transition is there are major changes in resources. And again, nearly 3/4 have reported that they feel as a healthcare worker, there are fewer resources to offer services. Again, 2/3 have talked about low morale. So that is something that has also come out very strongly. And then there are those who've reported a significant increase in the workloads as well. And these are numbers that are coming from a lot of healthcare workers. And the idea is to listen to what the experiences are looking like. And these will be discussed by the panel. So the other thing worth mentioning is under the health labor market analysis, we project a health worker shortfall of about 76,000 over the next about 9 years. So by 2035, if nothing changes, we are going to have a health workforce shortfall of 76,000 workers. But the interesting thing about that statistic is we already have an oversupply of certain cadres, and there are those cadres where even if we were to double the training, we would still not be able to achieve the targets by the year 2035. Nurses are a big problem, and primary healthcare staff are a particularly big problem as well. Now, the other thing worth noting is these are the people who, again, are highly affected by the donor transition and the integration process, either through additional work or reduced job security, and that also goes on to affect their morale. Now, if you talk about, what does integration look like in the eyes of the healthcare workers? So this is actually our worst performing indicator. And the general voice from the healthcare workers is they don't think integration of health workforce is happening well enough. They actually think we are doing very badly in how we are supporting them. And of course, the reasons are many. You're being assigned more roles, but you're not being trained or prepared. You don't have the supplies that you might have had to continue doing the work the way you were doing it before. And of course, there's also the trust issue. So the customers have certain expectations when they visit a facility for certain services. Now they're visiting with, and they're dealing with somebody who just isn't sure about how to deal with a certain situation. So there's low confidence among the community members and particularly HIV clients. I think that has come out quite strongly. And there's also an issue around uncertainty. How long are we going to, from county to sub-county, county, all the way to national level? And one of the development partners gave us a very good quote. They basically said you cannot plan your way to universal health coverage with last decade's data. Integration requires real-time workforce intelligence, county by county. What are the optimal staffing levels? But if you're to do productivity index or any other performance management, you can't do it without actually knowing whether you have the right ratios, And one of the things we are trying to do, and KHRAC is trying to do, is to figure out whether we can also do WISN in entire counties, so the public and the private sector, so that the county managers can actually know the real capacity they have in the county. One mistake we've made in the past is to separate the public and the private sector. So you hear a county complaining that they don't have, certain specialties, but they're idle people in the private sector with clinics that don't have clients. So again, it becomes a problem. Somebody in the morning talked about the issue that came out during COVID, when we didn't know how many ICU beds we have. And the truth of the matter is, unless I'm mistaken, Nairobi County did not have a single ICU bed. Nairobi County Public Service. I mean, I'm not talking about the national referral hospitals, those ones are national, but it seems a lot of the ICU beds we had were actually in the private sector, but the government didn't know about them. So even as we start moving towards the data, we need to now take a whole of market approach so that you also look at the capacities in the faith-based and in the private sector as well. Finally, task shifting, and again, a lot of staff feel task shifting is happening, but it's not being called task shifting. So roughly half of them feel they experienced something being thrown on their plate that they're not trained to handle, and it's being done in a very subtle way. And that's leading to a lot of discomfort. And yet we know that we've struggled with the issues of task shifting even before the donor transition. So it's important we first of all have very clearly defined scopes of practice, have career progression guidelines, what we used to call schemes of service that are very, very clearly articulated for different cadres. And then you can start discussing strategies on actually shifting some of these tasks. That becomes extremely important as well. So what do health workers really want? As I start summarizing, clearly, 3/4 feel they need some kind of assurance that they will have a salary in the next 3 months. It seems there's a system, particularly for donor-supported staff. We seem to be kicking the can down the road quite a lot. So, we seem to be giving them small extensions here and there. And some of the stories we are getting from focus group discussions are traumatizing. There's nothing as scary as a healthcare worker who's seeing a patient and their mind is not there. So that is one area that's it's coming out as a particularly programming. Of course, they are talking about if you must give me additional work, you need to train and prepare me for that. I know people in this room are tired of the word training, but service integration is one area where training really is necessary. You cannot delegate a task without the capacity. Of course, there are issues of supervision as well. That's equally important. And then, like you're saying, additional staff where they are needed. And so, we wondered whether to have a recommendation slide, but the whole idea is we have a group of experts who are coming to discuss these issues. So maybe not to bias them. But I think the whole idea is, again, just summarizing, this being my last slide, summarizing what we think are important factors is we need to be very explicit and have very explicit pathways when it comes to issues of, transition, integration of staff. are there roles that can be taken and integrated within existing cadres? Are there people who need to be absorbed so that we create instruments that reflect them and we have career progression guidelines for them? And are there roles that need to be taken back to pre-service training so that we actually solve the problem? Because what you're doing is you're pulling people out of the river instead of stopping them from falling into the river. That decision needs to happen now, particularly if you now need to start doing pre-service training in some of the areas that we are seeing gaps. I've talked about the workload indicator of staffing needs. It's extremely important that we do this, but also we do it across the market as opposed to public sector only. We talked about formalizing task sharing and task shifting, financing, and particularly primary healthcare, because it looks like there are roles that are invariably going to be pushed down to community health assistants and potentially community health promoters. And yet this is highly underfunded, so there needs to be a proper conversation on that. There's the issue of redesigning the training I've talked about. And then of course, the last and certainly the most important to me is let's take a pulse check on the burnout, on the welfare, on the working condition of healthcare workers as we go through these transitions, because quite often we are too focused on the system factors and the money factors and the politics. We actually forget what are the implications of the decisions we are taking on the healthcare workers. So Evelyn, I think I'm done. I hope I've set the scene because that's what I was supposed to do. And I might have quickly gone through some slides, but I'm trying to save you time as well. So I don't want to turn this into a monologue. So I'm very grateful, and thank you very much.
Thank you.
All right, sir.
Thank you so much, Prof. You've really given us insightful session that is setting the pace for our panel discussion. And you've been able to bring out all the challenges and what can be done, the solutions for making a resilient health workforce. So with that, we want to see how this will play out across the different parts of the health workforce through the policymakers you're calling on board, the training institutions, and the counties that are supporting the different health workforce in our facilities. And with that, I'd like to introduce to you our distinguished group of leaders from the public health, from our donors and training institutions. We start off with Dr. Betty Langat. Dr. Betty Langat, please come up. Dr. Betty Langat is a dental specialist and an experienced system leader who is currently serving as the County Director of Health Services at Kericho County. Karibu Daktari. Next, we have Dr. Abraham Katana. Dr. Abraham Katana is a senior public health specialist who works with CDC as the acting director, or acting deputy director, apologies for that, and has done a lot other than just being a medical doctor in certification in different areas, in different universities, the University of Oxford, among others. So karibu sana, Dr. Katana. Next, we have Dr. Kennedy Rateng. Dr. Kennedy Rateng is a family physician working with the Kenya Medical Training College as the head of the clinical services, and he's been able to support different areas in the training institutions as per his bio that is before us. Karibu Daktari. Then we have Dr. Gregory Ganda. Dr. Gregory Ganda, as he said in the morning, he doesn't talk much because he only knows about the 1%. But unfortunately, he realized 1% is not enough for him, and he went into management and is doing very well as the CCM Health for Kisumu County, where he's been supporting great public health activities and leading the service delivery in Kisumu County. Karibu Daktari. And last but not least, we have a distinguished our counties are facing workforce shortages. And these actually contradict the many services that we need as they continue to grow. From a county perspective, how is the County Department of Health addressing the financing and the sustainability of the health workforce to ensure quality service provision across the county facilities?
Yes, thank you very much, Dr. Shiono. Dr. Shiono was my classmate many years ago when we were doing undergraduate. So let me just start by laying out the reality of the matter. Is that the staff shortage and financing for human resource is a reality. And it's a reality because of a constitution we passed, and Kenyans decided that we should never spend more than 35% of government money on human resource. So how much are counties spending as we speak? Most counties spend 40% and above. My county spends 49% of its money on human resources, above the limit that's acceptable. So this is the basis of where you start from. And you know, the departments of finance usually don't argue with you. They just show you the laws if you want to increase the human resource. They tell you it's not possible, it's against the law. So how do we survive in this ecosystem? First, we are changing the way healthcare is being delivered, and I think this is national, in terms of effective use of existing workforce. And how do you use them effectively? One is what Prof alluded to, task shifting, which is a reality. By the time you have professionalized community health work, you're already starting to reduce or the number of people who are going into the facilities. Second, you empower the lower level facilities to do what would typically be done by a physician. And this is just the reality that if HIV was managed by physicians only, because that's a specialty, we would never have reached where we are. We have succeeded because of training clinical officers and nurses, and those are the lower cadres. So we could do it still at the lower level primary healthcare facilities, and that is what all of us are doing in terms of integration. But that also brings, the complication is that the number of people we have on the ground are already starting to get overwhelmed by the amount of work. So what do you again do? The existing staff, you must ensure that you retain them. You replace them whenever they get. So when people exit the service, the government has no problem with replacement. So we are very fast at making sure any retirements we replace, because that's not going to have a budgetary implication. And of course, training the existing staff workforce and ensuring you retain them. Finally, and where you are going towards, is strategic partnerships. Working with mission hospitals, working with private pharmacies, working with other facilities, private hospitals, to also deliver the care. You do not need to be given the care by the government, but the government can support the care to be given by another facility which has healthcare workers and still delivers the same. Thank you.
Thank you so much, Dr. Ganda. And being my classmate, I think I'll harass you a bit more. So you've talked about task shifting. And we know very well in the HIV landscape, we have quite a number of cadres that are not there in the primary county public service board. So what is the county government plans regarding these cadres, like the mentor mothers, the HTS counselors, and the likes, the expert clients, who are currently the backbone of ensuring that our clients continue on treatment?
Yes, that's a very good question, and that reality is already with us, that these cadres are very, very important. But we have three opportunities which we have availed. One is that the community health services bills or acts which are available in the counties allows you to onboard people in the name of community health services. So depending on how you wrote your Community Health Services Act, you're actually able to onboard those people within the Community Health Services framework. The second one is what we're calling the agency model. I've always said you don't need to employ a watchman. All you need to do is employ an agency, that deals with security services. So you have an opportunity to just hire, and by the way, that will not be taken as human resource. You just hire this agency that does all those kind of things, and then you are able to do that without increasing your human resource budget. But finally, the national government is working to include these cadres in the main acceptable cadres in the government, and that is work in progress. So I always say sometimes policies will work for the people of tomorrow, but the people of today need the services now. So you have opportunity to do this now as you wait for what is going to happen in the future. Thank you.
Okay, thank you. And one last question. Talking of the shortages, as you've clearly said, and Professor Frank has brought it clearly that we have got important tools which help in the need assessment for the health workforce. Can you tell us your experience in Kisumu County, which will be a lesson to all of us, on how you are utilizing the WISN tools, the IRIS tools, as has been mentioned by Professor Frank?
Thank you. I think WISN was a very good concept, and I prefer it to whatever we used to say about number of people per population, because it starts looking at what are you actually offering or what kind of services are available. So Kisumu, and I started this in Migori, Kisumu has applied the WISN. And when we did WISN a few years ago, remember when you do staff per population, we always close your eye to the private sector, look at the people in the government and say, this population has this number of doctors. But the doctors you are counting are the doctors in public sector, not those in private sector. You do the same for nurses, you do the same for everything. So the first time we did WISN in Kisumu, I think that was around 4 years ago, it told us that we have more nurses than we require. So that's where we started from. But then that is not the reality on the ground, because the reality on the ground is that sometimes you have a health center in the middle of nowhere, Ndingopanga, which might have 2 or 3 people coming per day, but they also deserve those services. So yes, there is a little workload over there, but they require those services, and it's only the government that can go to remote places to offer services. The private sector stays where the numbers make sense. The government goes where the numbers don't make sense. And so we are to align those ones. But within our PCNs right now, what we are doing is that we are allowing those in charge of the PCN to remove people around. And we are doing it all the way up to the ward. So we have something called a ward practice groups. And I learned this from India. India has the same problems with us. But what they have is their health center is connected to 4 or 5 dispensaries. And the human resource in all those dispensaries is managed from that health center. So you have, yes, the dispensary as one human resource, but when that person goes away, you send somebody from the center. Now what happens in Kenya is that you have 2 nurses in that dispensary. Because the workload is not so high, one comes this week, one comes next week, one comes this week, one comes next week, and then they go and leave at the same time. So so when they're on leave, they tell you, no, this place cannot be covered by only one person because I cannot work Monday to Sunday. So once you start reorganizing this in terms of the PCN, you give the staff the opportunity to move around. Just tell them, just get the work done. So that's how we have been able to do it in Kisumu. But the WISN was very important for us to relocate staff and to highlight where the problems were and to renegotiate the things I'm talking about, where the peripheral facilities are, but you need somebody there, whether the workload is there or not. Thank you.
Thank you so much, Daktari. You've brought everything in place, especially emphasizing that we need to use data, we need to use the policies, but at the same time contextualize to the needs on the ground. We move to Dr. Betty. Dr. Betty, Kericho County has been recognized for successfully transitioning partner-supported staff into the county system. Thank you so much for that. What strategies can counties adopt to absorb donor-supported staff without destabilizing county budgets?
Thank you very much. Yes, Kericho County has been able to transition most of the donor staff, especially the clinical staff, the non-clinical staff who don't have scheme of service have not yet been transitioned. So as a county, this was a process that took almost 5 years. So transitioning is not instant, it is a journey. And as Kericho County, we started with a staff establishment, reviewing our staff establishment to make sure that we have vacancies in our establishment to be able to take up the staff. And in 2020, we started by having the staff on contract. The county, yes, was employing other staff on contract, and the negotiation, because this is a political process, you have to advocate and convince the Department of Finance, you have to talk to the County Public Service Board, you have to talk to the MCAs, because they are the ones who are passing the budget. So first, we started by having our staff on contract for 5 years. And during the time of the contract, you have to note that the staff salaries, because our staff were supported by the donor, had been with us since 2004. And their salaries were slightly higher than our entry salaries from the county. So we had a discussion with the partner that on a sliding basis, we were able to have our staff get a salary from the government. And of course, we are not calling it a top-up, but they were able to get services for the service that they offered. Our staff, number one, were deployed not only to the CCC. Our staff were in most of our departments where we had HIV patients. So we had our staff in MCH for PMTCT, in the medical ward, in the pediatric ward, in the TB clinic, in our maternities, and also in the CCC. And it was blended with our staff who are employed by the government, both permanent and pensionable staff, and the staff who are on contract. So that the first process was we got a budget for the staff to be on contract, supported by the partner. After 5 years, again, we went back and we requested and negotiated to have the staff transitioned into permanent and pensionable. So all our staff, clinical staff in Kericho County who are in the payroll of our donor are now in the county payroll, permanent and pensionable. And as we talk about the staff being permanent and pensionable, we also went through the process of the Public Service Board, where the staff had to go through an interview. Of course, it's a suitability interview to make sure that we are employing the right person at the right entry. Thank you very much.
Thank you. That is quite exemplary and a lesson to many of us here. There are issues, Dr. Ganda brought them up, where sometimes the healthcare workers don't follow the norms and they're not on duty all the time. And in facilities where the the donor-supported healthcare workers are present, the rest of the county employed staff feel like it's a burden to take them to the CCCs, the many registers, and all that. So they're not comfortable working there. How have you been able to go through these challenges and ensure that services by the directly employed county staff remain of quality, documentation and reporting still continues with the quality that is needed?
Thank you very much. For Kericho County, our process started as integrated process. From the beginning of the program, well, not the beginning. At the beginning, we had a siloed program where we had all the staff employed by the donor or the partner working in the CCC. And in 2005, we had a challenge. And the challenge was the other staff felt that having an HIV patient in the ward or in the other departments or the other unit service delivery points, they felt that there were people who were employed to manage HIV patients. And that was a lesson to us. So we started in 2005 to integrate our healthcare workers into the various units. So from 2005, they were able to work together. So in all the areas where we had the patients, the CCC, the MCH, the medical wards, the pediatric wards, they were working hand in hand. The staff who are government staff, the staff employed by the donor, the staff employed by the county on contract were working in the same area and doing the same things. So it was easy for them to continue even writing the reports. So as we moved forward, we were able to have all our staff trained. When there was capacity building, the staff were taken for capacity building equally, given the same opportunities, whether they are staff employed by the partner or staff employed by the government. Number two, supervision was done by the government structures. So all our staff who are within the health sector were supervised using the existing structures. Number three is the issues of mentorship. We had a robust mentorship, and we still have, where now all the staff working in whichever area, whether it's a health center, a dispensary, are mentored together with the rest of the team. The other issue that we also had is that the partner staff were managed, whether there was staff rotation. So in a hospital, we normally have staff rotations, and that affected even the partner staff. All what we needed to make sure that we do is during the staff rotation, the staff employed by the partner was deployed to the area where we had the HIV patient. So a staff could move from MCH into maybe a female ward where we have medical patients, or to the maternity. And they were under the supervisor. When we looked at the issues of appraisals, their leaves, their management in general, it was done by the government officers using the government structures. So we did not have a big issue in terms of report writing because our staff, all of them, were capacity built. Thank you.
Thank you so much. Starting with the end at the beginning. Dr. Katana, yesterday from some of the remarks from our national leadership, those mentioned that we have around 14,000 staff who are being supported by the donor. And we know there are discussions that are all going to transition the donor-supported staff into the HRH, the national system. So how are these cadres, as you're supporting them, how are you ensuring that they're remunerated in line with the GOK schemes of service, even as these discussions are ongoing? And what strategies are you using that will support sustainable transition of this HRH without disrupting service delivery?
Thank you very much. That's a very good question. And so as you asked the question, I was reflecting about how we got there, where we have 13,000 plus health workers who are employed outside the government public service, board. And just reflecting on this, it took me back to 2002 when I worked as a young medical officer at Machakos District Hospital. And I started testing HIV for TB patients because we know the co-infection rates were very high. We did not have ART, so that time we were providing more of counseling and support for other OIs. And at that time, we had to, once you identify and you talk to the patient, then we had to inform the lab or collect a sample, take to the lab and have it tested. And now 2003 came and we had this big opportunity for rapid scale-up of treatment when WHO initiated the 3x5 initiative. And at that time, we really needed to get up to speed with identifying people living with HIV and making sure that we put them on treatment based on the guidance that we had. And I was among the early cohort that was trained as HTS providers with a nurse at the hospital. But we also had, other other work that took 98% of the time. And so as the need emerged and we had the opportunity with the resources, then the cadre for HTS counselors, came into being. As we were starting the program at the time in 0304, there were issues that were emerging that much as we had the medical knowledge on HIV treatment, there are things that best benefited from people with lived experience, and especially when it came to adherence. We used to talk about 95% adherence required, casually, but the real sense of that, taking pills every day, and that time there were quite a number, was not an easy one. And that's how we had to get the peer support system, the adherence counselors to really support and, support that. As we continued, we also realized the PMTST program that actually began earlier, could also benefit from peer, support through the mentor mother. So these HR numbers are not just numbered, but, really informed by need, in the program. So looking at where we are right now, with a program that has 1.3 million people on treatment, over 97% of them virally suppressed, is really largely in part, from this support that has gone towards, capacity building, but also the additional numbers that, as was mentioned by Prof, really helped reduce the gap in terms of, the need. So as we look forward, we are really aligning with what is expected over responsible transition. So one of the things that began, a few years ago was really working directly with the counties are the ones with the primary mandate for frontline health workers. So we have direct funding to at least 13 counties where they have employed, the staff through the county public service boards. And even in the other counties, we have the implementing partners who give sub-grants to the counties to employ. And so I think for the clinical staff, as was mentioned by Betty, there we are streamlined. Where we still have a bit of work to do is the non-clinical cadres, the ones that do not have an established scheme of service, because then as we discuss, moving forward, a decision needs to be made. We did have extensive discussions as we were developing the health cooperation framework around this. And I think the general principle that was agreed for these for the clinical cadres, it was straightforward, the lab and others. But for these ones, the agreement was a 3-step process. So one, really just mapping out to see who are they, where are they, and what they are doing, alongside or against what we have in the CHPs, because a few of them are also CHPs among the 107,000 that have been engaged by the government. Number two, look at the capacity needs that are there, for the CHPs and what needs to be done to really make sure that they are up and they are supported to be able to provide broader than what they are just providing. And then the third level will be looking at, after we've optimized the CHPs, what gaps remain. And one thing that we were in agreement was that there are things you cannot train. For example, for the lived experiences, you really can't train a CHP to be a mentor mother. But you can give a skill set that can support mothers living with HIV. And where there's need for that complement, then really looking at the best way to support. I'm happy to report that as we've had these discussions and you heard from the video that was played by for Dr. Oluga speaking, we managed to reach an agreement that, the 13,000 health workers would be responsibly transitioned. We worked out on a date. So the US government will continue paying these workers through June 30th of 2028. And then the government will take them from July 1st, 2028. Of course, between now and then, there are a lot of work that is going to be done around, validation, rationalization, capacity building, to make sure that it's not just a match to one of one-to-one, but it's really driven by need and capacity. But in the health cooperation framework, there is, good commitment from both governments to ensure this. In the meantime, we've worked with our implementing partners to make sure that they continue building capacity of these health workers and also the health workers who are not in the non-HIV space, so that, as we go towards integration, then that is, really supported. And at this point, I actually wanted to say, sometimes we talk about implementing partners, without clarity on the capacity they bring and what we likely are going to miss if we don't do it responsibly. And we have, I think our chair here, is there. I saw Dr. Emily Koech, who was actually my first boss at NASCOP. Yeah, and she as an implementing partner. So in terms of mentorship capacity that they bring on board is something that is worth appreciating. So that really continues, but I just wanted to give that assurance in terms of, that the government has a plan. President Ruto says, tuko na mpango. Tumepanga, tumetenga, and I think things are going to be well, by the end of this. Thank you.
Thank you. Thank you, Dr. Katana, for assuring us that at least with the donor investments, there is assurance of sustainable way forward into the national systems. So as we address the workforce sustainability, we must also ensure that we are training the workforce needed for the future. Dr. Rateng, training institutions are playing a key role in shaping the workforce future. How can training institutions adapt to ensure that health workforce are well equipped for the integrated service delivery, the task shifting our fellow panelists have talked about, digital health systems, you're moving digital, and then the healthcare demands that are evolving day by day?
Thank you. That's a very good question. I want to say that I come from Kenya Medical Training College, the largest training institution, training middle-level health workers in Africa. We train about 80 to 85% of health workers in this country. And I think it is very right that I'm here to speak when we are talking about human resource for health and integrating of health care services. This is a very good space for us to be in. I would say that we have done a lot. As a country, I know we have been talking about competency-based curriculum for the last 10 years. Yes, when Kenya shifted into that form of education. But as Kenya Medical Training College, we did this earlier, about 20 plus years ago. We had a consultant who came from a university in Scotland, that is Dundee University, who looked at our various curricula and the programs that we were training. And he told us one thing, that most of our education, as it was more based, more focused on the teacher than the student, was more knowledge-based than real skills or competencies. So we had to change. So we have strengthened our various curricula in training health workers to be competency-based education. And we have done this very well. We have, by introducing things like simulated laboratories in teaching skills and making sure that our health workers, as they come out from our colleges, they have competencies generic competencies that can make them work in any health system. And that is why you hear most of our trained health workers, the nurses, are even migrating to developed world, and they are able to cope. So we have also integrated a lot of training to prepare for integrated health care delivery. We have realized that as primary health care workers, the ones we train, there are common competencies that a nurse must know, must have, the clinical officer, for example, the pharmacist. So we have identified some of these common competencies and we train them together. And this has really worked well, in preparing them to work together. And I mean, when they're out in the field, that is interprofessional education. We have done that very well and it has worked. There was a time we had a problem, this is many years, those who are there. When introduced community health nurse, and at the same time, we were training clinic officers. At that point, a community health nurse was prepared to be a practitioner nurse that could do nursing services, could also have diagnose and perhaps manage our health centers. When they met out there with the clinic officers, there was a problem. The nurse said that we are the ones to head the health center. The clinic officer said, yes, health centers have been ours. Where were you? We didn't see you. Yeah. So now that went on, and we realized the problem was that we teach these people very separately and release them out there to work together. So by bringing integration in training, this has made such problems. This was a bit earlier, but we still used to see some of such problems when it comes to integrating health services. Then we have also brought a lot of digital health systems in our training. We're proud as one of the institutions that has the largest e-learning platform. I know many people wonder, I have not said, but I know we all know, we are well spread. We have about 90 campuses, well spread all over in the country. We have managed to do this because of our e-learning platform to maintain that teaching is standardized. They are taught by people who are trained wherever they are through that platform. But other than that, we also in the training, we bring in new concepts in digital health system, things like telemedicine. We let them know that, including even complex concepts like robotic surgery. Even at that level, they should know that such exists. So they are able to appreciate such changes within the health ecosystem. We also we have also enhanced a lifelong education as one of the areas to help us make sure our graduates, even as they are out there, they are still able to keep on improving on their skills by coming up with the short trainings, short courses in modular forms that a nurse out there can learn a skill in any area. We have several, we have over 120 short courses on health. We also have we have partners, and we collaborate a lot with various private and even public sectors. We have we have signed MOUs with county government, and this is so key to us because as a training institution, we don't own clinical placement sites. So through this, we have strengthened our training to make sure that we are training the right people that can survive in this changing health ecosystem. KMTC we are changing from what we are known for as a training center to more or less a learning hub. And this is through partnership. Like currently, we are coming up with, through a partner, we have a center of excellence in forgetting the area, but I remember it. But in the other area is on POCAS. We have partnered with Hatch International. This is a private partner that is helping us to come with a training hub in POCAS. And we intend to do that in various parts of the country. So I would say that as KMTC, we are really fitting in this space, and more so as a primary a physician, a family physician, this is talking well to me. I'm one who believes that services at the primary level should be integrated. We should not fragment care at that level because it becomes costly to our patients. It becomes very difficult to assess. And that is why, as also from a training institution that trains the large number of primary health care providers, we are really emphasizing that as our graduates get out of the college, they are able to manage most of the common problems within the primary health care space. I think I would stop there for now.
Thank you so much, Dr. Rateng. For sure, strong training systems, both for the pre-service and in-service, as you've mentioned at the KMTC, is what is needed to be able to have competent, adaptable workforce to deliver these integrated services. And you know very well, as workforce roles expand, training is needed even beyond the pre-service. So the sustained capacity building of healthcare workers in an innovative manner is very top priority. Professor Nduati, universities are a key player in ensuring that capacity building of healthcare workers is prioritized. In your view, what strategies are the most efficient for sustaining continued learning, keeping healthcare workers updated on like the new guidelines that were released yesterday, and this is taken up both during the pre-service and in-service, and noting one of the gaps that Professor Frank mentioned, demotivation of healthcare workers is one area that affects service delivery and is not prioritized. So how can that also be part and parcel of what is prioritized for our healthcare workers?
Thank you very much for those questions, and thank you to the colleagues who have presented here. I've also learned from their presentation. Now, digital learning is, digitization is a reality even at the university. It's a reality for all of us. And if you recall, when COVID came, we were able to sustain our medical programs. At the University of Nairobi, we were, within a very short time, able to sustain our programs. For the undergraduates, part of the effort was to address the mental health issues of the students. So the students were, wherever they were, being able to attend 1 or 2 classes per week was an important part of that. And we continued with the digital learning even when they came back. In the current situation, we run some of our classes, and I think this is true of all the medical schools. We run some of the classes online, but the students are increasingly demanding for face-to-face learning. They have felt a sense of disengagement, and they feel that they're really not learning. They're not learning as much. There's more of these psychological problems among students. I think there are probably increasing reports of even catastrophic things like suicide among students. So for us, digital learning is important. The efficiency is about it, but I don't think it can be the only way to do the learning. Now, when you come, we are also engaged in competency-based learning. Actually, for more than 15 years, curriculums are competence-based. The training of health professionals is pretty standardized. There's the core curriculum that the medical boards subscribe, and then each medical school may add a little bit of this, a little bit of that. But our graduates come out, they are benchmarked against global standards, and we're quite proud of our graduates. Now, the challenge in this age of digitization is integrity of examinations. And we've had all sorts of fantastic stories and experiences with our students. And the faculty, at least the faculty of the University of Nairobi, in the School of Medicine, we are very determined that our students are not going to get ahead of us. So, so I know you see some of the stuff in the newspapers, but we are back to doing exams the way you did them. We come to an exam room, receive an exam, we write it on a piece of paper, and we supervise to make sure that we are not marking ChatGPT, we are not dealing with Gemini, and particularly like Gemini is interesting. You can give it instructions. You can give it instructions to write your essay, and then give it additional instructions to make the mistakes that an average third year or fifth year student, right? Yes. Our students, because of the economic times, increasingly, the students we are training to be health professionals are from middle-income Kenya. They come from well-resourced households. And sometimes they're quite capable of fundraising and trying to corrupt the ICT departments so that they can get the exams. And they don't raise small amounts of money. It's a lot of money. So as I say, that this is an additional challenge for us as teachers. How do we make sure that there's integrity in the learning, there's integrity in the evaluation? Because exams are important. They determine whether you have achieved the competencies that are required before you go to the workplace. But we're working on it, and I think we're getting pretty good at it. Yes. Now, the guidelines, I want to say that the medical faculty from the schools of medicine, whether it's Moi, my colleagues are here, or University of Nairobi, we are embedded into the guideline policy for formation. And the guidelines we form, it directly informs what we are teaching. So our students are coming out well guided. And we are also engaged in a lot of research. Some of it is a large clinical trials that we get funded from US government. But also with our postgraduate programs, the MEd programs, we're able to do smaller studies that again inform provision of care. CareNet is very generous. It gives some grants to postgraduate students. We're able to look at, for example, one of the on the issue of integration. One of the studies that was really interesting is that having a pediatric team in labor ward reduces newborn mortality. And this was part of a dissertation done 1 year. There was no pediatric team there. You have to call them. And the next one, we had team there. And it was reduced neonatal mortality, reduced birth asphyxia. And so even the child who's admitted into a newborn unit is less ill than when there was no pediatric team. So there's studies like that really that directly inform care, but also teach the health worker, so the postgraduate student or the undergraduate student, that you need to investigate the problems at the workplace and improve on care provision. So that is reasonably well built into our programs. I think going forward, there's a need for deliberately building skills on ethical use of digital tools. And I think that's going to be work in progress. Even for us, it's a challenge going back to the university to work on this. For the hospitals, whether they are county hospitals or whether they are the national referral hospitals, making your hospital a learning environment, which is friendly to nurses, is friendly to student doctors, to postgraduate students, will support you in integration, and it will increase the quality of work. This is a lesson we learned. We went on a mission to find out how to improve teaching, and this was a mission. That's one of the lessons we came back. It's also a very important way, or very useful way, of maintaining the motivation of your consultants and being able to keep them in the workplace. When say the physician has some medical students or some visiting, some residents who are coming to do a program, the ward round is different, the clinic is different, the intellectual challenge is different. So it forces people to go back and study. There's a joy in coming to work. There's a sense in which that I'm putting in time on somebody who can replace me downstream. So really, and we've worked with more, in our University of Nairobi, we've worked with more than 18 county hospitals. We also have been able to reach out to other medical schools, so Kenyatta University, JKUAT, and Maseno. And we've had programs either with undergraduates, we have had programs with postgraduates, we've had programs of short courses to improve, improving continuing medical education for the staff, and which has made a difference in what's happening on the ground. So that's, I think, a very ready kind of opportunity that hopefully doesn't require too much funding, and we can do it. We have enough of us to do that. The other is the other strategy for this improving quality is involving your frontline staff in continuous quality improvement of the program. There's a system called SIRE, Systems, Analysis, Improvement, and Action. And there are many studies done in Kenya using SIRE and have demonstrated that it helps to sustain quality of services. The difference of SIRE from other CQIs is that you do a care cascade. So if you're treating patients with hypertension, when they came in, was their blood pressure measured? Did they see a physician to get a prescription? Did we what? And you track that, and then when you have your results, have a team meeting and do a process flow of how is your patient walking through the health services. Very useful, particularly in PMTCT. And then you are able to see where you need to tweak your systems to optimize care. In that process of doing that, SIRE, you have to look at the guidelines. What are we supposed to do? You know, in that discussion of problem solving, you improve the knowledge of the facility, the health workers in the facility. You increase the sense of ownership. We want to succeed, and hence the services actually get provided. The third thing we have also evaluated, and actually we have published work on it, is looking at your county as one unit, and building mentorship teams, mobilizing these consultants and senior nurses to work as mentors, sending them down to mentor their own institution, then the downstream to health centers and to the dispensaries. We did that here in the Coast region for several years. I think the people who work in the Coast may still remember. And and we were using HIV money. And so when you have a lab person who is the lab in charge for the district or the county, and they're part of a mentorship team, when they go to mentor, they don't just talk HIV. They check everything. They make sure the whole system is working. It builds a relationship so that the person who's in the farthest facility and is having trouble with something, they're able to call, and they're calling somebody who they know, who's like a friend, and they're able to work as a team. And in fact, at the time the transition was being made to the devolution of health, the facilities here in the Coast were able to sustain very high standards of PMTCT through that whole process, because they had developed that devolved mentorship practices. Now, the other, and not take too long, there are things we do in hospitals to improve the quality of care and are part of this integration. For example, it's very important to have grand rounds. Grand rounds brings everybody, so it's an opportunity for learning. It's important to do mortality reviews. I know maternal mortality review is a requirement, and I think now neonatal mortality as well. But even anybody else, even if an adult in an adult ward dies, it's important to review, because that's where you learn where things are a problem. This is where everybody also learns how to do things. And then of course, for the for the pre-service training, also as part of the pre-service training, we have very specific training training on the guidelines. For example, vaccinology, ETAT, HIV. The obstetricians do the Pronto course. And learning how to work as a team before they come to the workplace. But having said that, I think the medical schools, and having listened to all of you here, I think as the medical schools, we need to go and relook at our curriculums and see how we are better able to prepare our graduates for the workplace, especially the undergraduates, because the undergraduates are coming in as intern. The assumption is that the health facility has a capacity to take them from being graduates of medicine or graduates of nursing or whatever, to the point where this is a professional who is being registered and is able to function relatively solo, because we don't retain them after internship. They now are your medical officers. You might find them doing a locum here, a locum there, or you have hired them. So I think there is the change in the healthcare system. I think also challenges that there must be some innovations to have a person who's fit for purpose. Let me stop there for the time being. Thank you.
Thank you so much, Prof, for the very rich insights. I think learning continues, and this is an opportunity for us. We've been able to learn a lot. You can hear me? Thank you. So the financing, the training, and even being able to task shift and maintain just quality as we deliver services. So if this would like to shift to the audience so that we have a brief session of plenary where we can have some contributions to the discussions and questions to our great panelists here.
So we'll have the first round of questions, the hands. So
thank you very much. I have two questions. Dr. You say you are able to generate the income to substitute it for your county without, from inward. Now, what I'm saying, you are able to generate money from your county. Oh, it was, yeah, so that you can continue. Now, how much support did you get from the governor? And how long do you think that would continue if the governor is thrown out and a new office comes in? So where's the security of that whole issue? Which means that you need to get the MCAs and the others to onboard this in their constitution of the county. Ruth, Dr. Ruth, for those of you who don't know, Ruth is my big sister. How much of that, whatever you're doing, which is fantastic at the university, where does the funding come from? And again, what is its sustainability issue to go ahead to teach and continue with the teaching of the young people, despite the fact that they are using AI to continue with it, because that is a safeguard as to the quality that goes in. Because when I look at it, we've had several patients who go to India, and they come with their medical reports and everything else. And when the Indian doctors look at it, they put it aside and do their own. And the two are completely not in line. So again, the standard, that is what I'm trying to ask, because as we go along, the standard needs to be in place.
Okay, thank you for those questions. We'll have a maximum of 4. I'm guided because of time. So the second.
Thank you. My name is Susan Meta, representing the community, and I think mine is just an input in regards to the cadre of councillors. For someone who works in the community, I would think it's very important for us to upgrade the workforce, because despite the councillors just assisting the clients, what about the healthcare workers? They also need debriefing. Like, for example, I am stationed at Chulaimbo Hospital back in Kisumu West. Our TX car is 5,300. The first 3 weeks of the month, we get to see between 100 to 180 patients in a day. So that tells you even those health providers, at times they need debriefing. Ama tutafika a point, they will also unleash the stress on the clients. Also, as someone who is the advanced HIV disease champion, when it comes to mental health and psychosocial support, my work relates to the community to track, to trace patients who are treatment interrupters, and maybe those who have not been screened, and linking them back to care. Now, such patients, you find there was an issue with a patient that is related to mental health. So I believe the councillors play a very important role. As Africans, we don't go for therapy. We are people who've grown up with unhealed trauma. So some of these things become as a trigger. So I would really request, when you're considering such things, that understand councillors help us to play a very important role to make sure the treatment interrupter aligns and, takes their medication very well. Thank you.
Thank you so much. My name is Jotham Kiogora, still from the community, but on basically people with disability. From Kericho, you have talked of turning now permanent workforce into contracts. And I tend to think about the workers who are trained to deal with people with disability. And actually what happens is so expensive to train one, because they will have to undergo an extra mile. And when you turned everything into contracts, and at this particular time, this season, we found that also some of the healthy workers and a lot of demand from outside countries, or rather overseas jobs and all that. Were you affected actually to lose some of the very important workforce in your facilities? Thank you.
So the last hand, Dr.
Hi, my name is Richard Muko, working with AVAC as a regional advocacy person. My question is about the HRH gap, and it's basically directed to the formators, to the schools, the KMTCs. If we look at Tanzania, for example, the HRH gap is 52%. In Kenya, it's 64%, maybe going to 75%. That is just an approximation. So now we are going to the integration, and of course, maybe ultimately the country basically assumes the full burden of its HRH, whatever. So are we really prepared to reduce the HRH gap in the country and of course, what are the KMTCs doing to ensure that in the long run, at least we are able to reduce this? What is the ministry doing to provide solution to that area? In Tanzania, for example, they have a voluntary, something, that engages pre-permit workforce on this. But of course, in Kenya, I don't know exactly what we have in store. Thank you.
So thank you so much for the questions. We will get some responses from the panelists and we'll try to be brief. We start off with Dr. Betty, then we'll have Prof briefly respond, and then we'll have Professor Wafula, given your expertise as the chair of the Resource Advisory Committee, to respond to the question of the human resource gap. Then the rest, if you have something to fill in, you can be able to add. Over to you, Dr. Betty.
Thank you very much, and thank you for the questions. I think I want to make it clear. I think the two questions are almost related. One, yes, the governor, we had a goodwill from the governor and the MCAs in terms of getting a budget for our staff to be employed. And our staff are now employed on a permanent basis, permanent and pensionable. So initially they were on contract. And then they were on a contract with the donor. Then we moved them to contract with the county government. And then we now moved them to be permanent and pensionable. So even if the governor changes or the MCAs change, the staff would remain in the payroll, the county payroll. So again, for persons with disability, anybody who has been trained in terms of managing persons with disability will be deployed to the area where they fit most. So for now, we are assured that they are within the county payroll. Thank you.
The question was from my friend James regarding the standard and the quality of training and whether there's evenness from one medical school to the other. For many years, we only had one medical school. Then we had two. Now we have very many. And so some of the discussion that among the health professionals is that we need to move to a standardized exam as part of standardizing medical education. But for a school to be licensed to be training health professions, their syllabus must meet the minimum standards. And we get inspected regularly, not just by Q, but also by the medical boards. So in this way, there's an effort to standardize the quality of education that is there. I think when you give the example of India versus Kenya, there was a study done by the Danish and government. And I think Kenyans were, everyone, including the babies, were at least one day at 300 shillings for the Indian government. If you look at the amount of money that was going from Kenya to Denmark, to India, money from Kenya to India. But people are going there for services that they can actually receive here in Kenya. We have very many, very well-trained, highly skilled health workers in this country. But I think there's a feeling of the grass is greener on the other side all the time. There was a question about the health worker and the patient with advanced HIV and the issues of burnout. I think what you're talking about is important. We have some work that is going on, and we have counselors working with the mothers of HIV-infected children, many of them in advanced disease. And the counselors also are very traumatized in that process of providing CBT therapy. So the space of mental health is important. And beyond that, the gentleman who's asking about disability, there's this data that this troubling data that children of HIV infected women who are not infected, you know those we say HUU, they are not meeting their milestones at the same pace as a child who is not HIV infected. And as a result, there's a very large study that is going on neurocognitive development of children. Some of the work is going on in Nairobi, and I think some of the work is going on in Western Kenya. It's called the MIND study. I think this will be an important study for us as Kenyans. The KDHS of 2022, table 15 of that report reports on on the development of children, young babies up to 3 years. Are they meeting their milestones? And 1 in every 2 children of a mother who has not had any, who's not literate, is not meeting their milestones. And overall, about 10%, almost 10% of babies that age in Kenya are not meeting their milestones. That's a huge number of children who are potentially having neurocognitive deficits. The layman word is children with mental retardation. So it's a real problem. This issue of disability of different types is a real thing, and we need to keep it in our mind. Now, there was something I wanted to say about, yes, the HRH. I work in research, and I'm also a teacher. And when we do research studies, we budget for the human resource based on the work that is going to be done. So if you're building 5 chairs and you want to build them in a period of time, how many workers do you require? And I think the health sector needs to go that way, because now what we're doing is we say cap it at 35%. Actually, the work is more, so we task shift. And I think of all sectors in Kenya, the health sector has the largest number of people who are working and not getting paid. People are working as volunteers, or you're getting a little money for transport, and it is called a job. And they're doing it because they care for their fellow Kenyans. But the truth is that this is work that is being done, work that should be paid for, and that method of saying 35% cap, calculating health work as 35%, capping it as 35%, is fundamentally flawed, because the work, health work, is not a 40-hour week job. A hospital runs 24 hours, 7 days a week, 365 days a year. And every one of those hours must be covered. In the training where we are training residents, the working week of a person doing MED training, like some of the people who've been here, is 80 hours a week. And this is a standard across in the Americas, in Canada, in Europe. This is a standard 80-hour week. So we need to push for things. I believe that I don't believe things are cast in iron and stone. We actually can generate the evidence, and we can lobby for a change in the way we look at the workforce, and we pay wages, because this health worker who volunteers, this mentor mother who comes and volunteers, or even the health worker who volunteers to go work in the lab so that they gain some skills, but they're doing work. They have to pay rent, they have put food on table, they have to feed their children just like everybody else, right?
Oh, thank you. So I can feel a drop in energy in the room. That's normal. Adult concentration never goes above. Lots of professors here would tell you that 40 minutes is pushing it. So you guys have been sitting for too long. So I'll try to make it as painless as possible, just so that you can recover. Of course, there are ways of approaching the whole wage issue, and I know there are discussions around, are there certain aspects of HRH that could be classified as development rather than recurrent? I mean, if you're training and upskilling people in certain ways, is it actually a recurrent cost, or can you reclassify it to play around with the ceilings? So as far as the gaps are concerned, I mean, there's a whole, so we have a need of about 311,000 healthcare workers against, I think, about 234,000, give or take. So I know we have a gap of about 70,000, 76,000 perhaps. But what I said, and I really like the question, is there's a lot of things that are hidden in those numbers. We actually have oversupply of certain cadres. We don't like admitting it, but we do. And we have major undersupply in other cadres. That's why it becomes very important to stop using these blanket statements and pick out the cadres that have a problem. Now, once we know what our future needs look like, and I think right now we are talking about 2035, I think we need to project up to 2065, if you are to ask me. That then goes back to how the government is investing in production. And here's what KHRAC and the Ministry of Health direction is generally geared towards. University placements, the amount of money that's going there should actually go to areas of high priority, high need. So if you want to go and do a course that is needed for the future, then the government pays for you. If you want to do something that is perhaps less needed at this point, then you co-pay a bit more. So you pay a larger fraction. So the investment goes where the need is. Because as I said, based on the HLMA, even with the most conservative estimates, in 2035, there are cadres which we will not even have achieved 25% of the required. So you can't leave it to the market anymore. This is where government comes in and they say, we are only going to pay for people who are doing these specialties. We are not stopping you from doing them, but we are not investing actively in that area. So once the placement happens, this transitions to internship. There's a lot of discussion around internship. We've played around with the figures, and it's very difficult to find the right balance because the Ministry of Education is different, the Ministry of Health is different. Training happens under the Ministry of Education, people graduate, they come, they go to the Ministry of Health, they demand internship, which is a right. But the problem is the planning did not know that a certain university in 2028 would be increasing its intake of medical students. So how do you plan for internship for 2028 under our planning cycle when you don't even know how many people are going to be interns in that year? So should we also start tying internship to positions that are competitive and plan for within health so that people compete for those? Because you have to pay interns. We can't go to a direction where you're saying you are too many, now we cannot pay you. The balance has to be, if we need 2,000 and universities have decided to trade 10,000, then they'll apply for the 2,000 slots and then we focus our investment in that area. So there are policy things that can be done so that you don't stop people from training. I don't believe you need to tell universities to stop training people. I think they're independent. I think as long as they're offering quality and they're doing it in the right way, let them do it because training is a global good. You can train and they can go elsewhere. So I don't believe in the policy decision of capping numbers unless quality is an issue. But I believe in a solution of tailoring the investment based on the amount of money you have in the health sector so that you invest in the right places. Thank you very much.
Thank you so much. Thank you so much. I think we'll wrap up the questions at that point, and we'll have a quick fire round, and I'll just ask three of our panelists, Dr. Katana, Dr. Rateng, and Dr. Ganda. If you could implement one reform tomorrow, what would significantly strengthen the health workforce? What would that be? 20 seconds or less. What will that reform be? Listening to all of us here.
Okay, for me, it would be, a reform to standardize the assessment, so doing WISN in all counties to determine the numbers needed and the places they are needed. Thank you.
Thank you so much. Dr. Rateng?
To me, I think it will be training a health worker that is very resilient, ready to work with the right attitude in this strained financial ecosystem.
Thank you so much. Dr. Ganda.
I think Dr. Frank already said what I would have said. We must think about the human resource in health, not as a recurrent expenditure, but as a development expenditure. Thank you.
Thank you so much. That just proves he's no longer 1% doctor, Cindy. So let us appreciate our amazing panelists. We've been able to learn quite a lot from them. And as our photographer comes up, I just want to wrap the session by appreciating our panelists. They have been able to give us a lot of insights. From Dr. Betty, we've been able to learn how to transition, and that transitioning while maintaining quality services is possible. From Dr. Katana, yes, we have this 13,000, but they're just not numbers. There was a need that informed that, and the government is ensuring that these are transitioned in a phased approach. Thank you for that. Dr. Rateng, it's not just about the knowledge, competency and skills is key to ensure that as the health workforce gets out there, they're able to deliver quality services. Dr. Ganda, you've told us about the financing, about ensuring that the health workforce is managed properly as per the policies, including being able to take up the health workforce that is not in the that are in the non-public service board cadres. You've had the models, like you don't have always to say you are advertising for a cadre that is not there. Hire a firm that will be able to bring in these skills. Thank you so much. Prof, it's not just in the classroom. Mentorship is powerful. Ensuring quality is ongoing. Thank you for that. And Prof. Wafula, you've wrapped it up so well, from the task shifting to the tools, to what the government needs to do, and to the future for the HRH. So with that, let's give them a clap as I welcome you here to take a photo. And I would like to call upon Gladwell, who's been working behind the scenes, to please join us as we take the photo. Thank you so much. And please hold on, the chair will take up to close the day for us after we step down from the podium.
So thank you. That was a very wonderful panel. I'm always very passionate about HRH being a county implementer or coordinator for the HIV program. So I think we've learned a lot, and we really want to appreciate them again by giving them an abstaining. Tunajua ku abstain. Hebu tengeneza. Pasha. Dr. Mutuku na kuona. Pasha. Abstain. Itabidi turudie. We have to repeat that. You can't just be, I mean, even if you're adults, let's do again. Let's try to abstain. I know it's difficult, but this is what we do. So, tengeneza, abstain. It will never work. So, 2 quick announcements before I call upon Dr. Ramisi to guide us on the poster walkthrough. So 2 quick announcements. There is that corner there. There is a handbag that somebody has misplaced. Please, if it's yours, pick it there. And also a laptop charger. And again here, there is a pair of glasses. I think one of the presenters must have forgotten. So please, if it's yours, come for them. So at this juncture, I want to welcome Dr. Ramisi to guide us on the poster walkthrough. Then immediately after that, we will have the Mentimeter session displayed here. Thank you.
Good afternoon. Okay, we are tired. Good afternoon. Good evening. All right, so my name is Violet Oramisi. I work as a regional strategic information advisor with ICAP, CQUIN. For those who want to know a little bit more about CQUIN, we are a 21 country network where our focus is just basically to support knowledge exchange, sharing best practices among countries. So we are 21 countries in the network, and this is part of what we do. And we are excited to be supporting Kenya in this integration summit because we also have another session where we have planned to have more countries just coming together to share on integration, because this is the way all the countries that we support are now focused in terms of how they want to respond to these issues that we are all currently facing. So I'll just take a very short time to walk us through what we are going to do in terms of the posters. First of all, we're not going to abstain. Here we are going to clap. So he said abstain, me I'm saying enda yako yote. So let's put our hands together. We got 68 posters. A big round of applause. So this was really commendable work that was done by our colleagues from the counties. People really spent a lot of time reviewing those posters and were able to accept 68 posters. So they're in 6 thematic areas. The first thematic area, we got 30 posters. So they are all here and we need to go and see them. The second one, we had 12 posters. The third, we had 7 posters. The fourth, we had 7 posters. The fifth, we had 8. And then the last one, which is thematic area 6, we had 4 posters. So with these posters, what I want to encourage us is that we are all going to have a poster walkthrough. This time round, just visit the poster session. You know where the booth is. Do we all know where the booth is? On that side. So we have beautiful ladies who will be able to direct you and tell you poster this way. And that's where we are going to do it. Yesterday, we had Gen Zs being told that you need, lazima uchukue kura. Kura yako ndo itakusaidia. So why are we going to look at these posters? We also want to appreciate the work that has been done, and we'd like to encourage you to go look at the posters because we are going to vote. But because there are many, we will not vote today. So we'll give you a chance to walk through the posters, look at all of them. You can do thematic area by thematic area. You can do 2 today, 2 tomorrow morning, 2 at tea break, and then you can have another 2 at lunchtime, thematic areas. And then in the evening tomorrow, we are going to vote. So when you go to the booth area, you'll find the posters clearly labeled that is the thematic area. So the first picture is showing us how they are labeled. Then they have numbers. Please take cognizance of the number. Our numbers have been done in an integrated way. We have integrated the sellotape together with the marker, so you're able to actually see. So please mark the number and ensure you remember. So that number will help you tomorrow when you're voting. People have worked so hard, we need to vote, and then we'll be able to give an award to the best poster by thematic area. So tomorrow when we'll be voting, this is what we'll be asking ourselves: how relevant to the theme that poster was in that particular thematic area, and how innovative, or what was the originality? When you look at it, was it really innovative? Does it have a lot of originality in it? So as you review the poster, please remember that is the criteria that we are going to use to vote. We have tried to summarize because we've said we have been having like 40 tools, but we are now narrowing down simplification so that we're able to integrate better. 8 thematic areas, so just 2 questions per thematic area to help you be able to vote. So tomorrow we will vote. There will be no double voting. So you know yourself, you know your email address, you will use your email address to vote. So we'll vote using Mentimeter. And to just help us again continue using Mentimeter, we are now going to look at just how we are going to do this tomorrow, but we want to evaluate this session now using Mentimeter But tomorrow you'll be able to appreciate how the results come in, because you'll be able to see the highs, the downs as the results trickle in. So I'll request the media team to please put for us the Mentimeter up so that people can be able to vote or just give us feedback, first of all, on how the session was this afternoon. So the code is coming up for today's session. And once we are done giving feedback, I will call upon Daktari to come and close the session today. Yeah, so let's see. Mentimeter up for the sessions. Not that one, the other one. So this is the opportunity, the golden opportunity to remove your phone. I know you have all been very good, hamjakuwa mkiangalia simu. Sasa toeni simu. Okay, that means let's remove our phones. You can, this is the time you want to know, do you have an iPhone, do you have a Samsung, Tecno? Yako ikikataa, tutajua tu. The summit can buy you a phone, kishindwa. Let's all remove our phones. Ringa na simu yako, ni yako. Let's take a picture of the QR code. All right, I'm seeing we are doing well. Unaweza karibia tu, kama macho imekataa. Or maybe we can make it bigger for those who are not able to see. Yeah, some people are struggling. Let's make the QR code bigger. So far, 94 have joined. You all look so amazing from here. So please keep joining. Excellent. Good progress. All right. Yes, so the QR code is now bigger. Don't be ashamed, just toa your simu. Iko sawa. All right, a few more yet to scan the code. You can just take it as a picture, it will scan. All right, so thank you very much. At this point, please let's put our hands together for Dr. Carol Mwangi, who will close the session for us. Makofi. Hey, you guys, hata kama mnasikia njaa, si mpige makofi. Okay, Dr. Carol, you can stand there. They are going to clap for you better. A big round of applause for Dr. Carol Mwangi. Asanteni sana.
Okay, good evening. Thank you. Can we all stand up? And that's the quickest way to get energized. My task is brief, to thank you all for today's session's active participation that you're here until this time. We've had a very engaging day, and thank you for the support. We were graciously, the Director General for Health also graced us with his presence and gave us some very, very thought-provoking comments. So tomorrow is the community day. All the sessions from morning, whether the plenary talks, the panel discussions, the breakout sessions, will be community focused. So I'd like to request us to be here early so that we can start at 8:30. So as I close, I'd like Casco Joyce from Trans Nzoia to approach. She will pray for us as we leave. On behalf of our leadership, I'd like to wish you all a good evening and see you tomorrow. Thank you.
Shall we pray? Heavenly Father, we come before your throne of grace this evening with thanksgiving in our hearts, for indeed you have been good to us. Thank you, Lord, for the day that has been. Thank you, Lord, for your presence that has been with us. We thank you, Lord Almighty, for today's facilitators. We thank you for the presenters. We thank you for the moderators. We thank you for the panelists and all the participants. Father, we thank you for this time as we depart, we pray for your presence to be with us. We pray that you watch over us. May you watch over our families. We commit to tomorrow's activities and your able hands as we pray for your presence to be with us. For it's in Jesus' name I pray and believe. Amen.
Dr. Mogesi, please see me. Dr. Mogesi Mokaya. Tafadhali unione.